Um, Welcome everyone to Health and Human Services, and this is the start of a long day. One thing I do want to make an announcement. After the break this afternoon, we'll be meeting in State Room 100, which is the Judiciary Room, just because it's a little bigger and a little more comfortable. So with that, I am going to open the hearing on Senate Bill 409. And the prime sponsor, Senator Prentice.
Thank you, and good morning, Chair Birdsall and members of Senate Health and Human Services Committee. Before we get started, I just want to share with you that today in the city of Laconia is Henry Littman Day. He's here with us this morning. We're always glad to have Henry, and they are too in the city of Laconia. He has retired after serving as a long-time city councilor, and for that, I know we're all thankful for the work that our local electeds do. All right. For the record, my name is Sue Prentice. I'm from West Lebanon, and I am the state senator for District 5, covering 15 communities, a large part of Grafton, some Sullivan County communities, and one in Merrimack, the lovely town of New London. Today, I'm here to introduce Senate Bill 409. This bill directs the Department of Health and Human Services to submit an amendment to the state Medicaid plan regarding reimbursement for ambulance services when they respond, treat a patient on the scene, and are not needed to transport. Over the years, the demand for pre-hospital emergency medical care has grown, as have the capabilities of providers. What has not grown, unfortunately, to meet this demand is the number of ambulances and personnel that are readily available. We know that hospitals are low on available beds and also experiencing some of the same workforce shortages that the emergency medical services community is. Our EMS system has increasingly been responding to the needs or to grant staters in need of care that's not life-threatening or appropriate for transport to the hospital. These calls require personnel, they require fuel, they require equipment, and in some cases, there's even medical supplies that are utilized. Presently, EMS cannot bill Medicare. That's a federal issue. They ran a pilot program or started one called ET3. They dropped the program after COVID, so they're going back to talk about that because even at the federal level with Medicare, they recognize that there is a need for this type of reimbursement to be put in place. And I also understand and have been talking to some of our commercial carriers, they do provide some payment for these treat and non-transports, as well as does TRICARE. And there are some states already that do this, including Georgia, Minnesota, and I believe Arizona. There may be one other one that I'm missing. But the way the system is currently set up is that the way you get reimbursed if you're an emergency medical provider is if you actually provide transportation. But there, again, as we know, there are times when we go, we take care of somebody, they don't want to go, they don't need to go. There's also maybe another place they can go, like to their primary care provider, or unfortunately, they succumb to a cardiac arrest and resuscitation is terminated. There are still costs to those communities and those providers. And so what that does is it falls right to the communities. And we have an opportunity here to not only fill that gap, but to assist on the hospital side as well and keep those beds free and actually reduce those costs. So what I'm proposing here, which you'll see in 409, is that we ask for an amendment to the state Medicaid plan in order for New Hampshire EMS providers to be reimbursed in these certain circumstances outlined in 409, which I've already mentioned, but just to roll through for clarity and for the record, when the response is originated through a 911 call, the patient consents to evaluation and treatment. After the evaluation and when indicated, treatment by the licensed paramedic or emergency medical technician and the patient agree that there is not need for transportation by the ambulance, this shall include when resuscitation efforts are terminated. The patient does not request and actively refuses transport to an emergency department for evaluation. The patient is stable for referral to the patient's physician or other community resource or is deceased, and the patient has the ability, including the mental capacity and transportation resources to obtain assistance and medically indicated follow-up. So in these instances, and I've already somewhat spoken to this, it's reasonable to assume, and actually not assume, but we know that a hospital bed may stay open for another patient that needs it. We also know that the cost of the system, including the Medicaid reimbursement for the transportation and the emergency department bill, are going to be more than what we could provide for, in these certain circumstances, reimbursement for non-transport. So providing this reimbursement through Medicaid will bring some needed relief to our EMS providers, the services that they work for, the municipalities, but most important, will keep patients who do not need to be in a hospital and don't, and in some cases, do not want to be in a hospital, out of the hospital. So again, I'm aware that Minnesota, Georgia, South Carolina, and Arizona have been able to work it so that they can bring some Medicaid dollars to this problem as a solution. And I wanted to just add on here that according to New Hampshire's Department of Safety, their Trauma and Emergency Medical Services Information System, in 2022, overall, there were over 216,000 calls for help through the 911 system. A little over 59,000 of those were non-transports where some type of treatment was required. Not all of those patients have Medicaid. Some of them, 15 to 17%, are covered by commercial carriers. A large percent is covered by Medicare, but there is this Medicaid piece, and it is within our control as a state to do something about this. So I will conclude my testimony. Certainly, I'm very interested in Autopass. I do have some more technical experts with me from the field that I'm sure are here to provide some more resources for in support of this legislation. So I thank you for your time. And I'll take questions, and if I can't answer them, I may have to defer.
Okay, thank you, Senator. Senator Whitley.
Thank you, Madam Chair. Thanks for taking my question. You mentioned that there are a handful of other states that have done this. Have they seen those sort of savings that you're referring to from hospital costs? Did I get that right?
Thank you for the question, and I don't have an answer because it's still relatively new, but we'll continue to monitor that because that, again, is a real potential here.
Any other questions from the committee? Seeing none, thank you.
Thank you.
Henry. For Henry Littman Day.
On Henry Littman Day.
You're going to retire from Laconia, but you're not retiring from the department.
I know.
Correct.
Thank you.
Thank you. For the record, Henry Littman, State's Medicaid Director. I'm in support of this bill, and I won't repeat what Senator Prentice did. I think did an excellent job introducing it. We do, as Senator Prentice highlighted, there's been some sort of mix in terms of how CMS is viewing this, but I can say, particularly from my municipal experience, that municipalities have to either, if they have their fire department providing EMS or they're paying to have a contractor do it, that they're incurring a cost to provide these services with no remuneration. I have a experience when I was on the provider side through the city of Laconia managing an ambulance where a woman was, pregnant woman was actually bumped by a vehicle, knocked down, and the 911 Laconia Fire Department responded and basically checked her out, no compensation for that time and effort. So I do think in thinking about this, it has a benefit also on the municipal expenditures and tax rates potentially. But I am upfront here. I think that the criteria in the bill are very important in terms of what conditions need to be met. And I think that's an important part of this legislation. And the department appreciates all that the legislature has done in the last two sessions to strengthen the EMS system that really needs it. And so I think this is an important piece of policy to pursue if the funding can be found and if we can get CMS to approve a state plan. And I'll take any questions.
Any questions from the committee? I actually do, and forgive me if Senator Prentice has already covered this. based on the fiscal note, it says $1 million plus general funds and $1 million federal funds. Is that, don't, we need approval from CMS in order to get that
Correct.
federal, okay. Does HHS have the $1 million in your budget for this?
No, we would need an appropriation. And that's why I was saying earlier that we appreciate all you've done, and if you can find that, I think this is a worthwhile policy to pursue.
Okay. Any other questions from the committee? Senator Bradley?
Thank you. So what is it gonna take for CMS to approve this?
I
And
think,
how long?
yeah, I think it's something that could take like 6 months to work through with them. It could be shorter. Certainly, if there's an indication that the committee is interested to pursue this, we can engage with them pretty quickly. And the matter, CMS has got a lot going on still with the unwind of the federal public health emergency and unwind of continuous coverage. So sometimes it's hard to get time with them, but we will make a good effort. This is an important issue, I think, for us to spend some time on.
Thank you, Senator Birdsell. So, Henry, would it be appropriate, thinking about the potential time frame, whether we can execute this request and get approval, say sooner rather than later being 6 months? Would it be helpful to amend the bill to say contingent or, contingent on the approval from CMS to put that mechanism in place?
Yes.
So that we can still pass this? And if we get the approval, then we can put this into play. And if we don't, then we have to come back and revisit it. Would that be a strategy?
I think that's a good strategy, Senator.
Okay. Thank you.
Any other questions? That actually, thank you, that comment helped my next question, which would be, if we didn't get the approval from the feds, would the state be responsible for the full two plus million?
I think the answer to that would be yes if we implemented the policy, and I think that
By postponing or putting the clarification in there would hold it off until we get a confirmation from CMS.
yes.
Okay, thank you. Any other questions from the committee? See none? Thank you, Henry.
Thank you. Thank you also for the recognition earlier.
Thank you. Good morning, everybody. My name is Michael Setar, and I appear before you on behalf of the New Hampshire Association of Fire Chiefs. I also serve as the fire chief for Tilton and Northfield. And the New Hampshire Association of Fire Chiefs provides leadership, education, and advocacy for the New Hampshire Fire Service. On behalf of the association's members, I would like to express our support for SB 409 relative to reimbursement for ambulance services under the state Medicaid plan. In many New Hampshire communities, like those which I serve, ambulance services are provided by the local fire department. One of the most significant challenges associated with providing municipal ambulance services is ensuring revenues from delivering the services meet the costs. Many communities are struggling with costs related to ambulance service delivery. Our association has been very involved in this issue, and we support a holistic approach to addressing this problem. One piece of that approach is to ensure the payment is received for the provision of service to a Medicaid patient when no transport is required. SB 409 will begin to process to help ensure that this part of the issue is addressed. When appropriate, treating a patient on site in terms of cost and time is far more effective than transporting a patient to the hospital. My service transports to Concord Hospital on a regular basis. Due to overcrowding, my ambulances often have to wait for an open bed in the emergency department. Sometimes that wait can be up to 30 minutes. Those 30 minutes are additional minutes that my ambulance is not available for emergencies within my community. And this places an additional stress on my mutual aid partners, which must also now cover my community as well as their community. The provisions contained in SB 409 would help relieve those stresses in the emergency departments and emergency ambulance services by ensuring that providers are paid for the services that do not require transport. Our association recently surveyed our members regarding results from a recent Medicare ambulance cost survey. The data we received demonstrated that the vast majority of communities that provide ambulance service do not recover their costs for providing those services. This means that any additional costs are borne by the local property taxpayers. The parameters of SB 409 ensure that patients will continue to receive the treatment they need, but will ensure that providers of the treatment will be compensated for the services of those for the service provision. Currently, treat no transport for individuals covered by Medicaid leads to additional costs, which are then shifted to the municipalities. The New Hampshire Association of Fire Chiefs respectfully request that you vote to pass SB 409. Thank you. Happy to answer any questions.
Thank you, Chief. Any questions from the committee? Seeing none.
Thank you very much.
Chris Stewart. Welcome.
Thank you. Good to be back. For the record, my name is Chris Stewart, and thank you for the opportunity to testify today in support of Senate Bill 409. I am a lifelong New Hampshire resident and live in the town of Hollis, New Hampshire with my wife and family. I've been a nationally registered paramedic for the last 40 years and have spent my entire career in the New Hampshire emergency medical services industry. I am currently employed by American Medical Response, and I'm on the board of directors for the New Hampshire Ambulance Association. SB 409 directs the New Hampshire Department of Health and Human Services to submit an amendment to the state Medicaid plan regarding reimbursement for ground emergency medical services. The current New Hampshire Medicaid reimbursement model incentivizes emergency ambulance transport to a hospital. Since treatment in place, I call it TIP as an acronym, is not currently covered by New Hampshire Medicaid. In short, New Hampshire Medicaid can currently only reimburse ground ambulance providers if they transport a Medicaid patient to the hospital. TIP services, we believe, should be recognized as healthcare services and covered accordingly. The goal of healthcare should be to provide patients with the right care at the right time in the most cost-effective manner possible. The historical payment model for EMS contradicts this goal by only reimbursing EMS if we use an ambulance, which is the most expensive type of response and transport, to take patients to the emergency department, which is the most expensive type of healthcare available. Reimbursement for TIP as a permanent payment policy would support better patient care and save both hospital and EMS resources, both of which are in short supply. In 2023, our medics in New Hampshire responded to approximately 31,600 911 calls between Nashua and Manchester. 24% of those calls, so approximately 7,500, resulted in some type of medical care being provided at the scene, but did not result in a transport to a hospital. Approximately 20% of that population, approximately 1,500, were patients with New Hampshire Medicaid. We received no reimbursement for the services we provided to that Medicaid population since TIP is currently not a covered service. TIP is a safe, protocol-driven, and has physician-level medical control consultation available like every other EMS response. Recognizing the value of TIP and potentially reducing costly ER visits, TIP is already a covered service in nearly a dozen state Medicaid plans in the U.S. and numerous commercial health plans. TIP reimbursement is also currently covered by Anthem Blue Cross in New Hampshire in many of their in-network agreements. Just some quick examples of a treatment in place scenario: out-of-hospital cardiac arrest, as Senator Prentice mentioned, treating known diabetic patients in their home, treating known asthmatic patients in their home, treating chronic seizure patients, and also treating opioid overdose patients with Narcan. We believe TIP can be an effective way of providing high quality in-home or on-site treatment and helps avoid unnecessary ER visits. It can help keep medically vulnerable patients out of the hospital environment, which is especially important in our ongoing respiratory infectious disease environment. It also allows for faster turnaround time for ambulances, thereby creating more EMS resource availability. And while this legislation focuses on TIP, there are also other innovative and medically proven models of alternative transport options for patients being delivered with reimbursement throughout the country. Those include transporting patients to alternative destinations, such as primary care doctors' offices, urgent care clinics, 911 nurse navigation programs, and other right place, right care opportunities. My hope is that we can explore opportunities for reimbursement for those types of services in the future as well. Thank you for your attention, and I'm happy to answer any questions.
Senator Avon.
Thank you for your testimony. Just a question about helicopter transportation. Would that be covered under this as well?
I don't believe so. I think this applies only to ground EMS transport.
Right, okay, just.
Yeah. And I,
It
quite
is
frankly, would,
ambulatory at some point, right? I mean, if you have to be transported, or a helicopter has to come and get you. Medevac, thank you.
I focus this on the ground ambulance population. There are times when, oh, sorry, you're correct. So Senator Avard, there are times when helicopters do respond to, this would more likely be interfacility, not seen. Well, it could be seen, and the patient then becomes so unstable or is in cardiac arrest, and those are times when they don't transport. So I didn't, that was not the plan. I can consult the air medical community, certainly.
if I may, I think the current wording in the bill says it has to be as a result of a 911 call. So I don't know if helicopter would fall under that or not, because typically they're not activated on a 911 call. It's after arrival at the scene. But
I'm happy to take a look at that. Yeah. Good question.
thank you.
Actually, it does say, when the following requirements are met, the response originated through a 911 call, the patient consents to evaluation and treatment. After the evaluation and when indicated treatment, the licensed paramedic or EMT and patient agree there is not a need for transportation. So it does look like sounds like it's more ground transportation.
It's really, yeah.
But if you could look into it,
I'd
that'd
be happy
great.
to. We have one air medical program in the state through Dartmouth Health that has 2 vehicles, so I'll speak with Matthew or Courtney.
Any other questions from the committee? Seeing none? Thank you, Chris.
Thank you.
Is there anyone here that has not had an opportunity to speak on Senate Bill 409 but would like the opportunity? We currently have one individual here who's in support but not willing to speak. So with that, I will close the hearing on Senate Bill 409. Pam, a little bit of time to get ready.
You know, they have these height safe cards and when you call 911 and
I'm back. Good morning. For the record, my name is Sue Prentice. I'm the state senator from District 5, again, covering 15 wonderful communities, a large part of Grafton, part of Sullivan, and one community in Merrimack County, the beautiful town of New London. I am here today to introduce Senate Bill 455. This bill directs the Department of Health and Human Services to establish a reimbursement rate for prosthetic and orthotic devices under Medicaid that is equal to the rate under Medicare and makes an appropriation to the department for this purpose. This bill also directs the this bill also directs legislative oversight committee on health and human services to study this issue. In medicine, prosthetics they're an artificial device that replaces a missing body part that has been, limb loss has been, impacts a person through trauma, through a congenital defect, or through cancer. And orthotics are a special type of device that is put in a shoe or in a heel that, these are both prescribed so that a person who has, difficulty, say they have, one leg that's shorter than the other and it's causing them other medical issues, this would put them both on even par by creating that device. These are specially made, and I estimate, looking around, I did some searching because I'm only familiar with 2 groups that do this work, that there are 10 providers that do prosthetic and orthotic work here in the state of New Hampshire. And I have to say that I have a little more testimony, but I'm really happy that it's Henry Littman Day, because he's going to need to help me out on this. So this problem came to me because in November, and you all know that I've done work with children around limb loss and supporting, prosthetic devices in particular. In November of 2020, providers of prosthetics and orthotics in the state of New Hampshire found out that this contract with Medicaid managed care groups, New Hampshire Healthy Families, AmeriHealth, and WellSense, was allowing them, that contract, allowing Medicaid to reduce the reimbursements in part, and it eliminated Medicare co-insurances. So this amounts to what I can see as a 20% reduction. And due to these changes, orthotics and prosthetic providers are in a position now where they have to write off the co-insurances that Medicaid will no longer cover. However, Medicare is very explicit in regards to collecting co-insurances, and legally, providers are not allowed to arbitrarily write off 20% of co-insurances for any patients. So providers understand the majority of the patients will be unable to pay these co-insurances. However, we will have to, and so it'll end up in a result for a bill to the patient, or they will not be able to get these services. And that's both of those things in terms of consumer protections are most concerning for me. These are services that they are entitled to under Medicare, and they've been deemed essential medically and for their well-being. So I'm going to stop there. There are some folks that are here who are better versed at this problem, including Henry Littman, but what I've come to understand is that this change in the way that we do Medicaid managed care is impacting the ability of these providers to provide services, which ultimately becomes a cost to either a patient or their inability to have access to that care. And that's, finding ways to manage limb loss for healthy, active lifestyles has been important to me. I've worked on it for children, and so now I'm willing to, or I'm honored to be taking this up for adults as well. And so I will end my testimony with that and ask for your support, and welcome the others who are here, including Henry, to talk about the details of this. And I did just get the fiscal note last night. Henry was kind enough to call me while I was getting my hair done. So I was like, you're going to have to talk to me while they wash my hair. But he did, and he was very good about it. So,
Any questions from the committee? Seeing none. Thank you.
thank you.
Henry, just a minute. For those of you, if you're waiting to testify on 455, please don't block the door. Come on over to this side. If you're not, and it's standing room, then and you're waiting to speak on the future bills, please wait outside. Okay, Henry. Come on down. It's Henry Littman and Senator Prentice morning.
Good morning. For the record, Henry Littman, the state's Medicaid director. Thank you. So Senator Prentice alluded to the managed care program. Maybe just kind of give this context. So a lot of durable medical equipment nationally has become sort of commoditized, and so there's some good sides to that, some bad sides to that. In 2019, when we reprocured our managed care contract, we saw and heard from providers that, you know, prices were really being pushed down, you know, and so based on the available funding, we try to implement a strategy to make it better. This would make it even better, and that strategy was to require MCOs not to pay less than 80% of the Medicaid fee schedule. To get it to that was a $3 million investment at the time in 2019. This would close the gap to the Medicaid fee schedule. Under Medicaid, in this particular area, we're not allowed to pay more than Medicare, or we have to pay back that money, if you will, in terms of federal match. We're not allowed to go over 100%. So I think, again, this is a bill that I think is worthy. I think we do not have the funding. If there is available funding in this session, I think it would help. I think the concern that we all have is that when these necessary services are needed in the rural areas in particular, that it's expensive to go out, you know, and provide these services. So I think it would help secure access in the long term. And again, I think, you know, potentially talking with Senator Prentice about this, that, you know, what you did with ambulances, you did a couple step process to get to there. So that could be an option as well for example, rather than going to 100%, you could maybe take a step to 90% if there's funding available. And I understand state revenues are what they are, and there's a change in course there. But if there is available funding, this is something I think would be also worth pursuing. Take any questions.
Thank you, Henry. Any questions from the committee? Senator Bradley.
Good morning again, Henry. So when we increased the Medicaid provider rate last year, $134 million, was there anything that would have gone to durable medical equipment or not?
Yes, for the services that people provide as opposed to the commodity
Okay.
or the
So the answer
device.
is no.
It's only for the component that if there's I'm not sure what you would call a prosthetist, if they were
To the person
prosthetist-
administering a
prosthetist-
prosthetic, but not
yeah.
the device itself.
Yes,
Okay.
and that's where I think they need some more help.
Any more questions from Henry? All right. Thank you, Henry.
Thank you.
Samantha Terrace. Welcome.
Hello, my name is Samantha Torres. For the record, I am the practice manager of Seacoast Prosthetics. We're a locally and amputee-owned prosthetic and orthotic company in Portsmouth, New Hampshire. We provide artificial limbs and bracing to many patients throughout the Seacoast area, but also surrounding communities as far as Manchester, Epping, Rochester, all of that, and into Maine and Massachusetts. We have a variety of patients that we see from infants all the way up to elderly. I want to clarify a little bit of our payment structure. So The way we're allowed to bill is what's called a bundled payment system. So that includes the device cost as well as your office visits. And for a little background, typically our orthotic patients are seen for a minimum of 2 office visits, sometimes 3. That's an initial evaluation, a fitting appointment, and then follow-ups. Our prosthetic patients can be seen upwards to 8 to 10 times during the process of getting one leg. And as you know, a prosthetic is a lifelong commitment for someone, and they're in our office quite a bit. It's important to note also that we have about 800 New Hampshire Medicaid patients at our office. The New Hampshire Medicaid fee schedule is currently well below Medicare. They're often reimbursing, since Medicare has increased their fees, we're looking at 30 to 40% below at the New Hampshire fee schedule rate. As it was kind of alluded to, the managed cares are allowed to pay 20% below that. So now we're looking at a 50 to 60% loss seeing Medicaid patients. Let's see. We also provide services to main care patients. And as a background, they are reimbursing at Medicare rates. So to give an example, one of our knee braces that we provide costs us about $568, and that's the device itself. Medicare reimburses at $958, and as I said, that includes the device and visits. The current New Hampshire Medicaid rate is $524. So that means the managed care are reimbursing at $419. So when we see a patient who has Medicaid, the minute they step through the door, we're taking a loss. I fear that if this continues, there's going to be a discrimination in care that's provided, because we're going to have to make some really tough decisions on whether or not we can afford to see Medicaid patients. And oftentimes they're the most vulnerable in our state. So I hope that you appreciate the care that we provide to the community. We're very valuable in getting people up off their feet. Our motto at our office is "Life is moving," and I wholeheartedly agree with that. So with that, if you have any questions, my boss and co-owner Chris Phillips is also here. So if you want to wait for questions, we can tag team them. So, but you can ask me too.
I just have one question. Can you go through those numbers again? The cost of
Sure. Yep. So I gave an example of a knee brace. I do have other examples as well. Senator Prentice knows I've a wealth of information. But one of the knee braces we provide, it cost us from our wholesaler $568 for the device itself. Medicare reimburses at $958. The Medicaid reimbursement for it is $524. So right there, we're not covering the cost of the device. And the whole idea with the bundled payment is it's supposed to cover the device and the visits.
So the 958, what was that from?
Medicare.
Oh, okay.
Yep.
Sorry.
And like I said, our orthotic patients are seen minimum 2 times. Usually it's an initial evaluation, they get measured, things like that. And they're about an hour-long appointments where our practitioners are in there the entire time. So it's very different from a doctor's office setting as well, where you have nurses coming in and out, and maybe your doctor sees you for 10 minutes. This is very hands-on, patient care-centered, what we do. So
the 958 through Medicare, that does cover the cost of the knee brace and any visits that they need for fitting.
Yep.
And you're saying Medicaid, New Hampshire Medicaid only covers
$524. Yep.
And the managed care covers $419.
Correct, because that's 20% below the state fee.
Okay. Any questions from the committee? Senator Bradley.
So what would commercial insurance pay for the same knee brace?
It varies. It depends on our contracts. Right now, the Medicare Advantage contracts are paying the Medicare rates. Usually, maybe about 10 to 15% below is some of our commercial products below that rate. So, but I would say the New Hampshire Medicaid is our lowest payer.
What is, for instance, in Maine, what is their Medicaid reimbursement?
They're reimbursing Medicare fees.
Okay. Interesting. Okay. Any other questions from the committee? Thank you.
Thank you very much.
Chris Phil? Welcome.
Thanks for having me. I'm Chris Phillips. I'm the co-owner of Seacoast Prosthetics, and Sam covered pretty much everything, so I don't really have too much to say. She did a great job. But I do want to emphasize that we are a small business, so we have 6 employees and a couple contracted employees as well. So not only are we, always struggling to, provide for our patients and employees, but we're always struggling with insurance contracting and things like that, just trying to cover, the cost of seeing patients. So as a little bit of a background, I'm also an amputee from birth. So I grew up in the care, of folks like myself. I was lucky enough that my parents, my father worked for the government, and we had Federal Blue Cross, and so we never really had to worry too much about getting a new leg every couple of years. And of course, back in the old days, things were a little bit better off insurance-wise. But just to reemphasize, the payments that insurance pay includes the time that I spend with the patient, as well as all of the office time that our staff is taking to do the prior auths for insurance. These things, a lot of these devices are fabricated either in our office, hands-on, or like Samantha said, we purchase some items and then those are customized to fit the patients. So we're talking about, 45 minutes of time evaluating the patient in the office, explaining what the device does. It's definitely not like a durable medical equipment device where you're going to pick up, compression stockings at a store. These devices are either custom made from a cast or a digital scan, or ordered and custom fit to the patient at a second appointment. And then for 90 days after that fitting appointment, they can have a follow-up as needed. So any tweaking, any adjustments we make, they're back, and that's part of that initial payment. So if we're billing one L code, like Samantha was talking about, for that knee brace, Medicare's paying $900 or something dollars. So 400 of that would be covering my cost as a practitioner. So those 2 office visits at $100 each or whatever. But when you go below that, I'm basically, unfortunately, working for free. And so I'm going totally off script here, but as a practitioner, I want to do the best for my patients. I want to fit them with the best device that's appropriate for them. But I have to look at that as a business owner, and do I pay my employees, and do I, this constant struggle of substituting something different or something of a lesser quality for those patients, because I know that we're not going to get reimbursed properly for that. So that's a dynamic struggle, that happens in real time. Now I'll go back on script quickly. So, Senator Prentice talked about children, and so we do a lot of work with the Monarch School in Rochester. So these kids are significantly disabled. Many of them require complex bracing for just daily function, walking, standing, getting from class to class, things like that. So we actually have a great program where we'll go to the Monarch School. So I'll drive from Portsmouth to Rochester. We'll do sort of a small clinic where we'll see several kids, evaluate. The doctors have ordered bracing, so we'll cast them there. We'll fabricate the braces or have the braces fabricated, and then I'll drive back to Rochester and spend a morning fitting these things, and then I'll go back for follow-up as well. So for the past 5 or 6 years, we've been considering whether we can afford to take our time to travel and see these children there instead of making them come out of school, making their families travel to see us. But in the past 2 to 3 years, because of just rising costs and lower reimbursements, now the discussion has changed to, can we even see Medicaid patients at all? So will this population be serviced? And I know throughout the industry, like you said, we're tiny. There's only about 7 or 8 groups of us in the state, and they're being bought out by larger companies. So there's only 3 or 4 small businesses that are privately owned. And so every year when we are meeting together, we talk about, are we going to be able to continue to see these patients? We've already dropped WellSense as one of the managed cares because of other issues. New Hampshire Healthy Family was better payer and easier to work with, but now all that's gone to basically 40% below Medicare levels. So it's just becoming extremely difficult to keep this population treated. So there are movements across the U.S. right now. There's a lot of state involvement. Like Samantha said, Maine Care is paying Medicare rates, and so there's a lot of things. New York and Arizona just passed bills bringing Medicaid levels up to Medicare standards. And so that's certainly something that we support wholeheartedly to keep these guys going. Any questions for me?
Thank you. Thank you for your testimony. Any questions from the committee? Seeing none. Thank you.
Okay, thank you so much.
I'm sorry.
No, not a question, just to let everyone know that I sent the Excel spreadsheets with that Samantha talked about with the different products and the
Okay.
different products and services and the rates, and as well as I have the main documentation that you provided, so we can compare. So Cam has those for the committee. Thank you.
Thank you.
Is there anyone here that would like to speak on Senate Bill 455 that hasn't been given the opportunity? With that, I will close the hearing and let Cam set up. And Huh? Where's he? Yeah, I think Boston got the worst of it. Come in. Okay. I will let everyone know. Okay. So I am going to open the hearing on Senate Bill 403. I will say that we have 21 speakers on this bill, so I am going to limit everyone except for the prime sponsor to 3 minutes so we can get through that. Welcome.
Thank you, Madam Chair. Good morning, members of the committee. For the record, I'm State Senator Cindy Rosenwald from District 13 in Nashua. I'm thrilled to be here today to introduce Senate Bill 403. This bill makes pipeline investments in our healthcare workforce. This is a bill about building up the future healthcare workforce, not really about retaining the workforce we have, which, as we all know, is still just not adequate to meet our needs as an aging state. This bill is basically the second half of last year's Senate Bill 86, from which only the Medicaid rate increases moved forward in the budget. The pipeline investments in Senate Bill 403 are still necessary to help create our future health professionals. So despite putting hundreds of millions of dollars into our healthcare workforce, specifically $305 million of Medicaid rate increases over the biennium, and more than $150 million in incentive payments from federal funds, it's still very difficult to get a doctor's appointment, which I can personally attest to, or get a hospital or a nursing home bed, get home care, mental health care, or substance use disorder treatment. The lack of an adequate workforce has not only led to increased costs in the system as providers have had to pay enormous temporary staffing costs. But there are also worrying implications that the quality of our fantastic healthcare system in New Hampshire is at risk. For example, the Kaiser Foundation reported just this week that the number of hours nationally that of care that nursing home residents received declined by 9% between 2015 and 2023, with actual nursing hours down a staggering 21%. So in addition to keeping the workforce we have to take action to make sure professionals can work at the top of their scope. And we also have to interest students in health careers for the future. Senate Bill 403 does these things. I'm not going to go into a lot of technical detail because the 21 other people are, but I do want to cover broadly what's in the bill. First, the bill extends the sunset date on the Commission on the Interdisciplinary Workforce Issues by 5 years, with a particular focus on our state loan repayment program and public health. Second, it defines case management so as to help make the scope of services for any individual more efficient. Next, the bill amends the requirements for LNAs to be able to administer medication. Sections 6 and 7, which start on page 3, creates a process for OPLC to certify community health workers. These people are not clinical staff. They are folks with the experience, culture, language of the community in which they work. They're facilitators, and their importance to the broader healthcare workforce is that they free up the time of licensed clinical staff so those professionals can work at the top of their scope. Nurses don't have to be doing paperwork, setting people up with health screenings that they can get at a community health department or a health center. The community health workers can do it. And certifying them will allow them to be reimbursed by insurance carriers. That goes on for a few pages. Next on page 7, section 8, takes several actions to build up entry-level clinical staff, particularly in rural and underserved areas, offer learning opportunities for students, support a medical residency program in Coos County, support preceptor or mentorship programs in community health centers, help build LNA programs, and recruit all levels and specialties of clinical staff to New Hampshire. DHHS is also tasked here with improving peer supports to the drug and alcohol recovery system. This is a comprehensive bill, but I believe it's necessary if we're to have the healthcare system Granite Staters deserve. The bill does have appropriations to support all this work, but I hope that will be for a day down the road in finance if the bill gets a positive recommendation out of this committee and a positive vote on the floor. Happy to answer questions. Thank you.
Any questions from the committee? Senator Bradley?
All right. Thank you.
Patricia Tilley, DHHS.
Good morning. Again, my name is Trish Tilley. I'm the Director of Public Health Services at New Hampshire Department of Health and Human Services. Thank you for putting me first in the queue today. I need to get over to GNC right when I'm done here. So when I run out, don't take it as that I'm running away. So good morning. Thank you for the opportunity to provide feedback to SB 403. We provided a very long and very detailed set of written testimony, and we will spare you that level of detail right now. The sponsors of this ambitious bill completely understand that the health and wellness of New Hampshire communities and the foundation of our economy depends upon a foundation of excellent healthcare professionals, from community health workers, which Senator Rosenwald so beautifully described, straight up to our specialty physicians. I'm going to go through a summary of the breadth of the work that the department is sent to the department as proposed by Senate Bill 403. We are supportive of many of these concepts, but it's important to know that components of the bill may conflict with some current state plans, and there are other components that may need further exploration before implementation, especially given the ambitious timelines. We know that you as a committee are also going to hear from everybody in this room, and you're going to need to prioritize what you think is most important. Some of the proposed programs that are in the direction of the department are ready to go with sufficient resources. Some are promising, but probably need a little bit more time and resources than what are contemplated. And some of the proposed ideas have some technical problems that would make implementation unadvisable. And almost all of the proposed activities come with a hefty price tag. Again, that will be the problem of finance. Maybe not you all, but I'm sure it'll weigh on your mind when you do your prioritization and your consideration. So our team is completely committed to working collaboratively with the sponsors, with all of the people in this room and the advocates to find the best way forward for the more than 10 different programs that Senate Bill 403 assigns to DHHS. So let's jump in. Commission on Interdisciplinary Primary Workforce. Yes, absolutely, please extend. Case management. This is where we get into a little bit of tricky language. The department is concerned that the changes suggested by Senate Bill 403 may have some significant unintended consequences. The definitions of service coordination and case management must be clearly articulated and in alignment with our home and community-based waiver program and the Medicaid state plan. Importantly, the department has received increased federal Medicaid assistance percentage FMAP for $60 million for certain Medicaid expenditures and HCBS, home and community-based services. And the proposed legislation alters some of that. And while it is well intended, the proposed legislation, if approved as written, it puts the department at risk for potentially having to pay back those $60 million. So this is something we need to address moving forward. Community health workers, again, super idea. You can't find a fan of community health workers bigger than me. Many of us in the department are excited about the opportunities to continue and support further and further professionalize this existing cadre of amazing workers that serve on the front lines from Nashua to Berlin, and our community health centers, our family resource centers, our public health networks, our community mental health services. They're everywhere and doing great work. So far, the department and community agencies have cobbled together an informal system of funding for CHWs. And it is often based on time-limited grant funds. And those grants are ticking, and many of them are going to end soon. Right now, we have more than 100 community health workers out in the communities. And since 2021, they have served almost 10,000 individuals. The resources are incredibly important right now to continue that work. SB 403 contemplates some resources to keep some of those folks still working, and importantly, also thinks about sustainability by developing, asking OPLC to develop a professionalization, a certification process. We are happy to work with that. It also contemplates the department thinking about adding CHWs to the Medicaid state plan. Again, those things cost money and things for you to decide at this table, but I'm here to say that community health workers in general are a great idea, and we're continuing to try and think about ways to cobble all of the streams of money together. Number 4, entry-level clinical staff and direct care workers, and increasing that. Again, important work. And, in addition to cost-effective CHWs, we have to consider pipelines to increase the number of entry-level clinical staff, including direct care workers. SB 403 provides some resources to the department to support training and activities that set young professionals up for success in healthcare roles. We believe in this approach in concept, but we should note that this is a new area of work for the department, and it would take resources to get that up and running. Family medicine residency program, another fabulous idea. This bill contemplates the support of a family medicine residency program up in Cowas County at Cowas County Family Health Services. This is really innovative to put a family medicine program in a community health center versus what's traditionally in a hospital or healthcare system. We agree with the concept of training our own docs in the beauty of the North Country, but this approach also would be a new scope of work for the department and would come with an appropriate price tag to keep that up and running, not only for the work in COAS, but for the work that the department would need to do in maintaining that, providing the sort of oversight and advice to that program. State loan repayment, everybody's favorite acronym, SLRP. This makes, 403 makes additional investments in the New Hampshire SLRP program. In this, one of the ideas here is to provide funds to license, let me frame this way. Currently, SLRP funds licensed healthcare workers, doctors, nurses, social workers, certified mental health providers. And SLRP has a great track of success. It's a fabulous program. And with the end of the COVID-19 pandemic moratorium on school loan payments, we are seeing an uptick in applications. This is sort of an example. We've had some incredible investments during the pandemic for SLRP, and we certainly had business, but with the end of the school loan moratorium, we're seeing those applications tick up now. Makes sense. 403 appropriates $12 million to expand SLRP, but now to include non-clinical staff employed by eligible sites. And these non-clinical staff are those who hold bachelor's degree. So while SLRP has been incredibly successful for the clinically licensed folks and those credentialed professionals, this issue around bachelor's level folks, while needed in the community, no doubt, may actually create some unintended tax liability concerns for those non-credentialed or licensed professionals, because our program is based on some federal tax statute and regulations. And those regulations say that a state loan repayment program supported under this federal subpart must contract only with a person who is a practitioner licensed by a state or who has completed training in an accredited graduate training program. So there's some stuff there that needs to be considered as we move forward. Again, a great intent. We all want to make sure there's more workforce, but there's some details around SLRP that probably need to be addressed. 403 also puts forward the idea of a health care workforce information center. Again, a great idea, but as with some of the other new initiatives in here, it would come with a price tag and it would be new work for the department. Similarly, there is some language in here to support something called New Hampshire Needs Caregivers. Again, a great program that's up and running right now, does incredible work. It is an expansion of what the department does, and again, would come with its associated price tag. The Senate Bill 403 also puts in support for what we call the Bi-State Recruitment Center. They have, and this is a partnership that the Division of Public Health Services has had with Bi-State since forever. And the Recruitment Center really has made some significant impact in recruiting and retaining qualified clinicians to fill our healthcare roles, particularly in our rural and underserved areas. Bi-State will tell you this, but they have identified almost 500 individuals with an interest in the program and assisted with the recruitment of about 19 clinicians and making 41 direct candidate referrals to New Hampshire practices. An additional 340 candidates were referred to New Hampshire via the Recruitment Center. This is a model that works. SB 403 contemplates adding additional resources to it. It is a scope of work that is already underway within the department. 403 also directs the department to have some role in an apprenticeship program for individuals with lived experience with substance misuse. This builds on some great work that is occurring within our Bureau of Drug and Alcohol Services. And this appropriation directs the department to contract directly with the University of New Hampshire Institute on Disability to develop this comprehensive apprenticeship program for paraprofessionals and individuals with those lived experiences. The department suggests that the proposed legislation could even be improved by including language for BDAS to contract with individuals with drug and alcohol substance lived experience, and with folks with mental health lived experience. This is another place that we could work with the sponsors and the advocates in the community to really make sure it aligns with the current work that is happening in BDAS. Finally, and so I will wrap up, I would just say that the breadth of 403, addresses the needs of our workforce pipeline, recruitment, reimbursement. It addresses regulatory barriers, and it addresses some policy changes that would likely strengthen the foundation of New Hampshire's workforce. As noted, all of these things come with a price tag, and that is for the committee here and the finance committee to consider as you're making your choices. Some of the work is in complete alignment with things that the department already does and we think are successful. Some are new and innovative ideas and come with the price tag of new and innovative ideas. And there are some things that probably need some technical fixes. Thank you.
Went through that fast. Yeah. I'm gonna have to watch that on YouTube again.
You got 7 pages or 8 pages in your notes, so hopefully that takes care of it there.
All right.
Thank you.
Any questions, Senator Bradley?
Good morning.
Good morning.
Don't want to keep you from Governor and Council, but in going back to House Bill 2 last year and how we incorporated a lot of different things in this committee into the budget, the Medicaid rate increases, Gannon's bill, Senate Bill 36, you name it. Would you agree with me that the priority, not only of the department, but I think everybody in this room, was the Medicaid rate increases?
I would agree that the Medicaid rate increase is incredibly important, and we have made huge steps. And I'm looking forward to really seeing how that pays off moving forward.
So this is where I'm going to get in trouble, and people aren't going to like this, but there's a reality factor here, folks. Just a quick math, there's no fiscal note. It's $32 million. That's all general funds. No matching federal funds or any that would be over and above that. It's a non-budget year.
Mm-hmm.
Education funding, Sununu Center settlement, some big ticket items that are big unknowns. I guess what I would ask the sponsors and the department is to take this bill and strip it down into what can be done now that has minimal costs, and then the department and the sponsors should work through the budget process next year to come back with some of this as it is able to get funded, because we stretched to do $134 million of Medicaid rate increases. So
I would agree that there are lots of great ideas in this bill. They come with hefty price tags. Some of the things may be able to be accomplished now with a minimal price tag. Some things are probably great places for us to plan.
And that's what I'd like to see you focus on with Senator Rosenwald, of what can be accomplished now for a minimal price tag.
Thank you.
Any other questions from the committee? Seeing none?
Thank you.
Have fun.
Thanks.
General
Can I
Counsel.
just respond to that?
We have 21.
Just really briefly.
Okay, quickly.
Thank you.
Yep.
If you look at the appropriation sections, you'll see that I've been aware of the need to be very judicious about spending general funds in a non-budget year. So general funds are a backup source for all of the appropriations to federal funds. Thank you.
Thank you.
And I'd respond to that just by saying we're almost at the end of pandemic funds that are available.
All right. Jim Monahan and Christine Stoddard. Okay. Greg White.
Good morning, everyone.
Welcome.
My name is Gregory White. I'm from Milford. I am the CEO of Lamprey Healthcare. We are a federally qualified health center in Nashua, Newmarket, and Raymond, and we also have a mobile health unit that visits many of the communities in those areas. Our federally qualified health center serves as a medical home to over 15,000 people from over 40 communities in southeastern New Hampshire. And I'm grateful for the opportunity to provide input today on Senate Bill 403, which proposes sensible, timely investments in New Hampshire's primary care workforce. As you're well aware, healthcare workforce shortages in New Hampshire have been growing at a concerning pace for years and now extend across both our clinical and non-clinical staff. At Lamprey, our present vacant positions include not only registered nurses, but physicians, nurse practitioners, physician assistants, behavioral health clinicians, and community health workers. It's critical that we invest in policies to help retain not only our current staff, but to build pipeline for our future work staff. I understand that the purpose of Senate Bill 403 is to create more opportunities for individuals to work in healthcare. This includes funding to support community health workers who are a critical component of our integrated primary care programming. Community health workers assist patients with accessing services that they need to improve their overall health beyond just the exam room, including things like heating, mortgage assistance, childcare, and transportation and food. We and many healthcare organizations across the state that employ community health workers rely on intermittent grant funding to support this invaluable resource. A voluntary certification of community health workers included in Senate Bill 403 is a decisive step to providing much needed financial security for these key members of our workforce. Also, funding for the state loan repayment program is another critical investment included in this bill. SLRP is the #1 recruitment and retention tool that we use as federally qualified health centers. The program provides partial payment towards educational loans of healthcare professionals in exchange for their commitment to work in underserved areas. Community health centers, community mental health centers, critical access hospitals, and other community-based healthcare providers offer this program to our staff that qualify. Right now, eligible applicants only include those licensed by the state or working under the supervision towards licensure. Expanding the SLRP to include staff with bachelor's degree will allow us to recruit and retain other key employees. The bill also includes continued investment in a marketing and outreach campaign led by State Primary Care Association Recruitment Center, the only nonprofit recruitment center in the state. This center is an excellent resource for our state's federally qualified health centers, rural health clinics, and other practices. Their team has the structure in place to
That's been 3 minutes.
Thank you. So we're proud of the work that we do at Lamprey Healthcare and are grateful for our team who deliver this work. Our ability to continue to do this work certainly is founded upon the availability of workforce. I'd be happy to answer any questions if you have them.
Any questions from the committee? Nope, seeing none. Thank you.
Thank you so much.
Christina Field, and I will also say Paula Smith is after Christina. Welcome.
So I'm Christina Field Sparks. I'm the director and principal investigator of the New Hampshire Area Health Education Center. I'm a resident of Lyme, New Hampshire. And I'm here to tell you a little bit. So I've submitted testimony and I'll keep this brief, but I want to tell you a little bit about the New Hampshire Area Health Education Center, or the New Hampshire AHEC. So the AHEC started, the AHECs in the nation started back in 1972 through funding through Congress. And this was following the passing of Medicaid and Medicare. There was a large concern that we didn't have the workforce to meet the needs of the growing insured population in the country, with a focus on rural and underserved communities. So the Carnegie Commission came up with a report and said, we are really facing this huge workforce shortage in these communities. So they funded two things. They funded bricks and mortar structures, which are the community health centers. And then they funded the AHECs to help support, recruit, and train workers for those community health centers. So back to the rural and underserved community. So over the years, the Congress had appropriated resources to fund AHECs in the country, and states slowly received these AHEC awards through competitive applications. The funding is through the Bureau of Healthcare Workforce at HRSA, the Health Resources Services Administration. It's a limited funding to provide infrastructure. Sorry. That's okay. So the New Hampshire AHEC was funded starting in 1997. The grant is held at the Geisel School of Medicine at Dartmouth College, and the structure is the grant comes to the college, and then we contract out to our partners in the northern and the southern part of the state. The southern New Hampshire AHEC is at Lamprey Healthcare, and the northern part of the state is at North Country Health Consortium. And through this structure, we blanket the state with trainings, but our focus is looking at the pipeline and the future of the workforce. So this bill covers some of the initiatives that we have conducted with the limited funding that we've had over the past 26 years, focused on building the infrastructure for New Hampshire. And we focus on students, the future of the workforce. And you can see in the testimony some of the examples that we've given. We offer educational opportunities and exposure to health careers for middle school, high school students in New Hampshire, with the expectation and the guidance to expose them to what a career would look like in a time in their life when they're trying to decide what they want to do when they grow up. And so we guide them on this path. But we have limited resources, and this opportunity for us would allow us to expand some of the known programs that we have built, but have limited capacity. So we're focused on building our own workforce, and that's a strategy based on the research
That's
that
been
is
3 minutes.
successful. Okay, thank you. Do you have questions?
Any questions from the committee? Seeing none? Thank you.
Thank you.
Paula Smith. Okay, and then after Paula is Stephanie Pagliuca.
Good morning.
Morning.
I'm Paula Smith. I have been the director of the Southern New Hampshire Area Health Education Center for the past 26 years. And I'm here to talk about New Hampshire's healthcare workforce. So over the past 2.5 decades, the AHEC program in New Hampshire has tried to build the healthcare workforce to meet the needs of people in the community. Our AHEC pipeline program include our 5th edition of the Health Career Catalog, summer health career exploration camps, and enrichment programs that can run almost the entire school year. One student, Margaret, was interested in becoming an occupational therapist. During our program year, we had her set goals, do research on the career, present it to the class, and we engaged her and other students in a panel discussion with health professionals who talked about their career paths and how they overcame challenges to reach their goals. AHEC then facilitated a job shadowing at an OT practice so she could see up close what being an OT would be like. This student graduated from high school and is currently enrolled in an OT program. Another high school student was interested in becoming a nurse. We linked her to enroll in an LNA prep program, which prepared her to successfully apply to nursing school. And each one of these high school students, with proper support and coaching, can realize their dreams and be our future workforce. There's a lot of competition between manufacturing and retail and healthcare, and we really need to invest in our healthcare workforce. Susie was an adult looking for a career change. She looked at the AHEC Health Career Catalog and thumbed through it with sticky notes and writing on different pages. She was motivated to go back to school and is now an X-ray technician working in a hospital in New Hampshire. Another member of the workforce is community health workers. They are key members of the healthcare team and act as the bridge between the community and the healthcare system. And that includes behavioral health and oral health as well. CHWs are trusted members of the community who help people with the non-medical aspects of their life. 80% of our well-being is a result of where we live, work, and play, while only really 20% is dependent on the access and the medical care that we receive. And CHWs help people navigate to needed resources, they provide peer education, and they support other members of the healthcare team. Currently, CHWs are primarily supported by grants. The language about CHW certification will assure that we can find ways to reimburse them for their services and sustain this crucial member of the workforce. AHEC also supports the Sector Partnership Initiative known as SPI, where we convene employers, academic partners, and other stakeholders in 5 meetings across the state monthly to address regional workforce challenges. We're able to work together to problem solve and take action. As an example, the Monadnock SPI recently hosted a career exploration day in
3
Keene
minutes.
for 300 students. So I'm really proud of what we've been able to accomplish, and I think our ability to reach more youth and adults is dependent on having funding to offer consistent programming across the state. Thank you.
Thank you. Any questions for from the committee? Seeing none. Thank you. Stephanie is next. Stephanie, and then Wendy Hunt from the Nashua Chamber is next.
Good morning.
Welcome.
Okay, thank you. I'm Stephanie Paluca. I'm the Senior Director of Workforce Development and Recruitment with Bi-State Primary Care Association, and I appreciate the earlier shout outs to Bi-State and the work the Recruitment Center has done. I'm here this morning in support of Senate Bill 403 and the initiatives that are contained within it. I've been with Bi-State for 30 years now working on healthcare workforce. I joke it's my favorite topic, only second to oral health. So I really could talk to you a very long time about these initiatives. I'm just going to focus on 2 things right now this morning because you're going to hear from a lot of experts in the areas as well as the written testimony I've provided that has more detail. Essentially, the Recruitment Center can serve, we're within Bi-State Primary Care Association, which is an association of organizations that are promoting access to health care and works with the 10 community health centers across the state. But the Recruitment Center actually, in addition to supporting the health centers at Bi-State with their recruitment needs, works with hospitals, private practices, community mental health centers, and others. So we're a little bit broader than that. In the 30 years that I've been doing this, I really believe that the initiatives that are coming forth in this bill are things that are very sorely needed. We have great players, institutions in place that can be built upon, and as you heard, even just from the AHEC programs that can be expanded easily. 2 of the projects in the bill are the Family Medicine Residency Program in Coos County. This is the first and will be the only family medicine residency training program north of Concord, New Hampshire. It's important that residents or any health professional students get training in rural and underserved areas where their services are going to be most needed, because those are the areas to incentivize them to go to help them understand the populations that they'll be serving. We have wonderful training programs in the state that do need some expansion, but most of them are in southern New Hampshire, and they don't expose the students or give them those opportunities while they're in training to learn how it will be in practice when they go to rural and underserved areas. So this is very important. Also, having it centered in a community health center versus a hospital-specific facility is great, because it's really the type of practice that a family medicine doctor will do once they graduate. The other piece I wanted to speak to this morning is this piece of the bill that's specific to the marketing campaign that's facilitated by Bi-State's Recruitment Center. So I have just a couple of stats. I'm just going to check my notes here. We don't have enough training programs in the state to recruit from in a regular year. Now we're in post-pandemic times where the healthcare workforce nationally is having challenges, and we are feeling the effects of that in the state. So we always have a strategy through the Recruitment Center of National Marketing and Outreach in very traditional strategies where we go to job fairs, we promote online job opportunities, and our staff at the Recruitment Center actually work with the health professionals who express interest to find communities where their professional needs and their personal needs can be met, and we link them with employers in those communities for their hiring consideration. So we have that system in place already. In 2023, we had some additional investment to start a digital marketing campaign or digital media campaign.
That's been 3 minutes.
Thank you. The digital media campaigns has sent millions of views of individuals to the recruitment center. Our team is starting to see repeat visitors to our website, and we are starting to see the results of folks coming in from outside of the state to be recruited here. Thank you.
Thank you. Any questions from the committee? Seeing none, thank you. Wendy Hunt. And next is, after Wendy, is Lisa Madden from New Hampshire Community Behavioral Health.
Good morning. I'm Wendy Hunt. I'm President and CEO of the Greater Nashua Chamber of Commerce. My comments today will be focused on the business perspective of SB 403. The Greater Nashua Chamber of Commerce represents 440 plus businesses, large, small, private, nonprofits, all sectors, as well as the thousands of New Hampshire residents they employ. The city of Nashua has the second largest population in the state, is home to some of the state's largest healthcare providers, hospitals, mental health, addiction, and nonprofits. The Chamber consistently hears from our healthcare members that staffing shortages in all departments are at a critical point, and they are in desperate need of help from business leaders and state legislatures to help find a solution to develop a healthcare pipeline of talent. I am here on behalf of the New Hampshire healthcare community in support of SB 403, which would help address the state's critical healthcare workforce shortage for the following reasons. It's an excellent tool to address this shortage. I'm going to paraphrase so I get through this in my 3 minutes. The ongoing healthcare workforce shortage is a serious cost driver for the healthcare industry, with higher wages, recruitment costs, inflated labor costs, and necessitated by using contract workers in all positions. Higher healthcare costs impact all sectors of our business community. Downshifting higher costs to employers who sponsor insurance reduces the ability to increase employee wages. A higher cost also for employees due to their insurance contributions, copays, etc. There's also a delay of care due to staffing shortages. I can attest to that. I have a child I tried to take, and it's a 4-month wait. While no single approach is a panacea, I think this is a great move towards trying to solve the healthcare pipeline workforce issue. I urge you to support it.
Thank you. Any questions from the committee for Wendy? Seeing none. Thank you. Lisa Madden. And next is Bobby Bagley.
Good morning, everyone. Thank you for giving me some time to speak with you this morning. My name is Lisa Madden. I'm the president and CEO of Riverbend Community Mental Health. I'm also the vice president of behavioral health for Concord Hospital. I'm here speaking on behalf of the Community Behavioral Health Association, which represents 10 community mental health centers throughout the state. My comments today will be specifically focused on the Student Loan Repayment Program, or SLRP, and wanting to identify the value of this program and ask for your assistance in extending it to a bachelor level of care. As you know, we are in a very significant staffing situation and staffing shortage within our community mental health centers, with approximately 330 vacancies that are clinical vacancies that are inclusive of case management, community support, residential staff, and licensed professionals. We have benefited greatly from the SLRP model that we've been able to use for our licensed folks. In fact, as you'll see from my notes that I share with you, is Riverbend alone has had about 40 participants. We have several more pending, And we have a total forgiveness of $1.76 million for these folks, with $1 million actively engaged right now. And what that's translated to is a 70% retention rate of these professionals within our system. So being able to help folks with their loans has helped them stay in community mental health, which is critical to being able to open services for those living with mental illness and addiction. We believe that if we're able to do this for bachelor level folks as well, we can keep the talent that's coming from our university and college system in our state, have them start their careers with community mental health, do case management, and work in our residential programs that allows us to keep people out of the hospital, and be able to strengthen their educational experience and hopefully promote them into, should they choose, a higher level of education in their master's program. Very valuable component of our recruitment, and we encourage your support of this program. I defer to any questions you may have.
Any questions from the committee? Seeing none, thank you, Lisa.
Thank you.
Bobby Bagley. Thank you. After Bobby is Kim Bernard. Welcome.
Good morning, and thank you for this opportunity to speak to you in support of Senate Bill 403. My name is Bobby Bagley. I'm the Chief Public Health Official and the Director for the City of Nashville's Division of Public Health and Community Services, and I'm here with Greska.
Hello, my name is Greshka. I am a community health worker at Nashville Public Health Services. Thank you for having me.
This is a very important bill, and I'm very excited to see that this has come forth before you. During the aftermath of COVID, our healthcare workforce, as you know, was devastated. We had the opportunity to hire community health workers to help with our workforce as we provided response efforts and were able to connect community members to services that were being administered during COVID. We're now in the aftermath of COVID, and we still have the opportunity to continue to work with this workforce. Community health workers have been a valuable part of our team at the Public Health Department, serving as a bridge and as liaisons between our service population, organizations, and the community in which we serve. They provided services that have included helping people to navigate through our healthcare system and also get people connected to vaccinations. They participated in home visits, as well as working with us during our behavioral health work, the opioid response, and they've been able to help us effectively engage community members as well. With community health workers on board, we've been able to close the gaps of social and economic factors that impact our communities, in particular, our racial and ethnically diverse communities. Our community health workers have been able to serve in first language, addressing cultural issues and nuances that our populations face. We've been able to have community health workers across our 13 public health regions through our community-based organizations and our public health departments. In particular, in Nashville and Manchester, in our two largest cities, we've been able to deploy community health workers with our partnering organizations in behavioral health, with our schools, with police, in response to our SUD activities, and also able to enhance prevention efforts. This essential workforce has been outstanding and needs to be sustained. This bill allows for us to do that and support these community health workers with certification, with training, and with job opportunities.
Again, thank you for having me. My name's Greshka. I am a community health worker currently working in the city of Nashville. My experience as a community health worker started in 2015, where I was able to experience in the community of Manchester in a healthcare facility. I worked closely with early supports and services and was able to see how that resulted in families being able to obtain services for their young children through early supports and services. Now with the city of Nashville and the outreach we are doing, post-COVID, there are many homeless members in our community. With our outreach services, we have been able to get those people housed. Do basic things like provide these people with transportation. Things like things as simple as going to the DNB and getting them an ID. Getting them off the streets into treatment, if that's what that looks like for them. Getting them mental health treatment, I'm sorry. Providing them with providers, PCPs that they're not looking for in the moment. As community health workers, like Bobby said, we bridge the gap. So it's not just providing them with the services and then leaving them. It's helping them throughout the way. Maybe not holding their hand, but there's a saying that says, you can lead a horse to the water, right? You can't make them drink, but you can make them thirsty, right? People will get thirsty and they will want the things that you see possible for them. I have been able to experience these results and it's rewarding. And to be able to sustain this workforce through accreditation, through licensure, like other professionals have, would be amazing. I've seen funding come and go within my work. Like I said, I started in 2015 and it has looked differently within the funding provided to us. Now with the outreach services in Nashua, like I said, I have been able to see successes within our community. People are happy to have community health workers within their community, not just within public health. Like I said, within the schools, within the medical homes. Another funding that I had was geared towards social determinants of health for people, and we were able to provide those things within their medical home. Reduce healthcare costs within those things because people weren't going to emergency rooms for services because they knew and they understood through the community health workers that we were able to talk to them in their language and in a way that they're able to understand, that they were able to go
That's
to their
been
PCP,
3 minutes.
to their PCP and not have to go to the emergency room for services. Like I said, accreditation and licensure will support the workforce, and we don't have to see it or be scared to lose our job because the funding goes away and we have to apply to different funding or different things that look different. So thank you very much.
Any questions from the committee? Seeing none. Thank you.
All right. Thank you for having us.
Yep. Thanks for coming. Kim Bernard. After Kim is Lindsay Courtney.
Good morning.
Morning.
Thank you for this opportunity to speak in support of Senate Bill 403. My name is Kim Bernard. I'm the Chief Public Health Nurse for the City of Nashua Division of Public Health and Community Services. Our public health team works collaboratively with our community partners, including nonprofits, healthcare systems, private organizations, and governmental agencies, to deliver services throughout the 13 city and towns in the greater Nashua community. Without adequate funding for the public health workforce, we risk a weakened defense against outbreaks, slower response times to health emergencies, and diminished community health services. This shortfall could lead to an increased disease transmission, heightened health disparities, and a strain on healthcare systems, ultimately compromising the overall well-being of our New Hampshire residents. In closing, investing in our workforce is a measure to prevent these potential consequences. Supporting this bill is essential to safeguard the health of our community. Thank you for your time.
Seeing none. Thank you.
Thank you so much.
Lindsay Courtney. Might not be up. Next up is, after Lindsay, is Carolyn Virtue. Oh. Okay. DNC. Carolyn Virtue.
Thank you. I was hoping, my name is Caroline Virtue, Granite Case Management. I have worked in long-term care in New Hampshire since.
Just hold on.
Sure.
After Carolyn is Ben Bradley. So, go ahead. I'm sorry.
Do I get to start my 3 minutes over? Carolyn Virtue, I've worked in long-term care in New Hampshire since the 80s, longer than I care to recount at this point because it makes me pretty old. I appear before you to speak on the case management section of Senate Bill 403. I emailed my prepared testimony to all of the committee members early this morning. But I'm going to veer away from that given the testimony of the department through Ms. Tilley. I became aware of the testimony the department intended to present here today on the case management section earlier this week. I worked with Medicaid Director Lippman because although the department's position is service coordination is not case management, he has signed off on a state plan amendment that says it is. I spoke with Christine Santaniello last evening. The Bureau of Developmental Services has filed documents with CMS which say service coordination is case management. The last item I directed to the department late yesterday was their new MMIS rate sheet. That sheet does not list service coordination as a service. So what I would say to you here today is service coordination is case management. Service coordination has been case management. The New Hampshire Department of Health and Human Services was under a plan of correction for 8 years. They were directed by CMS to fix this. The department had until June 30th of this year. I'm very sorry to play this card here. I had no intention of doing it. I thought I had resolved the issues with the department before the hearing today, but it made it to the testimony. So the department has certified to CMS that case management can be provided by any willing and qualified provider as of July 1, 2023. Here we are, several months out from that, and despite a great deal of effort working, and there have been personnel changes, I get all that, but there's no desire to be in compliance with this.
That's been 3 minutes.
Thank you. I'm happy to take any questions. The department is out of compliance. I'm serving people and I can't bill. So I will end with that. And really, I do appreciate your efforts. Thank you. And I appreciate Senator Rosenwald's efforts. So thank you to her.
Senator Bradley.
So when we did Senate Bill 36 last year and incorporated it into the budget, you worked with the department on an exactly similar situation for case management. What happened?
You put language in that bill that the department should understand service coordination is not case management, and they still don't understand that. So this is the language in Senate Bill 403 is the federal language. All I'm asking is to put it in there because they can't, seem to get a grip on that. The other thing I will tell you, if you're concerned about money here, I don't know how the department is going to come to the expenditure of the funds that they're saying I'm jeopardizing with this language, because there's no code to bill service coordination anymore. So I think somebody really should look at these appropriations.
Where, Carolyn, is the actual language in question?
Section 4 is what I added. It's language we are already bound by federal law to subscribe to. So
Okay, thank you.
thank you. Really, I appreciate it. And if anyone has any questions, my cell number is on the top of my testimony.
Thank you, Karen.
Thank you.
Ben Bradley? After Ben is Holly Stevens.
Good morning, Madam Chair and members of the committee. My name is Ben Bradley, Vice President, State Government Relations with the New Hampshire Hospital Association, representing all 26 of the state's community hospitals as well as all specialty hospitals. The New Hampshire Hospital Association supports SB 403 relative to healthcare workforce investments, and thanks Senator Rosenwald for her leadership on this bill. This important investment makes one-time investments at a time when our industry faces unprecedented challenges that make it difficult to sustain, build, and retain a strong healthcare workforce. Vacancies across New Hampshire healthcare industry remain significant, as evidenced in part by our latest vacancy report, which shows a total vacancy rate for all hospital positions of 15.5%. Today, I'd like to focus on one section of SB 403 that's of keen interest to our hospital members, specifically the provision for voluntary certification of community health workers. Hospitals employ community health workers but do not receive any reimbursement for the important services they provide to support patients in their ongoing care and recovery. By passing SB 403, the Office of Professional Licensure and Certification will be able to promulgate rules to establish certification criteria for community health workers that would assist in eliminating some of the barriers currently in place that prevent community health workers from seeking reimbursement for the services they provide. Thank you for the opportunity to comment on SB 403, and I'm happy to take your comments, questions.
Any questions from the committee? Seeing none? Thank you, Ben. Holly?
Good morning. My name is Holly Stevens. I'm the Director of Public Policy for NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI New Hampshire, I'm here today to speak in support of Senate Bill 403. Workforce shortages continue to challenge New Hampshire as a whole. However, the impact is especially grave on the state's healthcare workforce, which includes the mental health care workforce. The struggle to attract and retain critically needed staff results in excessive wait times for patients and increases the risk for harmful burnout in dedicated professionals. I've included some statistics in my testimony about the rates of mental illness in New Hampshire and the number of folks that were able to actually receive services, which I will allow you to read. I won't go into, but I did want to call your attention to one of our volunteers who attends our public policy meeting, who has asked me repeatedly and asked us repeatedly, what are we doing on workforce? She is an individual who has, over the last couple of years, lost about 5 or 6 psychiatrists and about the same number of oncologists. And when you think about the services that are provided by those two providers, you share some of your deepest, darkest secrets with psychiatrists and with oncologists when you're facing staring cancer in the face. And so she has, said repeatedly at those meetings, I just lost another psychiatrist. I just lost another oncologist. And Senate Bill 403 will do a lot to help with holistically with the pipeline and with the state loan repayment services, program, will help to resolve this issue of the revolving door of providers going in and out of different employers and leaving the state as well. So in closing, when individuals with mental illness receive the right services in the right place at the right time, fewer folks will end up homeless, hospitalized, or incarcerated, all of which cost the state far less than providing community-based services. As I mentioned, the holistic approach that Senate Bill 403 has with pipeline development programs as well as the state loan repayment program will help to address this workforce shortage. Therefore, we ask the committee to support Senate Bill 403, and I will answer any questions that you may have.
Questions from the committee? Seeing none, thank you very much.
Thank you.
Alex? Is Alex in here?
Saw him. I think he's outside.
Tom, you can take his place. I know you're not. That was the next one. Yes.
Oh, she did.
I could be taught.
Good morning. Sorry about that. Thank you, Madam Chair and members of the committee. My name is Alex Katrubis. I'm here representing the New Hampshire Association of Residential Care Homes, the New Hampshire Healthcare Association, and the Community Support Network, the 10 area agencies. New Hampshire ARCH and New Hampshire Healthcare, so that's assisted living and the nursing homes, support, and I don't think this has been brought up yet, but it may have. I've been trying to listen in the hallway. Section 5 of the bill. It's at the bottom of page 2, the top of page 3, lines 34 through 36 on page 2, and lines 1 through 5 on page 3. And this is a workforce issue that was requested by the long-term care facilities, both skilled nursing and assisted living. As you know, the long-term care facilities in our state are facing a patient care crisis because of the lack of healthcare workforce. And I won't go into all the statistics that I did last session with Senate Bill 86, but just a quick reminder, the AARP study in 2023 ranked New Hampshire as having the second worst nursing home staff shortage in the entire country. So Section 5 would allow an LNA who's been practicing for 1 year the opportunity to earn a certificate of medication administration. And just as a quick reminder, the M&A program, it prepares licensed nursing assistants or LNAs to function as partners with RNs and LPNs administering medications to clients in long-term care facilities like nursing homes and assisted living. The current BON rules prevent LNAs who have less than 2 years of experience from earning their M&A. So this bill would simply override those rules, and the required study and clinical requirements for the M&A would all remain in place. This just reduces the work experience requirement from 2 years to 1 year. I saw that OPLC was signed up. I don't know if they had a chance to talk. I certainly don't want to speak for them, but I did speak with Director Courtney, and she said that she agreed that this requirement could be lessened or even perhaps eliminated. So just in summary, we do support Section 5 of the bill. It doesn't cost any funding, any state dollars or federal dollars to do this, and we really don't feel that there's any good reason that you have to be an LNA for 2 years. We feel that after 1 year, both the employer and the OPLC will be able to judge whether or not this individual is able to move forward and continue with their education and experience to receive the M&A. So this is, I think, a small step to try and increase the workforce pipeline. And I cut out a lot of my other testimony, but again, all of my clients support this legislation. We do have one concern. Specifically, the area agencies have a concern, and this was raised by the Deputy Commissioner of HHS, Tricia Tilley. Page 2, line 31, we have a concern in the DD community with making case management and service coordination the same thing. The DD system is moving away from the term case management and moving.
That's been 3 minutes.
It has been submitted. Okay, so. Oh, I apologize. So we would just we echo the concerns of HHS. We want to work with the proponents of this language and try and come to a compromise. But the area agencies share the same concern as the Department of Health and Human Services on that issue. Thanks a lot.
Thank you, Alex. Any questions for the committee? Seeing none. Thank you.
You're welcome.
Tom Bloomquist.
Your patience, polio is a gift that keeps on giving.
4, 5, 6, 6.
Interested in earlier testimony as well, MPT as well.
See what she said.
Thank you, ladies and gentlemen, for your time. Thank you, sir. I urge you to support SB 403, a plan to increase healthcare workers in this country. I came to New Hampshire at the behest of an anesthesia provider pain manager in Woodsville, New Hampshire. So I've been to the northern areas. Having chronic pain in your back is tough enough, and trying to get to a healthcare provider in the northern area, you can get north and south in New Hampshire, but trying to get over the country roads when you've got excruciating back pain is a real bugger. And say, oh yes, you're over here, go to Dartmouth or go down to the southern part of the state. That's real tough. So educating people in the North Country would be very helpful. I am a recently retired anesthetist pain manager and represent a large group of educated providers willing to be instructors and teachers. But the colleges don't want to talk to anybody short of a doctorate, despite years of education, many degrees, and so forth. So, and a lot of these people, recently retired, very educated and experienced, are more than willing to be educators to help the upcoming people and help with this healthcare shortage. If we can clear the blockages, open the pathways, and I urge you to work with your constituent groups, the many of them, to say, hey, how about talking to these people? You know, some can work as, you know, some have done well and can work on an all voluntary basis. Some may need a little support, or academic recognition would be enough. But we have this woodpeckers. We have this. You have this huge resource of folks willing to help with this problem. And I urge you to find a way to harness this resource of educated, capable, willing grant estaters ready to help with this problem. So I thank you very much for your time, and we could be a piece of the solution puzzle.
Thank you very much. Any questions from the committee?
For
See-
further contact, my contact information will be on the bottom of my submitted testimony.
That'd be great. Thank you. Next up is Brody. Brody Deshays.
Good morning.
Morning.
Thank you for indulging me. I appreciate it. Chairwoman Senator Regina Birdsell and Senate Health and Human Services Committee here to testify on House Bill 403 relative to healthcare workforce investments. My name is Bertie DeShays, and I'm the Policy and Communications Manager for New Hampshire Hunger Solutions. Our organization advocates to end food insecurity, improve access to nutritious food, and address the root causes of hunger for all New Hampshire residents. New Hampshire Hunger Solutions is committed to improving equitable access to federal nutrition programs. House Bill 403, legislation relative to healthcare workforce investments, provides a foundation for community health workers to connect people to the support and services they need most. Food insecurity is a leading cause of chronic disease, illness, death, and increased healthcare costs in New Hampshire and the U.S. Because of this, New Hampshire Hunger Solutions co-leads a work group with the Department of Health and Human Services and partners from around the state to improve nutrition equity. The group's priorities are grounded in evidence-based practices recommended by the CDC. They are to 1, screen community members in healthcare, public health, and community-based organizations settings for hunger, housing, career services, childcare, and other social support needs. 2, refer community members for needed services and ensure they get connected. 3, match community health workers from healthcare and public health organizations to help with screening and connect people with the needed services. An essential element for fighting hunger in New Hampshire is ensuring everyone living with food insecurity can connect to the programs and resources they need. Community health workers are essential to this goal. One significant barrier to implementing these approaches is that healthcare and public health organizations need to be reimbursed for providing the community with connecting services carried out by the community health workers. This bill would rectify that discrepancy and put the pieces in place that allow Medicaid and other third-party payers to reimburse community health worker services. This bill is critical to ensuring that New Hampshire healthcare and public health organizations can provide New Hampshire residents with the healthcare and social support they need to stay healthy and to give back to the New Hampshire economy. Thank you for your time in taking my testimony, and I appreciate your service to our great state. And I printed up my testimony to submit for all of you. Thanks again.
Thank you.
I'll
Rhoda.
take any questions.
Any questions from the committee? Seeing none.
Awesome. Thank you. Have a great day. I'll see you later.
Jess Asklund is next. Oh, she's out there. And after Jess is Kathy Harvard.
Good, morning. Madam Chair, members of the committee. For the record, my name is Jess Eskeland. I am the Senior Policy Manager for the Alzheimer's Association here in New Hampshire, and I am delighted to be supporting Senate Bill 403 before you today on behalf of the association and the 26,000 Granite Staters living with Alzheimer's disease. Healthcare workforce shortage is one of the biggest challenges facing this constituency in the state right now. I said 26,000 folks living with this right now. That is supposed to go up by 23.1% by 2025, meaning that 32,000 New Hampshire residents will be living with Alzheimer's or a form of dementia. Even without this increase, the workforce shortage is already resulting in long waits for diagnostics, evaluations, and ultimately treatment for these folks. This is happening at a time when early detection is more important than ever due to exciting research advances, but underscoring all the more the importance of early detection and care. So I will be very brief. The association supports this bill, but I wanted to highlight just a few key components that we're really excited about. The investment in the Area Health Education Center's workforce development pipeline is fantastic. This would increase the number of entry-level clinical staff, including direct care workers working in New Hampshire. This will lead to more LNAs and ultimately more PCPs in the state, and these are some of the jobs that are really on the front lines of facing our dementia issues. PCPs are more and more on the front line of evaluating, diagnosing, and treating these folks, and really managing their care once they get into the healthcare system. LNAs are a critical part of their care, whether it's home and community-based care or residential. They shape their everyday lives. They help with all elements of their physical care and are really critical to their quality of life and care. Very much support the investment in Coos County Family Health Services Family Medicine Residency Program, which will also help, we feel, address the PCP shortage. This training will be particularly beneficial as it's in the North Country. It's the only training of its kind north of Concord, as I understand. And our hope would be that these folks, after training, as is often the case, would choose to stay and practice medicine where they're trained. This would be an incredible boon to the North Country that has a large geriatric population, is in very much need of these services. Finally, we strongly support the investment in the New Hampshire Needs Caregivers Program, which will go a long way toward addressing our state's LNA shortage. As I said, LNAs are a critical piece of the scene in terms of addressing the needs of those living with Alzheimer's and dementia, providing their care, whether it's having the staff to getting them placed in residential care or taking care of them in home and community-based settings, depending on what that patient and their family wants. I'd like to close on a hopeful note, which I alluded to earlier, and that is in the last 2 years, we've seen some of the first disease-changing treatments come online for Alzheimer's disease. This is really exciting. And unfortunately, you know, they're not cures, but they do promise some folks the promise of a longer time feeling like themselves, recognizing family members, and affording them the opportunity to make some of their own decisions about what happens down the line as the disease progresses.
That's been 3 minutes.
What's that?
That's been 3 minutes.
Oh, okay.
You can finish up.
It was super optimistic, wasn't it, though? So what I would say is, because of this enhanced focus on early detection, we want to be sure we're doing everything we can to ensure these folks are getting the quality and timely care that they need to give them the best chance they have. So with that, thank you so much for your time. I know it's been a long morning, and I ask for your support on this bill.
Any questions from Jess? On front to Jess? Seeing none, thank you.
Thank you so much.
Kathy Harvards. And after Kathy is Karen Rosenberg.
Good morning, and thank you. My name is Kathy Harvard. I live in Hanover, New Hampshire, and thank you for the opportunity to offer my testimony in support of Senate Bill 403. Direct healthcare support and the availability of healthcare workers who are knowledgeable and trained in dementia care is probably one of the single most critical issues that faces families who are struggling with Alzheimer's disease or some other form of dementia. Whether in the earliest stages when seeking a diagnosis or later when caregiving is really an around-the-clock job, family caregivers and residential facilities alike need a reliable healthcare workforce that can help them support and manage this extremely difficult disease. I speak today on behalf of my own family, but as well as the 26,000 other families throughout the Granite State who are facing these struggles every single day. I've shared my family's stories with many of you before, but let me just quickly run over the outlines. My story is being repeated essentially by other families. So when you're hearing my story, it's everyone's story in many parts of it. My husband was diagnosed with younger age onset Alzheimer's at 59, just 9 months after being fired from a job for performance issues which were in fact connected to his illness. This is a common story for folks with younger age onset. Had anyone recognized that he was suffering with the early symptoms of Alzheimer's disease, he would likely have received disability support through his employer rather than being fired. Instead, our family's resources, that includes our college savings for our children, our retirement savings, necessarily needed to be directed to 10 years of caring for my husband. In the early days, there were very few caregiving services or resources in my community to spell me while I made time to work and to care for my children and my family and my husband. The home health care services I used faced chronic health care and health staff shortages and very high turnover rates. In addition, few had formal medical training and most had little to no dementia training. Like most caregivers, I realized pretty quickly there was not going to be much backup. I was in this pretty much by myself. It just wasn't available. For the last couple years of my husband's life, he lived in an assisted living facility, and I would like to tell you that he received the premier care that they advertised, but I cannot say that that was the case. Well, there were certainly several wonderful and devoted staff there who did their best. Their numbers were too few, their training in dementia care inadequate, and they too faced chronic staff shortages and turnover. During the final 3 months of my husband's life, my husband's need for dementia care increased significantly. Instead of being transferred to the memory care unit of the facility where he'd been living as promised, I was told he would not be accepted there and we would need to find another facility. The explanation, staffing concerns. The meaning, not enough trained staff. My husband died before a move took place, but I recognized how our experience illustrated so graphically just how urgently we need a healthcare workforce that can meet the needs both of families and medical and residential facilities who are grappling with the growing numbers of persons with Alzheimer's and other dementias in New Hampshire. New Hampshire's healthcare workforce crisis affects us all, but it is particularly acute for the Alzheimer's community. Thank you for your support for this bill, and I hope you'll make it a priority.
Thank you, Kathy, and thank you for your story. Any questions from the committee? Seeing none, thank you. And I apologize, Karen Rosenberg is signed up not to speak, so next on the list is Mike Padmore. And right now, we only have 2 speakers after Mike. Welcome.
Good morning. Madam Chair, honorable members of the committee, thank you for allowing me the opportunity to testify this morning. My name is Mike Padmore, and I'm the Associate State Director of Advocacy for AARP New Hampshire. With 210,000 members across New Hampshire, we are the state's largest advocacy organization focused on the interests of the Granite State's 50-plus population. I'm here today in support of 3 sections of Senate Bill 403. The Family Medicine Residency Program in the North Country, the Community Health Worker Voluntary Certification and Deployment, and Area Health Education Center Workforce Pipeline Development. I think others have covered all the details of the benefits of these programs. I'm going to keep this pretty high level. We all know that there's a healthcare workforce shortage across New Hampshire, but this is particularly evident in the North Country, where patients tend to have to travel further to see a primary care provider. A family medicine residency program for the North Country would make strides in improving access to care for our senior population in that part of the state, bringing in physicians skilled in providing high-quality, efficient care. And while this program will offer immediate additional capacity for care, we also know that residency programs tend to have a long-term impact as well, increasing the likelihood for those physicians to continue to practice in the region of the state that they did their residency once they finish up their residency. For the Community Healthcare Worker Voluntary Certification and Deployment and Area Health Education Center Workforce Development Pipeline sections, we support these investments for much of the same reasons as the residency program. These investments will go a long way towards training and deploying healthcare workers, many of whom will be direct care workers who will be serving our communities and will undoubtedly result in better access to care for seniors living in New Hampshire. Thank you for your time, and I'm happy to answer any questions.
Thank you, Mike. Any questions from the committee? Seeing none. Rebecca Sky. And next is, and last on the list is Carly Hughes after Rebecca.
Good morning, Madam Chair and members of the committee. Thank you for the opportunity to speak with you this morning. My name is Rebecca Sky, and I'm the Executive Director for the New Hampshire State Commission on Aging. The Commission on Aging was established during the 2019 legislative session. Our key charge is to advise the governor and legislature on issues related to aging. So just as you turn to the Department of Health and Human Services to figure out this bill and work with the advocates, please also consider the Commission on Aging here to serve you in that capacity. As you need, and to find answers, all that, answer all your questions, etc. So On the front side of my testimony, you'll see that it largely talks about data about the healthcare workforce shortage. The New Hampshire Commission on Aging, for the past 2 years in our annual report, we have named growing the direct care workforce as one of the top priorities for New Hampshire. I'm not going to dive into the data on the front. I just want to bring your attention to one bolded section in up there that says the decrease of 12. There's been an overall decrease of 12% in the long-term care workforce and 23% specifically within the skilled nursing workforce from 2015 to 2022. That's what the dire, that's just a piece of the dire situation that we're in. That data is from the New Hampshire Employment Security. People have talked about many of the good aspects of this bill. It's filled with great things that will help New Hampshire. I want to jump to, I think I'm going to address only two issues in particular. Part 7 about community health workers. I just want to talk a little bit about exactly what they do for older residents of the state. People have talked broadly about their role. They are of immense value to the healthcare team supporting the fundamentals to good health. They, among other tasks, they facilitate access to healthcare and social services and other community health integration services, connecting older people to transportation to get to their healthcare appointments, to Meals on Wheels programs for nutrition, senior companion programs to prevent social isolation, and support use of telehealth and so much more. So professionalizing this workforce, recognizing their contributions as a critical part of the healthcare team, enabling reimbursement, all good things. It'll help to keep people out of hospital emergency rooms and avoiding the pipeline to skilled nursing facilities by helping people to successfully age in their homes. And the other section I wanted to talk about is Part 8, the New Hampshire Needs Caregivers Program. It's a program that's working exceptionally well. I know there's big concerns about the price tag on this bill, but there's some things that if they are not funded this session will go away, and this potentially could be one of them. The funding for this program is ARPA funds that runs out. It's either in May or June of this year. To rebuild up this program in, let's say you wait to a budget year to make the decision on this program, the resources will go away, the momentum that it's built will go away. I have provided in my testimony here some data, program data for 5 months of their work. I believe in this.
That's been 3 minutes.
Okay, in the student, I'll just in one sentence finish up. Then the Southern New Hampshire AHEC testimony has a lot more data about the program and its success rate. Thank you so much for your time.
Thank you. Any questions from the committee? See none. Thank you. Carly Hughes. At this point, Carly is the last speaker. If there's anyone that is interested in speaking on this bill, please let me know after Carly speaks. Welcome.
Hi, my name is Carly Hughes, and I'm a community health worker. I want to tell you a little bit about my role and what I've done in my position. I've now held 2 roles as a community health worker. In my first role, I was at a federally qualified health center, and I worked directly with patients in the primary care setting, as well as out in the community. In the community, I was able to meet people in their own space and discuss how to access medical care and how to overcome these barriers that they have to their medical care. In this role, I also obtained a certificate to become a health coach. As a health coach, I would meet with patients that had chronic illnesses. One woman I worked with was living with high blood pressure, high cholesterol, and obesity. Working with her was wonderful. We met bi-weekly, and through the use of motivational interview, she was able to set obtainable and time-specific goals and make small weekly changes. Throughout our sessions, she was able to make major changes to her life, becoming more healthy and more active than she had been in a long time. This woman looked forward to spending time with her daughter outside again and was able to regain access to some wonderful parts of her life that she had been missing. I also had the privilege to work in a mobile healthcare unit, bringing care to the community in spaces where care is needed. Along with providing medical care to our patients through our providers, we're able to assist in accessing resources and find ways to have their needs met in their own spaces. I spent time working in a reverse primary health care integration program, primary care within a community mental health care center. I was able to work closely with a population that statistically does not receive the care that they require to stay healthy. They often die 25 years earlier on average than those outside of the routine mental health care system. While in this setting, I was working with one woman in particular who had extremely high anxiety. She needed routine medical care, and that was hard for her. Oftentimes, patients are given referrals to obtain care with a specialist. As I'm sure we're all aware, this can be difficult. You get a referral, and they don't take your insurance. Or you need an urgent appointment, and they give you one that's 6 months out. This is a challenge for anyone. And when you have a patient that's already struggling with navigating the healthcare system, or they may have not have had the best experiences, I'm happy that I'm there and able to help. I worked with this individual to make sure that she not only had everything she needed, but I was also able to put the pieces together for her. With that support, she attended her appointment and was able to get the care that she needed. I think it's important to remember that we are here to help. We are community members, and we help them attend to things that they need to attend to. We are not enabling people to become dependent on a system. Instead, we are giving every interaction the best chance to become successful. We are here to cheer them on and then to navigate through barriers when they arrive. In my current position, I am what I like to refer to as a community health worker for community health workers. I'm a program coordinator. I assist in facilitating the community health worker training offered by my organization. I truly love seeing the growth during the class, and I look forward to continuing to be a resource for all community health workers. Community health workers are doing great work, and there are many spaces, not only in healthcare, but mental health, family resource centers, schools, and many more, where CH integration has yet to start. Obtaining community health worker certification will help to sustain the current workforce and continue to provide our communities with the support they need. Our communities need our help, and we want to be here to close the gap.
Excuse me. Thank you so much. Any questions from the committee? Seeing none. Thank you, Carly. Is there anyone here that would like to speak? That after Emily.
No, accidentally.
Oh. Sure, come on up. I'm sorry, what's,
I think I was toward the end. Did I sign in on the wrong one? That's what happened. I signed the wrong sheet. I'm
Okay, sorry.
That makes more sense now. My apologies. So my name is Melissa Nemeth from the Department of Health and Human Services, and I wanted to provide a little bit more information than Tricia did in her overview and in response to some other testimony you heard, specifically on Section 4 of the bill relative to case management. The department and I do have some federal regulation I can point out. I know there was reference made to the fact that there is federal law language that is mimicked in the bill. That is relative only to state plan case management services, and these regulation that I am circulating is relative to home and community-based waiver services, and it specifically outlines that case management, and it's the term case management and service coordination is somewhat used interchangeably, which admittedly can be confusing. But this federal regulation says that case management for waiver services can be a service as it is defined by the agency and approved by CMS. And that is what has happened now. The department has home and community-based services waivers that include service coordination, and that is separate and apart from the case management that is offered on the state plan. So the department's concern is that if this bill were to pass as it is currently written, you can only have a service on the waiver if it is not offered on the state plan. If the definition is the same, then there would be no need to have it on the waiver. And that is what leads to the concerns about the funding that were in the written testimony, and also that Tricia alluded to, in that because the department has accepted ARPA funds, you are not allowed to change. If you change a service that was in place as of April, I believe the date is April 2021, and it's in the testimony, the department is at risk for payback. If this needed to be taken out of the waiver because it became synonymous with a state plan service, that would change a service on the waiver in its scope, frequency, and duration, and would put the department at risk for a $60 million payback. That would be in all general funds. So that is a significant concern. Also, there was reference in previous testimony that the department had a corrective action plan with CMS to address this. I'd just like to clarify that the department was under a corrective action plan with CMS. However, the reason, one of the components of that was to ensure that the agency providing service coordination to an individual and the agency providing direct service to the individual were not one and the same. So it did not address the specific issue that is outlined or proposed to be addressed by the language that is currently in the proposed legislation. And I just wanted to offer that clarification that the department is not afoul of any federal regulation or corrective action plan with CMS in the way that the service is delivered currently. And there was, I think there was in previous testimony, there is billing being done these as of July 1st to come into compliance with the corrective action plan. All providers of Medicaid services for the waiver participants must be directly enrolled with the department as a Medicaid provider, whether or not they want to bill directly or use a billing partner. That is happening. The department, the website is updated regularly. That includes a list of all of those who have been provided to, all of those who've been enrolled to provide each service on the waiver. And that is certain, that list is something, if it was of interest to the committee, that could certainly be provided by the department. But there is, and it is being billed as well by providers. And with that, I'd be happy to take any questions.
Any questions from the committee? Yep.
The department would be happy to serve as a resource for questions.
Yep. All right. Thank you. With no questions, I appreciate your time.
Oh, yes.
Is there anyone here that has not spoken on 403 but would like the opportunity to? With that, I will close the hearing on Senate Bill 403, and as soon as Cam is ready, we have one more bill.
On the
Lauren Bobbitt's ex-husband was arrested.
What'd you say? Who's?
I said you'd like it, Lauren Bobbitt's ex-husband.
Oh my God.
All right, so,
So what they're saying, she just clarified that the definition in the bill, like, we have to be careful that there's a certain definition for like a straight Medicaid service, and then there's a separate definition for like a waiver service. Waiver, basically, like, you don't want to.
okay.
Correctly.
Still, the next one been vetted by the.
How many?
I forget if I gave you the amendment. Yeah, you can hand it out. Yeah, thank you.
I will open the hearing on Senate Bill 410, and prime sponsor is Senator Whitley. But I will, just as a reminder, and I'll say it again at the end, after the break, when we start at 1 p.m., we will be meeting in room 100 across the street. So go ahead, Senator.
Great. Thank you, Madam Chair. And good morning,
still, members of the committee. For the record, my name is Becky Whitley, and I'm honored to serve Senate District 15, which includes the wonderful communities of Bow, Concord, Pennacook, and Hopkinton. So today, I'm honored to introduce SB 410, which establishes a mental health community and transitional housing fund. You all know the myriad of services that our regional community mental health centers provide, but you may not know that they also provide several housing services with different reimbursements. These include certified community residences and supportive housing. The certified community residents are more intensive settings. These are the ones that provide 24/7 staffing, meals, on-site functional support services, and then supported housing is more for patients with a lower acuity and that needs fewer support services. So despite this being a very important part of the service array, a major challenge in providing this housing is the below cost reimbursement that the CMHCs receive for these services. And of course, this is particularly problematic for supportive housing because there is no Medicaid reimbursement. And almost no state funds provided. So that means that all supportive housing programs operated by CMHCs do operate at a financial loss, and the folks behind me can speak to that in greater depth. So as a result, it's been increasingly challenging for our CMHCs to provide this current housing. These are our nonprofit organizations, and of course, any expansion of these numbers offers much more serious challenges. In the current state operating budget that we passed in June of 2023, there was a modest increase for higher acuity certified community housing Medicaid rates. But because there is no Medicaid reimbursement for supportive housing, the operating shortfalls for the lower acuity supported housing continue because we did not really address those shortfalls in the budget. So to address this issue, the legislation provides a two-part solution. First is an appropriation to offset costs for CMHC operated supportive housing to address this below cost losses that are currently being experienced. Second, and the folks behind me can actually sort of talk in greater detail about those losses and again, per bed, what those losses are. Second is a one-time appropriation per bed to CMHCs to use to offset existing capital costs and to add additional beds in either the certified community residence programs or the supported housing programs. So I want to put this in context about why this is particularly important. We know that DHHS is working very hard on the Mission Zero initiative, of course, as part of this ongoing litigation for in the community mental health system. And that Mission Zero initiative is designed, of course, to eliminate those the ER boarding wait lists. A key element of that is not just higher acuity hospital beds, psychiatric beds, but community housing for individuals who are being discharged out of New Hampshire Hospital and other inpatient settings. This is a huge gap, and we won't achieve Mission Zero until we address that gap. Without a robust supported housing program like the one we're talking about today, this backdoor part of the solution, it won't work. We have to get to the table and try to figure this out if we're going to get to Mission Zero in our ERs. I'm happy to take any questions, but I certainly will defer any technical questions to the folks behind me, particularly on the losses that they're experiencing and the need that they see. I will bring the committee's attention to an amendment 0106. My understanding is that the community mental health centers worked with DHHS on this amendment to make sure that it aligned fully. Minor changes on line 11. I think there was an addition of per bed and then a clarification on line 11 at the very end to say community mental health centers rather than programs. And then on line 14, we adjusted the date a little bit to align with other requirements. Thank you very much, and I urge your support of Senate Bill 410.
Any questions from the committee? See none. Thank you. Jenny O'Higgins from HHS. Welcome.
I did the opposite. I did push the button, but it was the wrong way. Thank you so much for having me today. My name is Jenny O'Higgins. I'm a senior policy analyst at DHHS for behavioral health. And the department's here today to just provide some information. We want to thank the sponsors for their interest in sustaining and increasing housing options for those experiencing behavioral health challenges in New Hampshire. The department recognizes the importance of all of the concepts in SB 410 and is in agreement with the need to increase and expand housing. In the department, we did submit a fiscal note worksheet, which I do believe is attached in the online version of the bill, although it's not here, so hopefully you do have it. We just recognize that there were a couple of technical mechanical defects that, if corrected, would make the legislation more effective, and so we would like to work with the sponsors and advocates to get the bill across the finish line. We will have some need for capacity for the coordination and management of the fund and some clarifying language that's needed in order to make sure that the fund is there. There is also some potential challenge where if it's federal funds, if they're the resulting funding source, then there would likely be a period of performance limitations that would not allow the funds to be carried forward for use in future years. And the appropriation is specifically for state fiscal year 25 and not subsequent years. We're also in support of increasing those Medicaid rates, but respectfully request just flexibility to be able to work with our actuaries to determine the best use for the rate increases. And so again, we'd be happy to continue to work with folks to make sure that we can get this to be the most effective version that we can.
Thank you. Any questions?
Yeah, we're just, the one online, the fiscal note online is what we have. It's 3 million plus the 96,000.
Mhm.
Is that the updated one?
That's the correct fiscal note for the bill as written. Not, we would need to resubmit if there's amendments.
Have you seen the amendment?
No.
Just came in last night. Sorry about
Thanks. Okay. So I think there's just, I just would want to make sure with any new amendment that we would have amend RSA 612 to create the fund. We would just want to make sure we have that in there that wasn't in the previous bill as written. We were recommending that there be some clarifying language on the desired number of awards. The current language reads as 1.5 million at 25,000 max each, potential for 60 awards. Is that how you want it to come out? You had mentioned per bed in the introduction of the bill, but it doesn't read in that way today. So maybe some clarifying language there that could really be helpful. In terms of the fiscal note, though, it is correct that we were thinking one position to have the capacity to do the rulemaking and monitor the grants and evaluate the grant making and really make sure that the money can move through and out of the department to get to where it needs to be. In the state fiscal year 25, it would be assumed that we could utilize the part of that money for that position, but in the subsequent fiscal years, uncertain where the appropriation might come from.
Thanks.
Yeah. So my understanding in looking at this is that both of these initiatives of 1.5 million are in FY25. Why does the department want to have the specialist 4 position continue if it's a one-time grant initiative in 26 and 27? That's number one. And number two, for a one-time grant amount, why is a position even necessary to begin with?
My understanding of, or my interpretation of the bill as written is that it's establishing a non-lapsing fund that would carry forward funding year to year. So it would not be necessarily a one-time grant making.
Okay.
If I have misinterpreted that, then that's something we could clarify.
Yeah, I'd ask you to go back to the department because I think there's merit in the appropriation, especially for transitional housing, but to see that it requires a position to administer this amount of money seems a bit excessive.
Okay.
Any other questions from the committee? Seeing none. Thank you.
Okay, thank you.
Lisa Madden. Next is Sam Hawkins.
And for the record, my name is Lisa Madden. I'm the president and CEO of Riverbend Community Mental Health and vice president of behavioral health for Concord Hospital. So I'm here to speak on behalf of the Community Behavioral Health Association in support of this very important bill. A couple of pieces of background to just speak clinically for a moment, if I may, is to remind people of the importance of this level of housing. We see this as part of our continuum of community mental health services that helps people achieve recovery and independence in the community. We certainly support people being able to exercise their free will to be able to live near their loved ones in a community environment with supports in place that keeps them out of a higher level of care. The reality of the situation is that operating these such facilities is extremely expensive and there's limited opportunities for reimbursement. It's mainly a rent and some clinical treatment that occurs within the facility. I can give you an example. Within Riverbend, we run 3 programs right now, and 2 out of the 3 create significant deficits year over year. And 2 of them are the transitional housing and community-based housing. So for 10 residents in one facility, we lose $250,000 annually. For another residence in Boscawen, we also lose about $260 to $270 annually. We have a mission to keep those available to the community and are very committed to that. But as our resources continue to struggle and we do not have access to additional COVID supports or things along that line, it's getting harder and harder to keep them functioning. So we implore you to support our efforts to be able to keep this service available to our constituents in the community, and certainly would answer any questions about any of the details you may have.
Thank you, Lisa. Senator Whitley.
Thank you, Madam Chair, and thank you for taking my question. Can you sort of describe how the role of these 2 types of housing supports to the ER boarding crisis? I
Absolutely.
think that connection is important.
Yes, thank you for that question. Right. So what we know is that the level of acuity that enters into the emergency department has resulted in a long-standing boarding issue. And for folks who need a higher level of care to get to either New Hampshire Hospital or a designated receiving facility has resulted in long waits. Part of the challenge of being able to admit people is that they cannot safely discharge people outside of the hospital because they need this level of transitional housing support in order to safely integrate into the community. If this level of support wasn't available, they wouldn't be able to leave the hospital. In fact, my colleagues at New Hampshire Hospital say that there's between 40 and 50 people right now who could leave the hospital if they had this level of care. And we don't have sufficient resources to do that. So with the goal of Mission Zero, which we are very actively engaged in finding solutions to the problem, we need to be able to have people safely live in the community with supports. And those supports vary from independent housing with clinical supports to staffed residences that are maybe 18 hours or 16 hours a day to 24/7 opportunities, which are community-based and community engaged, which is just really important for people's choice of where they want to live.
Any other questions from the committee? Seeing none. Thank you, Lisa.
Thank you very much.
Sam? And after Sam is Carly.
Good morning. Thank you for the opportunity to testify today. I will keep my comments brief as it's been a long morning and they largely echo the speakers prior. My name is Sam Hawkins. I'm the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide. On behalf of NAMI New Hampshire, I'm here today to speak in support of Senate Bill 410. As we're all aware, New Hampshire is experiencing a crisis in the boarding of individuals in emergency departments while waiting for inpatient psychiatric services. This crisis is a top priority for NAMI New Hampshire, and there is much work to be done in solving it. One key component to addressing this crisis lies in the availability of community resources, especially housing, after a patient is ready for discharge. Every day, patients are clinically ready for discharge from New Hampshire Hospital, but are unable to leave due to a lack of appropriate housing available within the community to support their needs. This backdoor issue exacerbates the stress on the state's inpatient psychiatric resources and creates further wait for those boarding in emergency departments. Senate Bill 410 would help to alleviate this crisis and aid in providing crucial resources for the needs of Granite Staters living with mental illness overall. Solving the crises affecting our communities means strengthening the resources available to them, and this bill does just that. For these reasons, NAMI New Hampshire urges the committee to recommend OTP for Senate Bill 410. Thank you very much.
Thank you, Sam. Any questions from the committee? Computer. Thank you. Carly? Carly Hughes, she spoke on the last one. I wonder if she accidentally signed up on this one. That's.
Oh.
I found him.
Sorry.
No, Senator.
No, I'm still talking about the previous bill.
Good morning, everyone. I'm Karen Rosenberg. I'm the Policy Director at the Disability Rights Center. I am not here to take a position on the bill, but I did want to share some information that I think is relevant. As you probably know, our office generally is very supportive of devoting additional resources to enable people to leave the hospital and get treatment, people with mental illness to get treatment where they need it, and in the most community integrated fashion that's appropriate for them. And in addition to the emergency room boarding case and the that you were discussing and the need to get to zero emergency room boarding people, the state is still operating under a settlement agreement in the Amanda D case, and that is a case that was resolved in 2014, which requires the state to develop community integrated supported housing for people who experience severe mental illness. It's part of the continuum. So one thing that's a bit confusing about this bill is that it uses a term supported housing or supported community housing, which isn't really defined. That term is defined in the community mental health agreement. It's not clear that without a definition, whether this bill would advance the state's ability to fulfill its obligations under that agreement or not have any impact. I did bring copies of just the housing portion of the settlement agreement so that you can be aware of it. But generally, the way supported community-based housing is defined in the settlement agreement, it is integrated, scattered site, small housing. So transitional housing would not be considered part of the community mental health agreement. This bill isn't about that. I understand it, but I think the committee needs to be aware that there's another definition floating out there, and that the state is still going to need additional resources to be able to meet its obligations under the community mental health settlement agreement, which we're really hoping that it will be able to do at some point. In thinking about community housing, transitional housing tends to be larger, segregated housing. It's important for people who need it, but one concern we have is that without paying attention to supported housing as defined in this mental health agreement, that we're not investing enough to allow people to transition to somewhere, right? Transitional housing ought to be a transition to somewhere. So it would be really helpful for the committee to consider when there are opportunities to devote finances to this, to address this issue, to address the issue by financing the entire array of services that are needed for people. Anyway, thank you, and I'll circulate this portion of the settlement agreement for you so you can see how it's defined, how supported housing is defined in the settlement agreement, but also I'm happy to take any questions.
Any questions from the committee?
Thank you
Seeing
for your
none.
consideration.
Thank you. Is there anyone here that would like to speak on Senate Bill 410 that hasn't been given the opportunity? With that, I will close the hearing on 410. And again, I will remind everyone that we will be meeting across the street in room 100 at 1 o'clock.
The meetings, they don't
Okay. Welcome to Health and Human Services in State House Room 100. A little bit larger, a little bit colder. So we'll start the hearing on Senate Bill 319 with Senator Gannon, prime sponsor. Welcome.
Thank you, Senator Birdsell. I'm just thinking back 10 years ago, I appeared before you.
Oops, I'm sorry, Kim.
Are we ready, Kim? Sure. 10 years I appeared before you, Senator, in election law. And I thought I knew everything, if you remember, on a 14-day voting thing. And I knew everything, and I was going to tell you how to do everything. Now I come before you a much humbler person, and I know all of you have a lot of experience. So I'm looking for your help in guiding some of these bills. And I'll start there. Okay. Thank you. Again, good afternoon, Senator Birdsell and members of the Health and Human Services. My first time venturing here, I usually stay in my confines of judiciary and commerce fairly tightly, but events took place and bills came before me, which had to go to your way. So I have the pleasure of Senator Bill Gannon, pleasure of representing Senate District 23, known as the heart of the wine country. I am here to introduce Senate Bill 319 relative to vaccine and pharmaceutical products purchased, promoted, or distributed by the state and its political subdivisions. 319 prohibits the state of New Hampshire and its political subdivisions from purchasing, promoting, or distributing any vaccine or pharma product that has not been tested with voluntary human trials. There is an exception for the flu vaccine or when the governor calls a state of emergency. The bill also prohibits the state from forcing granite staters to be vaccinated during a state of emergency. Granite staters should be able to trust our government when they are told a drug is safe and effective. I would have one recommendation, and again, you can discuss it amongst yourselves later. The vaccination part was the people in my district and the many representatives in my district who wanted this bill would be willing, and they think a better fit might be to take the word pharma product out of line 3 and line 6. And so that would maybe make the bill a little more palatable to some of the interests here today. So again, so we'd only focus on vaccines. If you people saw fit to have an amendment, again, removing in lines 3 and 6 the words pharmaceutical products. And I have a lot of people behind me who are very passionate about this bill, who probably would be better to handle your questions, but I would try to handle any if I could.
Any questions?
Yes, Senator Prentice.
Senator Prentice.
Good afternoon, Senator Gannon. Good to see you. So here's my question.
Okay.
Would this prohibit, so this would only allow for, adoption or use in New Hampshire by choice if it's tested on humans but not on animal subjects? Is that what I'm hearing?
Can I bring a representative up who has been very instrumental in this bill to testify with me?
Yeah.
And she was going to testify anyways, might save some time.
Okay.
Representative Phillips, I think you're behind me.
Thank you.
The representative, it's one of her passionate bills, and so you didn't mind my calling you, did you?
No.
Okay.
Good afternoon. So I submitted a similar legislation last year on the House side. We tweaked it a little bit.
Could you introduce yourself?
Absolutely. I apologize. I'm Representative Emily Phillips of Rockingham 7, Fremont. Last year, we submitted HB 575, which is the bulk of what this bill is. We found a lot of opposition regarding the flu vaccine, and this would limit the state from distributing that to nursing homes and things like that, people on Medicaid and Medicare. So I asked him to put that in as an exemption. But to answer your question about the animals, so this would not, we want the state to not pay for things that are not tested through human clinical trials. Specifically, the bivalent booster, the COVID shot, was only tested on mice before it was purchased and distributed by the state. So that was the point of this bill, was to have a vaccine go through clinical trials prior to the state purchasing and distributing it, yes.
Okay. Follow up. So, and this could be for any, so stepping away from vaccines, this could be for any pharmaceutical product.
Yes, I proposed to the senator that we remove the pharmaceutical product terminology because another issue was it may be preventing right to try options for those who are participating in Medicare or Medicaid.
Just one quick, just my line of questioning and thinking here really, especially when it has to do with pharmaceutical products, is that I quickly, had Googled, I've been thinking about this, there's a number of medications that are used to, treat cancer patients, HIV/AIDS, Alzheimer's, hepatitis, malaria, that didn't have human clinical trials. It started with animals. So I want to make sure that we don't box ourselves into a place where these are possibilities, because there are patients in the state. Now, I know this is about what we purchase, but I just have a concern about that. I think it's off to the side right now, but it crosses in a little bit, so I'm going to continue to watch that while we talk about this legislation. Thank you.
Yes. Any other, Senator Whitley?
Thank you, Madam Chair. Thanks for taking my question. Is there, was there consultation with the medical community, with experts about what are the problems with non-human clinical trials? I'm not a physician, so I don't know if you're a physician, but I'm just curious about the evidence base for bringing forward this bill.
Well, I don't want to go over my whole, presentation for the first time around, but I've been in clinical trials as a participant. I have type 1 diabetes, so I've been constantly volunteering for things. So I know what the process is from my personal experience. No, I'm not a physician, but I do think that rushing things to market in this case is a concern when people don't realize that a product is being promoted, purchased, and distributed by the state and pushed when it's only been tested on mice. So I think a lot of people don't realize that's what occurred. So that's what I guess came before this legislation. When you're saying, did I consult with healthcare professionals? Is that what you're asking? Yes. I don't have anyone that I know of that is here right now to, there's plenty of experts behind me that are people to testify who might be able to answer more specific healthcare questions. But I definitely think it's a concern that we're testing products on our population. Thank you.
Should she go next?
I think we'll wait because she's going to speak again.
I'm happy to, yes. So I think, thank you. The senator said what I think would be best would be to amend this down to just vaccines, because I agree with you. I think pharmaceutical products is very broad. It could be, a roll of gauze could fit under that description. So I think most products are tested on animals. It's just the next step of we get to human clinical trials where it's voluntary, right? You have informed consent. That's not what occurred with the bivalent boosters. So that was the motivation behind this legislation. And this was a way to get it reintroduced in the discussion to keep going and address the opposition by putting it on the Senate side because it did not pass the House last year. So that's where we're at.
Okay, thank you. Any questions? Seeing none? Thank you.
Thank you.
All right, Teresa Bastaracci? How badly did I butcher that one?
You're fine. My name is Therese Bastarash, registered nurse here on my own to testify in support of this. I would address the pharmaceuticals for cancer patients' right to try. I believe that amendment should go through, that we're just focusing on vaccines. In my career as a nurse, I've also worked as a school nurse, and I can tell you that families, because it's coming from the government, automatically aligned a trust factor there, that this is safe and this is appropriate for their child to do, because the doctor is recommending it, because it's something the vaccine bus is coming around to the school, that it's safe, it's been tested, and it's not going to harm their children. As time marches on, we have found that we as humans don't always know everything we think we know, and we come to find out even with the best intentions, we've made mistakes. That's happened throughout history in healthcare. My concern here is that we are promoting it. We are running commercials, the vaccine van's going to be here, and we're kind of pushing this onto individuals, and they're automatically aligning themselves with the trust factor. To me, there's a liability to us as taxpayers. So as someone who's concerned with the liability to the state, I think that we are now seeing enough evidence that individuals are having turbo cancers, strokes, cardiomyopathy, sudden death, and we're aligning and we're seeing enough information to know that there's a lot of reason to be concerned that these are not indeed safe, specifically for children. My concern is that right now, if you go to cms.gov, the average reimbursement rate for each one of these vaccines is $28.39. Here in New Hampshire, if you go to usafacts.org, you will see that 1,203,845 individuals in the state of New Hampshire have at least received one dose of these vaccinations. That's $34 million. That same usafacts.org says 982,000 New Hampshire residents have probably received at least 3 doses. That's a total of $83 million that these healthcare providers have received from CMS for administrating these vaccines that have not been tested on humans, that we are now seeing catastrophic health consequences. Also, as a hospice nurse, I am seeing people go from 0 to stage 4, all within a matter of 30 days. We are seeing things we have never seen in our 15 years of career.
Could you have him close the door, please?
All right. My concern that is as we push this, as the state, DHHS, as medical professionals, people are assuming that they can trust that these have been fully vetted and fully tested. Time and time again, I've spoken to my patients with informed consent. And I said, do you understand that these have not been fully tested yet on the human body? That is the first that they have ever heard of it. So if we're going to promote this and we're going to push it, to me, any fair-minded judge down the road is going to say, you did not give full consent, a full informed consent to this mother before her child now dropped dead of a cardiac event. That to me is a liability on us here in New Hampshire. And that is something I would like everyone to consider as they think about moving this piece of legislation forward. Thank you.
Any questions?
Sure, thank you, Senator. And thank you for coming before us today. So separating out, other medications, just talking about vaccine, you just talked about consent, you giving consent at the bedside or in an office. So is it your understanding, it sounds like it's your practice, but is your understanding before any vaccination is given that informed consent takes place, or are you saying that informed consent is not taking place and that starts back with just the actual purchase of this by the state? Is that?
So informed consent is a requirement. We need to always tell a patient the risk reward of any intervention that we do, whether it be surgery, a medication, they need to be informed. And I would say that we have been lacking informed consent from the beginning when it comes to these vaccines for COVID-19. I feel we are still very much lacking in informed consent to the general public before they inject their children specifically, is my biggest concern. If someone is fully informed and they choose to do that, that's great. But we are promoting this, we are purchasing it, we're running commercials, vaccine vans, come get it, come get it, come get it. And we're not telling them that this has not been tested on humans. To me, that's a huge liability. And why would we do that? Why are we choosing not to fully inform them? Well, I believe it's because there's $83 million involved with it. And that does not feel good. Doesn't feel good at all. I take a vow as a clinician to do no harm. Whether I lose my license because I do informed consent outside of what CMS requires me to do as a nurse, and I make sure that they understand it hasn't been tested on a human. God put me in the profession of being a nurse. If he wants to take me out of it, he'll take me out of it. But I'm going to make sure my patient knows, because I don't want to look that mother in the eye 2 years from now when her son drops dead on the soccer field because his heart had a malfunction. And we're seeing that evidence. We're seeing it. And we can't just continue to pretend like it's not there. And every day we have more information to know that these aren't safe. And we continue just to pretend like that's not a reality. I believe we're going to put ourselves at liability. People are going to have a reason to sue and win that case. Because we're not telling them when I'm at the school, we're not telling these elementary children's parents that this hasn't been tested, and the risk is far greater now than without it. That's a liability, and it's just ethically not okay. If people are fully informed, I'm all about freedom. Do what you right to try, biggest proponent ever of it. But right now, the state of New Hampshire is buying these, promoting these, administering these, showing up, doing flyers, making sure everyone knows where they're going to be to get them, get free Dunkin' Donuts cards and donuts. And, you know, it's really, to me, crossed a serious line of really not being ethical towards humanity. It's very bothersome to me.
Just one quick follow-up. And I appreciate what you shared. I just want to just kind of go back a little bit on the last part. So purchasing, promoting, but then there's administration and there's the consent before that. So in terms of choice, consent has to be given, whether this is promoted or not. An individual or a parent has to give consent before they take a vaccination, and that consent should be, I'm not a nurse, but I have been a medical professional and have given fully informed consent before anything that I do. So I think that we share that in common. We might have a different view of it, but I believe that the consent is a key piece here. They're knowingly taking this.
So if we had just as much commercials and propaganda going out to go and get the vaccine, also a balance of know that this has not been fully tested and trialed in the human body, that to me is informed consent. People are by default thinking that it's been fully tested and there's no concern. And we've had people in government speak, and DHHS, to say these are fully safe. These are safe. These are safe. Nothing we do in healthcare is 100% safe. So we are misleading people catastrophically. And that's where, to me, as New Hampshire legislation, if you're protecting the citizens and you're protecting the taxpayers, this needs to be, hey, this is available to you, but it has not been fully tested, and there is risk to this. And I'll tell you, I've not seen one commercial, propaganda, anything about COVID that has ever said that. That's not where the general public land if you were to go out to the street and say, you know, do you know that this hasn't been tested on humans yet? They don't know that. We have failed. And to me, I don't think the state has any business promoting, administering, getting this supply into the hands of professionals, knowing that it hasn't been fully tested and that it's not safe.
Thank you. Any additional questions? Seeing none, thank you. Representative Yuri Polozov.
Dear Chair, committee members, for the record, my name is Yuri Polozov, representing Merrimack 10, Hooksett, and Dunbarton. And I'm very thankful for the opportunity to testify in support of this bill. It's time to follow the science, to follow the need for double-blind controlled clinical trial, because it is a gold standard of science-based medicine. Some of us may argue that the whole system of state controls, centrally planned, socialized approach in medical sector is flawed. But if for a minute we agree with status quo, should not we make sure that the medications that the state promotes are at least safe and effective? So two scenarios. Base case scenario, when we do not follow the science of clinical trial, we simply waste resources. When we promote something that does not work, we deny the needed resources where they can make difference. We have shortage of nurses, hospital beds, even some antibiotics, but the funds are wasted. We're supposed to have separation of religion and state. Unfortunately, new quasi-religious beliefs are guiding state expenditures. We were said, we believed that COVID vaccine will stop the transmission. Based on what? There was no clinical trial for transmission. In worst case scenario, the refusal to do clinical trials kills our constituents. Was it a good idea to wait to the late stage of COVID and then put patients on oxygen ventilation? Without science-based clinical testing for safety and efficiency, this policy killed many people in New Hampshire. This policy was promoted, resources allocated, hospitals were receiving bonuses for putting people on ventilators, and censorship and suppression. We had some of the smartest doctors. They knew to start antiviral treatment early. They knew to fight cytokine storm in lungs with anti-inflammation medications. They knew to try monoclonal antibodies well before the federal government nationalized it. But those doctors were silenced because we followed unfounded beliefs and denied safety for clinical trials. And also answering some of the questions, I have a degree in biology, and when we do clinical trial, even between different populations, like based on race, we can have different side effects. So of course we want to do it on human because even if we do it on monkeys, on pigs, like side effects could be different from what we will see when we apply it to humans. So please support this bill if you believe in science-based medicine. Thank you.
Any
And
questions?
I'm ready if any questions.
Any questions from the committee? Seeing none, thank you. Representative Jason Gerhardt. And go ahead, sit down. Let me just say that please, if you're going to have a conversation, please take it outside. It is distracting to our recorder. Thank you.
Thank you. Committee, my name is Jason Gerhard, represent Northfield Franklin, Merrimack 25. And I'd like to address the fiscal note on this bill. It's not on this page, that was outside, but online it's attached. And specifically the last sentence, the Department of Health and Human Services. The department anticipates that if the bill is enacted, there may be an indeterminable increase in Medicaid and other healthcare costs related to an increased number of COVID cases. I am unaware of any data that would support that, and I'm curious as to where that came from, because as far as I can tell, the number went from 100% effective to much lower. So I don't really know where that number's come from. I'm concerned about that, and specifically now back to the general basis of the bill. I think it should be pretty evident that testing on humans is important for instituting a medication among humans. So just kind of putting common sense out there, and that's all I wanted to say. Thank you.
Thank you. Any questions from the committee? Seeing none.
Thank you.
Ryan Tanyan and Ben Chang. Welcome.
Good afternoon, Madam Chair, members of the committee. I'm Dr. Ryan Tanyan. I'm a registered pharmacist and chief of the Bureau of Infectious Disease Control with the New Hampshire Department of Health and Human Services and the Division of Public Health Services. I'm joined here with Dr. Benjamin Chan, who is the New Hampshire State epidemiologist and an infectious disease physician. In addition to the written testimony provided, we are here to speak in opposition to Senate Bill 319. If enacted, Senate Bill 319 will have potentially wide-ranging negative and unintended consequences for the department, other state agencies, counties, cities, towns, schools, and many other partners. The department does not believe there are any vaccines or other pharmaceutical products that are currently purchased, promoted, or distributed by the Department of Health and Human Services that are not supported by human safety and efficacy data. To do otherwise would be unethical and outside the medical and public health best practices. And there are federal regulations and requirements ensuring pharmaceutical products are safe and effective before making it available for healthcare providers to prescribe or administer, and before they are recommended by the Medical Advisory Committee on Immunization Practices or other relevant expert advisory committees. We believe this legislation is unnecessary. It opens the department to legal action if someone were to interpret this legislation differently or misunderstand or misinterpret the science, which is also included during the regulatory process. Senate Bill 319 is unclear and lacks sufficient detail to know what is intended by requiring human clinical trials, since there are different types of studies, clinical trial designs, different measurable outcomes, different ways to evaluate product effectiveness, and furthermore, Senate Bill 319's vagueness does not define the level of evidence that's required. For example, some routine childhood and adult vaccines undergo periodic updates, but there are not necessarily new clinical trials to reevaluate vaccine efficacy. Rather, vaccine efficacy can be inferred by comparing immune system responses to the old versus the new or updated vaccine. The most significant consequence of Senate Bill 319 as introduced is that the department and other governmental or quasi-public partners may not be able to purchase, promote, or distribute potentially many different routinely recommended and life-saving vaccines or other medical therapies, depending on how someone interprets the requirement for clinical trials, human clinical trials. This would negatively affect the patients and staff, including those at county nursing homes or correctional facilities, the New Hampshire Hospital, Glencliff Home, the New Hampshire State Veterans Home, and the Manchester and Nashua Public Health Departments. This is contrary to the mission of these individual organizations as well as the department. The department believes this legislation was proposed because of concerns regarding the annual updated COVID-19 vaccines. However, we now have almost 4 years of extensive data and real-world experience with COVID-19 vaccines, which supported their approval by the United States FDA and recommendation by the Advisory Committee on Immunization Practices. The updated COVID-19 vaccines have followed a process similar to the approval and recommendation of annual influenza vaccines, which are exempt in this legislation. It is likely any future vaccines that require annual or periodic updates would follow a similar process. Senate Bill 319 is likely to have a negative and unintended impacts on future vaccines or other pharmaceutical products, including combination vaccines. The department also believes, if enacted, Senate Bill 319 will likely lead to higher patient costs for some childhood immunizations, where currently the New Hampshire Department of Health and Human Services is able to purchase childhood vaccines at a reduced cost through our Vaccines for Children purchase program, so that participating healthcare providers and families can receive the vaccine products of their choice at no cost. If the department and other partners are unable to purchase, promote, or distribute certain vaccines, then costs to individuals, communities, and the overall healthcare system will increase. As stated in previous testimony, the department does not intend to make COVID-19 or influenza vaccinations a requirement for school or child care attendance. However, it is available through the New Hampshire Vaccines for Children program for families that wish to provide maximum protection for their children. An additional unintended consequence of Senate Bill 319 is the impact on an FDA provision known as expanded access, also referred to as compassionate use, which some were referring to and alluding to earlier. But again, just to reemphasize, this is a mechanism that allows patients with serious or immediate life-threatening diseases and conditions. They then have access to medical products, including drugs or biologics, medical devices, which may be outside the scope of the clinical trial after they meet a defined set of criteria. These products are undergoing clinical trials, but in a desperate situation, they can be used under the compassionate use provision when no alternative therapy options are available. Examples of some conditions folks talked about earlier, cancer, but to add in others, we have muscular dystrophy and ALS that are oftentimes we see compassionate use for products or therapies related to those conditions. Additionally, Senate Bill 319 specifies voluntary human clinical trials, and DHHS is unable to identify a definition or reason for such a provision. As mentioned previously, there's federal law in place, including 21 CFR section 50.20, where use of involuntary human subjects in clinical trials is prohibited and considered unethical. It's important to note that Senate Bill 319 is also identical to the previously introduced House Bill 575 from the previous session, as was also mentioned earlier. However, this version of Senate Bill 319 does include the exemption for the annual influenza vaccine. Last session, House Bill 575 was found to be inexpedient to legislate by both the House Health and Human Services and Elderly Affairs Committee and on the floor of the House on March 23, 2023. To summarize, the department is opposed to Senate Bill 319 for reasons similar to House Bill 575 from the 2023 legislative session. The language remains vague and the intent is unclear, and it will negatively impact the health of New Hampshire children and adults. If passed, Senate Bill 319 will likely lead to decreased access to vaccines and other pharmaceutical products and increased healthcare costs. The American people are protected by an existing robust federal system that continuously uses rigorous scientific methods and evidence to ensure that drugs, vaccines, and other therapeutic products work correctly and that their health benefits outweigh their known risks. Senate Bill 319 introduces undefined barriers to ensuring life-saving vaccines and other therapeutics that are available to all who wish to access them. We want to thank you for your time, and myself and Dr. Chan are here to answer any questions that the committee may have.
Thank you for your testimony. Just a couple of questions, if I may, Madam Chair. You talked about unintended consequences, but it seems to me that when the mandates came out that people had to get the vaccine, or you couldn't work in a hospital because it was going to spread the disease. If you're not vaccinated, you can't work. That was an unforeseen consequence. Do you stand by the fact that if you're not vaccinated, you're more likely to spread it than if you are vaccinated?
Yeah, Madam Chair, members of the committee, thanks for taking our testimony and for these questions, Senator Avard. I'm sorry, I'm just gathering my thoughts.
I can repeat it. I mean, it basically, people lost their jobs, their livelihoods. We kicked out of the military. We lost a third of our medical workforce because people weren't being vaccinated on the premise that if you're not vaccinated, you're going to spread it.
Mm-hmm. So I think there's a couple responses there. The first is that the state, the New Hampshire Department of Health and Human Services, did not require the COVID-19 vaccine. What you're referring to were policy decisions made at the level of individual healthcare organizations and healthcare institutions. So we're not in a position to be able to comment on those policies. Regarding, I think your second point, though, is around the effectiveness specifically of the COVID-19 vaccines. And the efficacy of these vaccines have changed over time and have changed as new variants have emerged. And so, yes, there was evidence early on that the COVID-19 vaccines were effective at preventing infection, were effective at preventing transmission, were effective at preventing hospitalization and death. And what we have seen over the course of the pandemic was that those vaccines became less effective at preventing infection and transmission. I'm not saying not effective at all, but less effective. And so the focus for recommending vaccines, the COVID-19 vaccines in particular, has really been around preventing severe consequences of disease. So preventing hospitalizations, preventing deaths. And in fact, with the new updated annual COVID-19 vaccines this year, there are studies now emerging showing that these vaccines, putting numbers to it, 70-75% effective in the short term at preventing hospitalizations. That's new data that's come out over the last week relative to the new updated COVID-19 vaccines. So again, just to reiterate, we at the department have not required the COVID-19 vaccines for anybody. And that the data consistently shows that the vaccines are effective, particularly at preventing more severe outcomes of disease like hospitalization and death.
Thank you, Madam Chair. With regards to informed consent, I can't help it. Every time I see a commercial, I just saw one the other day, and we had to laugh. It had to do with, I believe, Alzheimer's. And that's not a funny subject, but the fact is, well, if you take this, the side effects are death. You got beautiful music going on in the background, and everybody's smiling, you get flowers, sunshine beaming coming in, but you're informed. You know what a possible side effect is. And then I went down a long laundry list of other things that could happen. Now, with the COVID vaccine, if you will, is there a list somewhere of the side effects that so that people can make an informed consent on, hey, what's in it? Has it been tested on humans? And what are the side effects? Thank you, Madam Chair.
Yes, thank you for those questions. So I want to reiterate what Dr. Tanian said earlier. Right, the scope of this proposed legislation really is around requiring human clinical trials. And I just want to be clear that we do not believe there are any vaccines not supported by human clinical trials showing human safety and human efficacy. You can look at any package insert, the vaccines all come with package inserts, including the COVID-19 vaccines, and you can look at any package insert for a vaccine and see outlined in that document all of the human clinical trials which support both the safety and the efficacy and have instructions for clinicians and guidance for clinicians around how to counsel patients, what are some common side effects, and it outlines all of the studies that were used in the approval process for making that vaccine come to market. That includes the COVID-19 vaccines, and so in those package inserts are listed all of the human clinical trials over the last years, 3-4 years, that back the approval and recommendation of that vaccine. And part of what we are concerned about with this legislation is that it's vague and unclear what it means by human clinical trials. And as you're hearing in the testimony, there's obviously disagreement on what level of evidence and what level of data is out there to enable us to promote, distribute, purchase these vaccines. And so Senate Bill 319 doesn't actually resolve any of these disagreements or these conflicts, right? So when I read a bill like this, I have a lot of questions. What level of evidence is required? What type and what quality of studies are being required before we can, promote a vaccine? What clinical outcomes should be evaluated in those studies? What type of analyses should be performed to show that a vaccine is effective? What even qualifies as a new vaccine requiring a whole new set of, clinical data? So Senate Bill 319 doesn't actually address any of these questions, these issues, nor is it, I think, practical or desired to legislate that level of information, particularly when there's already a robust federal process that outlines all of these details and all of these requirements that vaccines have to go through before they're approved by the FDA and ultimately recommended by the ACIP. Part of the reason or part of the concern is that this bill also creates a double standard, right? Flu vaccine is exempt in this but COVID vaccine isn't. Well, flu vaccine and COVID vaccine go through the exact same process and the exact same requirements in terms of level of science and level of data that are required for an updated, not a new vaccine, but an updated annual vaccine to come to market and be recommended. But this legislation essentially creates, two different standards for, what we can purchase, promote, distribute for updated vaccine products.
Follow-up. And thank you, Madam Chair. Just a quick follow-up. So would you mind just providing the committee a typical sample of an informed vaccine for the COVID? Just, any document that says all, the procedures, what's in it, how it's been tested and all that. If you could send us something like that.
Yeah, so any vaccine that is administered has including COVID vaccines, have a vaccine, what we call a vaccine information sheet, or VIS. That was the case all through the pandemic when the vaccines were being made available. And the purpose of that supporting documentation is to inform primarily patients and to assist providers in that informed consent process so that before they get the vaccine, the patient is given the vaccine information sheet. And those VIS statements, I haven't looked at one recently, but with COVID-19 vaccines included all the typical common side effects and included also the concerns, I believe, about myocarditis, the rare occurrence of myocarditis associated with COVID-19 vaccines. So those types of supporting materials are out there and are available online through the FDA website, through the vaccine website. So that's a common tool that's used in the healthcare setting for obtaining informed consent.
So you don't mind sending us one?
Certainly we can, yes.
Any other questions from the committee? Seeing none, thank you very much for your testimony.
Thank you.
Janet Hutula. Welcome.
Thank you, Madam Chair and committee members. My name is Janet Hudula, and I'm from Londonderry, New Hampshire. And I'm a person that you're talking about. I am unable to take almost all vaccines. And I have, and it's not just me, I've got it in my family. I don't know why, nobody's ever figured it out. But I'm allergic to most antibiotics as well. So I have to be extremely careful. I'm now 74 years old. I've been aware of this since I was about 9 or 10. And subsequently, the rest of the family got aware on my mother's side. I cannot take a vaccine. My doctor won't even give me some, not even a tetanus shot that I asked for one time, because he was fearful that I would die. When COVID came out, I had to do my own due diligence. Fortunately, I have help in that. I have a neighbor who's an ICU nurse, and she worked at a hospital throughout this time. She was threatened to lose her job. Her husband worked for Raytheon. He lost his job, but they showed me things, as one of the committee members were asking, because I wanted to see what was in COVID. So initially, when the COVID came out, I don't know if it's changed, but there was nothing in the description list of what was in it. Also, I learned that one of the testing packages, if you have it, that came from China, had a cancer-causing disease in it. I really want to see this tested on humans that can take vaccines before I get forced into having to take it and not be around, okay? My mother lived to 93, so did my grandmother, so I think I have another 20 years in me. All right? That's all I wanted to share.
Thank you very much. Any questions from the committee? Seeing none, thank you. Julie Smith. Julie?
Good afternoon, committee. First, I find it astounding that anyone can take an oath and keep their oath and oppose this bill, especially from a high-ranking position. But be that as it may, I support this bill. As a layperson, I always intuitively knew what was wrong with receiving an injection with no historical data. Think of all the experimental medications that are not covered by Blue Cross simply because of their status. Why should vaccines get to play by different rules? And as for the state purchasing them, the taxpayers are the ones paying for them rather than private insurance, thus making we the people the customers. Private businesses make decisions based on sound logic and view purchases as investments after a thoughtful cost-benefit analysis. Political subdivisions, I saw that word in the language. Political subdivisions. I am a taxpayer and I live in a frivolous city that spends big money just to please or enrich certain groups of people rather than based on financial prudence. Purchasing vaccines without plausible historic data is a departure from the traditional private sector business practice. And I want to remind the two swing voters that government is a business and should be managed as such. So please vote to pass. And thank you for the time.
Thank you. Any questions from the committee? Seeing none, thank you. Dorcas Kirsch.
It's hot. Hi, thank you. Oh, I wasn't expecting to speak, but I'm coming from this in another perspective. I see it from the spiritual side, that we know that Satan is a liar, a thief, and a murderer. And I wondered for many years, well, you know, why are we here? What's going on? Until I came to a point where I found Jesus. I cried out to him to know that we're here to lift up his name, to live through the words of the Bible. I've got this, I'm a born again evangelist. I go around sharing Jesus. I love Jesus. Jesus is real. And I'm hearing people talk, and it's like saying things that aren't true. God tells us what we are. We're liars, we're thieves, we're rebellious. And until we come to that point where we seek forgiveness, this world isn't going to change. I think what's going on, I thank God that all this is happening, that people wake up. But Jesus, there's a heaven, there's a hell. Jesus came down. We're all sinners. The sin virus is the one that's going to kill us, not the coronavirus. The sin virus is going to pull us all to hell. And Jesus came from heaven down here to pay for our sins. We're all sinners. We all need a Savior. And Jesus is that Savior. And I just ask people, open your Bibles, read the good book. And let's stop playing these games. Thank you.
Thank you. John Bodwin, Sr. Welcome.
Hello, thanks for having me. It's not that far, Massachusetts, hour and a half. So I plan on moving here, making New Hampshire my home. I plan on dying here. About 20 years in Connecticut where I grew up, and then about 40 years here. So I know time is short. Let me get to a few things. Before I speak about what I wanted to speak about, let me address the epidemiological aspect that was given testimony a few minutes ago. So when somebody says no vaxxers aren't human trialed, okay. Some were trialed on the most healthy people, and there were a few people. What he's not telling you is, were they trialed on babies? How do we know they're safe for babies? Were they trialed on pregnant women? Were they trialed on people with clotting disorders, Alzheimer's, dementia? I'm going to get into some data that will tell you some numbers on those in Massachusetts. Also, flu and COVID differences. He said, oh, there's no differences between the trials. Well, then what is EUA for? Emergency Use Authorization. Why did it skip all the trials? So there are differences. So there's a disingenuous testimony that was given prior to me. I think you should consider. Okay, so I'm a systems engineer. Made my career in putting large contracts together. So I understand various systems, not just engineering. So I have an MBA also. I put together the MK6LE, that's the Mark 6 guidance control system for the Polaris nuclear missile. It's about $1 billion that came from that deal. I was told not to do it. I did it anyway. And they pulled together Raytheon, General Dynamics, Lockheed Martin, Northrop Grumman, Honeywell, and the prime contractor with whom I negotiated, Draper Laboratory in Cambridge, Mass. The reason why I can understand statistical methods that are used is because I used to use it against people in winning contracts. And the methods that are being used to tell you that these are safe and effective are, well, I was born in Hartford, so let me just quote somebody from Hartford, or at least his house is there, Samuel Clemens. There are three kinds of lies: lies, damned lies, and statistics. And they're fooling everybody with all these. Not everybody, they won't fool me. So here's some real data that I got from Massachusetts. I have 1 million unredacted death certificates, about 500,000 from Massachusetts, 420,000 from Minnesota, and the balance comes from Vermont. I'll just talk about Massachusetts for a minute. As far as safe and effective goes, I traverse the hierarchy of data and evidence from the individual case, that's a single death certificate, all the way up through all cause, which is the highest level of hierarchy. So all cause deaths, yes, they were up quite a bit in Massachusetts in 2020, but they were also up in 21 and 22. All of a sudden, the causes of death that were causing the excess death shifted from a respiratory seasonal virus. So you have pneumonia deaths, ARDS, COPD. They were up in 2020. Well, what happened on a year boundary when the vaccines were introduced? Everything shifted to blood and circulatory. Blood and circulatory deaths all of a sudden started going up. They didn't go up when COVID was around in 2020. They all of a sudden started going up in 2021. Acute post-hemorrhagic anemia, thrombocytopenia, cardiac arrhythmia, cardiac arrest, pulmonary embolism. And I can tell you about the individual cases. Cassidy Baraka from Groton, Massachusetts, was injected in January 13. There's a report written about her. She reacted in 5 minutes, vomited for 8 to 10 hours. Cassidy died on January 18, 4.5 days later. You know what it says on her death certificate from Massachusetts? Complications of coronavirus 19 viral infection, with no mention of the vaccine. Those are multiple federal felonies that the medical examiner, Stephen Schwartz, committed on her death certificate. A couple days ago, it was referred to the Attorney General of Massachusetts for criminal investigation. That's just one. Breonna McCarthy. Oh, Groton is right on the border of New Hampshire, by the way. So is Methuen. Breonna McCarthy. She reacted in hours with a headache. She went to the ER. They said, go home. You have a headache. It was so bad, she went to the ER again. They said, here's some Tylenol, go home. She didn't recognize her sister. So her family brought her in. She had intracranial pressure. They cut a hole in her head, did a craniotomy. That didn't work because the clots were all through her head. They kept her on life support for a while after she had had a seizure, paralyzed in half her body. And it's about 2.5 weeks before she died. And that was she was injected on March 30, 2021. And she died on, I think, April 15. This is the official date of death, but she was brain dead in a few days. I just talked to her father a few days ago. So you would think a stroke like that killed her would be rare. In fact, it says it in the summary that 6 doctors from the Harvard Medical College, Beth Israel Deaconess Medical Center wrote about her. That's in the Neurohospitalist Journal. the title of which is Fatal Post-COVID mRNA Vaccine-Associated Cerebral Ischemia, translated to English means the vaccine killed her by stroke. Every paragraph in that report says the vaccine killed her by stroke. In fact, it says where thrombocytopenia is frequent. But in order to get published in a peer-reviewed journal, because the journals are all captured by pharma, you have to write in the conclusion that's extremely rare. They also wrote there are several reports of several vaccines, COVID vaccines, causing these clots. 2 weeks before Brianna was injected, Diane Dubois, 62 years old, died of acute intracranial pressure in the setting of thrombocytopenia. It says it in her death certificate, but it's not coded by the CDC, because the CDC, they have a software called Transaction Acme. It automatically reads the death certificate, the English words, and converts it into codes. And the codes, they're international cause of death codes, ICD-10 codes. Those codes are the only way that the public knows what's going on, because that's how you track data. Nobody's reading all the words that are in the death certificates. Solomon Kizito died at 62 years old in Massachusetts on January 16, 2021. Idiopathic bronchopneumonia in the setting of thrombocytopenia in a person vaccinated recently. So it says it, and it's coded. Y59.0 viral vaccines, T88.1, other complications from immunization elsewhere not classified. The CDC, however, says that nobody died from the vaccine. We don't have any reports. Yeah, because they turned off the software after that. And the next 8 from Massachusetts that say, I'll look over here because you guys are engaged with me. Thank you. The others are, let's see, reacted to the vaccine in 5 minutes, didn't make it out of the clinic, dropped dead from cardiac arrest. That was not coded by the CDC. This is felony federal fraud omission. And there's a number of 18 U.S.C. 1343, 241, 242, 1035, 1040, I could go on. It's also murder, because what I should tell you guys, you all probably already know this, as officers of the courts of New Hampshire, you have a legal duty to act on information and belief that the public is in danger. And knowing of this fraud, and I do have a document called the CDC Memorandum, it'll be published once I redact the names from certain names from Minnesota. The other names will be in there. You can have the official copy without name redactions. It'll be served to the directors of the CDC, FDA, NIH, 12 of their underlings, 6 state attorneys general, and perhaps Mr. Formella would like it too. I'll be happy to drop it off. I met with him. Representative Polosov and Gerhard brought me in. I spoke with Attorney General Formella for 45 minutes. It was supposed to be a half-an-hour meeting. They extended the meeting. It went pretty well. They understood. This was March of last year. I showed him the likely deaths of New Hampshire residents who died in Massachusetts hospitals. I have all their records, first names, middle names, last names, parents' names. When somebody from the state says this is safe and effective, oh no, he didn't say that. He danced around the question, I forgot. He wouldn't answer your direct question with a yes or no.
Please don't refer to other people's testimony, just yours.
Oh, okay. Thank you. Sorry about that. So this bill, 319, is a good step forward. It's very important because drugs should be tested before they're given. I'm deaf in one ear. I have been since I was 4 years old. They gave me a shot of streptomycin and penicillin mixed together for the Hong Kong flu. I didn't have the flu. They wanted to make money on a shot. So they gave me a prophylactic of antibiotics without me having anything. And they found in 1968, you cannot mix streptomycin and penicillin. It makes small kids go deaf, so thousands of kids went deaf. I'm lucky I have one ear since I was 4. Now, I mean, who cares about me? I'm 59. I'm running to the end, right? But we got kids getting injected. I told you about Cassidy. Brianna was 30. Oh, by the way, on Brianna's death certificate, it doesn't say the vaccine killed her. It said COVID killed her. They lied again. It's double fraud. Fraud by omission, fraud of commission. So you have to ask yourselves, are you here to support the people or the pharma companies? And do you have a legal duty to act for the safety of the people of New Hampshire? And that's what this bill does. It acts for the safety of the people of New Hampshire. Now, I know I only have a few minutes. I'm probably running to the end of your patience with me. I do appreciate your time. Nobody in the world has the data that I've compiled. Kevin McKernan is Chief Science Officer at Medicinal Genomics, also ran the Human Genome Project at MIT. He gave testimony at the World Council for Health. He said there's one guy in the world who has the data to show this, and that's me. Secondary malignant neoplasm of the lymph nodes, ICD-10 code C77.9. It's up 400% of normal in 2023 in Massachusetts. You've heard of the term turbo cancers probably being caused by these vaccines. You may not know the reasons. There's a theory behind that. The SV40 promoter, that's been found by and verified by 10 labs internationally. The simian virus, it's a plasmid. It's a piece of protein that was found. It's not supposed to be in there. It's contamination. They're shipping contaminated products and injecting people en masse. And it could likely cause cancers and other things. I mean, I can tell you the whole blood system is dysregulated from hematopoietic cells, which lead to the creation of every type of, thrombus. I'll try to use regular words. Platelets, red cells, white cells. Okay, it's the basis for all of them. When you get a dysregulation at that level, that's why you're seeing so many different systemic problems in the body where people say, well, it can't be from the vaccine. There's so many different things. No, it's really just one or two things, but it manifests in other things because the blood goes everywhere in your body. So I have to end at some point. This bill is actually the first step, and it's great. But if anybody wants to talk to me after, I'm willing to talk at all times. And I have talked for 4 hours straight. If you type my name into the Rumble search bar, 70 videos will come up. I've been interviewed on podcasts around the world. I've presented to doctors and scientists around the world, thousands of them, and no one has refuted my findings and data because it's just truth. I don't do statistics. They're not statistics. You know, Ian was in Bellingham, 11 years old. He got the vaccine, got a booster. This was November of last year. No, the year before, sorry, 21, 2? I'm getting confused, 22. Anyway, he died on December 3rd. The family donated his heart. They pulled it out. They couldn't use it. It was full of clots. To not care about an 11-year-old child and to listen to testimony like that and just not pay attention, it kind of blows my mind that people can do that. So thank you for your time.
Thank you.
And any questions?
Any questions from the committee? Seeing none?
Not at this time.
Thank you.
Thank you.
We only have two speakers left. Catherine Kindop. I'm sorry?
There's another sheet outside.
Good afternoon. My name is Catherine Kendop, and I'm the administrator at Maplewood of Cheshire County. So, dear chairperson and elected officials, I do thank you for your time and listening to and considering impacts that this proposed legislation brings to our operations and our citizens of New Hampshire. Today, I speak in opposition to the Senate Bill 319. Each county owns and operates a county home. COAS has two. And the impact of any legislation that prohibits the state and its political subdivisions, which includes counties, can have direct impact on the operations of county healthcare facilities, such as our county nursing homes and our county-run assisted livings. In addition to state laws, nursing homes are subject to many federal rules and requirements to participate in funding from Medicaid and Medicare. As such, many rules are set up by CMS, Centers for Medicare and Medicaid Services. One example of such a rule that would apply to this proposed legislation includes that CMS requires nursing homes to educate residents and staff on certain vaccinations. We are furthermore required to assist staff in obtaining certain vaccinations. This past cold and flu season brought a new twist to nursing homes from our pharmacy providers. We were required to purchase certain vaccines for our residents, administer them, and then seek reimbursement. During the public health emergency, our pharmacy providers had helped us to procure, provide, and in most cases, administer the COVID-19 vaccinations, and they would apply for reimbursement. However, this past season was different. Regardless of the beliefs of any one worker, we are compelled to seek the interests of our residents or coworkers relative to certain health considerations, such as vaccinations. And regardless of our beliefs, we are required to educate, provide, or assist, and at times administer certain vaccinations. This proposed legislation would only serve to complicate an already overregulated nursing home environment in the counties, such that we would have to additionally research the background in testing methods used per the language proposed. What is concerning has to do with the not being able to purchase, which we may be federally required to, or worse, not promote, which can be subjective. Having personally talked with all of my staff in early 2021, when the initial COVID vaccination was becoming available, it was very evident that subjectivity as to education versus promotion will always be a factor. And such language in this proposed rule can call this into question, for which there may be no agreement by opposing parties in a matter of vaccinations. We're in the business of taking care of our vulnerable elders in nursing homes in our counties. We must navigate many rules and regulations. Please do not bring additional laws, such as adding this language that will put respected health facilities at odds between state law and federal sets of rules and regulations that, when imposed, can cause harm to our reputations, as well as levy significant financial penalties up to and including termination of payments from Medicare and Medicaid, leading to facility closures. Thank you for your consideration.
Thank you, Catherine. Any questions from the committee? Seeing none, thank you. Second to the last speaker, Russin Chester. And Russin, before you speak, I just want to let everyone know that we did indulge a little bit, but sniping at others' testimony is unacceptable and will not be tolerated here. Thank you.
Thank you, Madam Chair. Thank you, committee members. My name is Roseanne Chester. I'm a resident in Bedford, New Hampshire. I'm also a vaccine survivor. It was not the COVID-19 vaccine. I fortunately was injured by a flu vaccine 6 years prior. I had Bell's palsy for 8 months. There were 7 other in my group of 73 that all developed Bell's palsy that year. None of us were first-time flu vaccine recipients. We worked in a situation where we had no choice to continue our employment. We had to have the flu vaccine. The flu vaccine was given with informed consent. What I found after becoming a victim of Bell's palsy is that the flu vaccines, unfortunately, they change every year. So it was most likely that we were allergic to one of the non-active ingredients in the flu vaccines. One of the things that's happened with the vaccines over the years is that we have needed to find ways, for whatever reason, to be more cost effective. So we are putting so many poisonous things to the human body in our vaccines. However, they're safe and effective because they're supposed to be at a small enough level. But there are a lot of absolutely horrendous things in our vaccinations, all of them, all of our children's vaccinations, everything. There are things in there that if I were to tell you the common language, you would say, that's poison. Yes, it is. But as long as it's done in a low enough percentage, chances are you'll be okay. That should not be okay. I listened to the testimony, and I'm concerned that sometimes we hear what everyone says, and we put certain weight on different individuals' testimonies, and that's not okay. One of the things that I decided to look up was, because a lot of folks here earlier talked about oath of office. I took an oath of office. I was a psychiatric social worker prior to COVID-19, and I now am a private person who helps people who feel that somehow they have violated their oath of office. But the one thing I wanted to bring to your attention is the fact that we don't always know, as lay people, who we assume that our politicians are there to protect us. Our government is there to protect us. We assume that our doctors and our teachers, they have our best interests at heart. It's not until we look underneath and said, okay, instead of thinking about what the doctors and the medical professionals said today, let's take a look at the people that opposed this bill and their positions in our lives. I know I've always put a lot of weight on my pharmacists' decisions and recommendations. Pharmacists do not take an oath of office, swearing to do no harm. So I wanted to bring that to you folks' attention, because I think it's important sometimes that we put too much credit on the people that stand up here, the lobbyists, the pharmaceutical companies, the administrators. You know, they didn't take an oath of office. Don't we ever wonder why? Why do the only people that oppose this kind of thing are the ones that stand up here and say, I represent? But the people themselves who took that oath don't come forward. And I think that's really important. And the other thing I want you folks to take away is that all the testimony that I heard today, the biggest issue is buyer beware. And that's not okay. We, as a state, as legislatures, we should never put our citizens in a position where they should have known better, because that's what's coming. We've seen it. I've had 30 people since January 1st die from sudden death. That's not normal. 30 people that I know personally, that I've met, that I've interacted with. That's not normal. I'm 63 and it's still not normal. It's time to start looking at things and saying, there's something not quite right here. Thank you. And I'm open to take any questions or.
Any questions from the committee? Seeing none, thank you. Last speaker is Tara Hafey.
Hi, thank you for having me. I'm here today to speak as a mom of a girl who has a severe vaccine injury that was due to the COVID vaccine. And she graduated high school in 2021, and almost every child that graduated high school in 2021 was mandated by their colleges to get the COVID vaccine. She was going to an out-of-state college. Because of that, we delayed as long as we could. We were nervous about her getting it. She got the COVID vaccine on August 4th, and within a few hours, she was admitted to the hospital, where she then was admitted into ICU. She spent the rest of that week until the weekend in the hospital. When she came home, she
was unable to really walk unassisted. Her heart rate would spike. She was dizzy. She's approximately 5'2", weighed about 110 pounds. She lost 20 pounds after the vaccine. When she received that vaccine, she received no informed consent, no document that explained what the issues were. She also received an adult dose because she was 18 years old. She was 5'2", 110 pounds, and received the same dose as a 6'4", 250-pound male would have received. There were no clinical trials that differentiated that information. Because of that, it's been 2.5 years, and she is still recovering, and our family's lives have been forever changed. I'm here in support of this bill because I don't believe any vaccine should be on the market without full and clear, double-blind, placebo-based, multi-level clinical trials for the safety of everybody, especially our young kids. On top of that, my daughter has now gone on, she wants to be in the medical field. She now has an exemption from all and any vaccines. However, even though New Hampshire may not mandate it, other states may not mandate it, it may not be mandated in hospitals and medical professionals, our college students who want to enter clinicals are required still to get these vaccines. They are not protected because we continue to say these vaccines are safe and effective. We continue to say that this is what's needed to protect others. So I'm here because I support this bill. I don't think it goes far enough, but I'm here in support, and I wanted to share a little bit of our story so that people can understand it's real people who are being affected by this. So your decisions matter.
Thank you. And thank you for your story. Any questions from the committee? Seeing none. Thank you. Tara was our last speaker. I will say that on the sheet that I have, we have an additional 6 in support and 3 in opposition. With that, I will close the hearing on Senate Bill 319. And when Cam is ready, we'll move on to 351. What?
I said you're like judiciary, you're gonna go really late. Maybe not. I'll be quicker. Some of those.
Okay, I will open the hearing on Senate Bill 351 with the prime sponsor of Senator Gannon.
Thank you, Senator Birdsall. It's good to see you all again. I am Senator Bill Gannon, representing Senate District 23. I'm not going to read my testimony. I'm going to wing it because I think at this point in life I should be able to talk to you rather than read testimony. So it might be a little weaker. Sorry, Tricia. Right now, which I'm talking about a Back to Work Act of 2024 is what I'd like to call it. So right now, under federal law, I'm only talking about a very limited area to begin with. I'm talking about able-bodied workers and they have no dependents. So for your family, you're older, this only is 18 to 49-year-olds again. And so right now, you can get food stamps as long as you're willing to. Under federal law, you're required to work 20 hours a week. You could volunteer, you could train, you can be going to school. That'll count as your 20 hours. The problem is the economy is really good and there's lots of jobs out there. And New Hampshire is one of the states that keeps going for exemptions. And so our DHHS in 2022 exempted the entire state from the Able-Bodied Workers Without Dependent Act. So you didn't have the requirement of meeting those 20 hours at all. And our state is doing it by they look at the federal rate, which is about, I knew it in December, but it's about 3.4% unemployment. So if you were in an area that's 20% higher, 4%, then you could get an exemption. The problem with that is when we went from 6 to 5 to 4 to 3, there's always going to be large areas that are going to be within 20%, even though unemployment gets closer to zero. We're still giving it to people who probably shouldn't be on it. I take, for example, Maine in 2014, Governor LePage implemented an act that they weren't going to do the waivers anymore. He went from 14,000 on again, these are able-bodied workers without dependents, 14,000, and a year and a half later, they were down to 3,000 when they required the Work Act. So I think due to the state of the economy, our jobs are going unfilled in New Hampshire. We should be getting people back to work and encouraging them to do so. This has been implemented in many states, Florida, Texas, many other states, and it's found to be successful. So I would like us to follow suit with these business-friendly states and do the same. Thank you very much.
Any questions from the committee? Seeing none? Thank you.
Very good. Thank you.
Brian Clark, Debbie Sorley, Sorley. DHHS, welcome.
Good afternoon, all. Brian Clark is not available, but I am Deb Sorley. I also was going to represent with him. I'm with the Bureau of Family Assistance at the department. Brian, unfortunately, is over at LOB at a conflicting hearing. So I have the department's stance. I am also here to answer any questions that you may have at this time. Basically, what Brian had prepared was just the proposed legislation would prevent the department from seeking waivers of ABOD requirements based on high unemployment and discretionary exemptions. If passed, the department would not renew the current waiver and stop using discretionary exemptions. It would also prevent the department from seeking waivers in the future, which would limit the department's ability to respond to an economic downturn. I will add that we are very, very limited in our use of waivers and discretionary exemptions. We are very, very cautious and they're used minimally. So I could give examples if you're interested. Basically, the department has a waiver for 6 towns that are considered areas with very high unemployment. They're also in the very remote areas. Hales location, Pinkham's, Grant, Stark, Stratford, North Stratford, and Stratford Hollow. Stratford's really 1, but there's 3 ways that folks represent it, so 4 or 6. There are only 5 individuals in those towns that are impacted. So we only have 5 folks impacted by the exemption. So I think that's important. We currently have just over like 9,200 ABODs. So the 5 is really impactful to see the smallness, and it is just because of the locations where they're located. I will say there is a discretionary exceptions that states are allowed to use at a state's discretion. We are extremely conservative in using discretionary exemptions. The only discretionary exemption we used for 2023 as we came back into the requirements of ABOD. ABOD participation was suspended by the federal government during the public health emergency, and it came back in October of 2023, well, September of 2023. Unfortunately, we had a very short notice from the federal government that it was returning, so we had a very short opportunity to notify those that would be impacted, our 9,200-ish clients, that this was coming back around, if you will. So we sent out a heads-up notice in May and didn't get final clarification on expectations until August, when our letter went out. We used discretionary exemption for the entire 9,200 population for the month of September only. Reason being, not fair not to do so. They wouldn't have had any time to prepare for the new requirements on them. Come October 1, we had everybody up and ready to go with participation as needed. So that is the only discretionary exemption that we are anticipating for 2024 as well.
Thank you. Any questions?
Thank you, Madam Chair. Thanks for being here to take our questions. So this bill relates solely to SNAP, correct?
Yes.
Okay, Paula? And with SNAP, am I correct that we're talking about all federal dollars in terms of food benefits?
That is correct.
Okay. So, this bill doesn't save any state dollars, correct?
That is correct.
Okay, thank you.
In the past, has New Hampshire requested a work requirement? I thought we had requested a work requirement and CMS had turned it down. Was that for?
That's Medicaid related, so
Okay.
it was for Medicaid participation. Yes, that they did implement that. I can speak to that as well. I oversee. That was for Medicaid. So they were trying to do a work requirement for folks that were receiving Grant Advantage.
Okay. Have we requested a work requirement through the Fed? Do we have to ask for a waiver for work requirements through the federal system?
For the
For the
Medicaid?
SNAP and the,
Oh, for SNAP. ABOD is a SNAP requirement. I mean, it's just a program, if you will. Able-bodied adults without dependents is the acronym for ABOD. So
Okay.
it's just an opportunity for those folks to receive SNAP for a limited time, 3 months, if they are in full compliance. But really, it's if they have other challenges going on, we're here to support those individuals. And, the whole goal always is to work towards self-sufficiency, but in the interim, it is there for them.
okay, so did you say there's already a work requirement for SNAP?
It's not a work requirement, it's just it's just a subset of SNAP. Probably is the best way to put it in layman's terms.
Okay, thank you.
Sure.
Any other questions? Seeing none. Thank
All
you.
right, thank you.
Laura Milliken?
Yeah.
Good afternoon, Chairman Birdsall and honorable members of the committee. My name is Laura Milliken. I'm the Executive Director of New Hampshire Hunger Solutions. We're a nonprofit, nonpartisan organization that advocates to end food insecurity, improve equitable access to nutritious food, and address hunger's root causes for all New Hampshire residents. I'm here today in strong opposition to SB 351. SB 351 would not allow our state to temporarily waive SNAP time limits, even at times of recession, high unemployment, or genuine hardship. It's important to understand that currently, the SNAP program does not discourage work. SNAP recipients do not receive any cash benefits. They receive an EBT card on which there are benefits which they can only use at approved food locations in our state and only for food, not for toiletries, not for toilet paper, not for anything but food. The current SNAP benefit per meal does not cover the average cost of a modestly priced meal in any county in New Hampshire. On average, SNAP recipients per person get about $6 a day. Federal law refers to people who are between 18 and 52 years old who have no children in their households and not living with a disability as able-bodied adults without dependents, or ABODs. Currently, if ABODs do not work at least 20 hours a week, they can only receive SNAP for 3 months in a 3-year period. So most people on SNAP who can work are working. SB 351 would remove the discretion of the Department of Health and Human Services to waive the ABOD rules, even in areas of the state where there are no jobs, and even at times of recession, hardship, or emergency. In New Hampshire, data for the last 2 decades shows that New Hampshire has applied for waivers and exemptions in a conservative and targeted manner. It's just not true that there was a statewide waiver in 2022. Back in some of the waivers that were applied for were back in 2001 when Pulp and Paper of America filed for bankruptcy and 850 jobs were lost in Coos County. The state applied for a time limit waiver for Coos County. When the state was slow to come out of the last recession in 2009 and experiencing high statewide unemployment, it applied for a statewide waiver of the time limits. Since then, New Hampshire has applied for waivers for only a handful of towns that have had very high unemployment rates and insufficient jobs. In each of these cases, the state has made the case with data that these areas were so hard hit that continuous food and nutrition support was needed for the population eligible for SNAP. As you heard from the state, New Hampshire has also used very few discretionary individual exemptions each year when extenuating circumstances warranted. So what are the kinds of exemptions we're talking about? A temporary illness, which doesn't rise to the level of a disability, like someone breaking a leg. Seasonal workers when work is hard to find, like a plow driver in years where there's no snow. Domestic violence, family illness or emergency. SB 351 would tie New Hampshire's hands to be able to ever apply such exemptions. SNAP is a proven economic stimulus to local economies, especially during times of economic downturn. USDA estimates that every dollar spent on SNAP benefits in times of economic downturn generates more than $1.50 in gross domestic product. And that's because people spend SNAP dollars using an EBT card quickly and in the local economy. It can't be used for anything else but food, so it doesn't make sense to implement policies that limit the state's ability to benefit from SNAP's stimulus effects. Limiting the state's ability to gear waivers and exemptions to actual economic downturns and individual hardship will not increase employment in New Hampshire and will likely limit the state's ability to benefit from SNAP's stimulus effects. SB 351 will certainly increase hardship for people who are struggling to access food. For these reasons, we ask you that you oppose SB 351 and vote inexpedient to legislate. Thank you so much for this opportunity to testify.
Thank you, Laura. Any questions from the committee? Seeing none.
Thank you so much.
Is it Mike Edelberg, United Way? Sorry, I probably butchered that.
Heard worse. So it's my turn when I actually see the cringing look with the handwriting and the name. So, Madam Chair, members of the committee, my name is Mike Affelberg. I'm the president of the United Way of Greater Nashua. I come to you today in opposition to Senate Bill 351, seeking to limit the state of New Hampshire's ability to waive work requirements for SNAP benefits. We believe this proposed legislation is unwise and would have detrimental effects on individuals and families who rely on SNAP as a critical safety net during challenging economic circumstances. The pandemic, which hit the nation in 2020, brought about unprecedented economic challenges. In New Hampshire, our unemployment rate overall surged to more than 16%, placing an immense strain on the livelihoods of countless individuals. Had SB 351 been in place during that time, food support through SNAP would not have been as readily as available to individuals who desperately needed assistance. In the spring of 2020, I remember vividly a food distribution event in Nashua that we sponsored, where over 500 vehicles, my neighbors, lined up for food. Senator Avard probably knows the area. This took place at the school offices on Ledge Street, and the line of cars was all the way down the block to the Boys and Girls Club. This event for me highlighted the acute need for support within our community and the flexibility to provide immediate assistance without cumbersome work requirements, and how crucial that was. Enacting legislation that restricts the ability to waive work requirements may hinder our ability to respond effectively to similar situations which might arise in the future. It is essential to recognize that while times may be relatively stable today with low unemployment rates, the unintended consequences of this legislation could limit our state's flexibility to respond in times of crisis or need. Economic conditions, as you know, are dynamic, and the current positive circumstances do not guarantee future stability. Enacting legislation that restricts the ability to waive work requirements might leave our residents without crucial food support when they need it most. Moreover, I would like to emphasize that United Way, as an organization committed to community well-being, believes in a deep understanding of the importance of maintaining a robust safety net to support individuals and families facing hardships, especially during times of heightened economic uncertainty, such as the recent pandemic. In conclusion, I urge you to consider the potential unintended consequences of SB 351. While the economic landscape may be favorable today, we must prioritize the well-being of our residents by maintaining flexibility required to provide SNAP benefits during unforeseen crises. I implore you to preserve the state's ability to respond compassionately and effectively to the needs of our community in times of stability and during periods of crisis. Thank you very much.
Thank you, Mike. Any questions from the committee? Seeing none. Eileen, New Hampshire Food Bank. I'm giving up on last names. Welcome.
Thank you for having me. Thank you. My name is Eileen Laponis. I have the honor of being the Executive Director of the New Hampshire Food Bank. I'm honored to be in front of you today. Unfortunately, I stand in fierce opposition to this bill. I had a strange sense of deja vu when I was preparing for this, because 7 years ago, I was 1 month into the job, and SB 7 was introduced. Senate Bill 7 at the time was really going to gut SNAP, and because it was going to affect close to 18,000 folks. That would all fall on the charitable food distribution system, which we represent, all 400 of our partner agencies throughout the state. The first safety net is the federal SNAP program. And just to show you, to back up what my colleague from the United Way said, how things quickly can change. Before COVID, we did maybe 6 to 10 mobile food pantries a year. Maybe average 250 families. And they were special, targeted. For example, the North Country Electric Co-op would do one on the Saturday before February break, making sure that it was very concentrated on breakfast and lunch items for the kids who were going to be out of school that week. When COVID happened, we were doing 3 a week for an entire year. Then I did 2 a week for the year after that. I have since held fast with 1 a week. I averaged 400 families a week, sometimes close to 20,000 pounds, depending on what comes through the door. Things have changed very quickly in our distribution system. I purchase now 600 more times food than I used to. I used to be in the charitable food distribution system. There's not as much donated anymore. We're all having a hard time putting food on the table. We don't have the food drives that we used to. Our grocery partners are having a hard time locating the product. We don't have as much donated to us as possible. So I am buying. So to have that pressure on us, we are the second in line. First in line is the safety net of the federal SNAP program. And in 2017, it was going to have a big impact on us. For this bill, I'm questioning where it's coming from. It's going to take the ability of the state's agency who has the ability to act on a dime with those waivers, and they were able to serve so many thousands during COVID and afterwards. Why would we take that ability away from them? And my apologies for the numbers. Everything is documented except the 37%, and I'll tell you where that came from. I don't have the documentation and access to it that the department did, but I did note that there were 4 towns that were affected in the current waiver. Back in 2017, there was 14 towns. We've come quite a way. We have the most conservative, one of the most conservative SNAP programs in the country. For those 4 towns, there's 1,232 people. We estimated that there are approximately 40 SNAP participants in those 4 locations combined. That was based on the 2017 number when 37% of the SNAP recipients were ABOD recipients, beneficiaries. So we estimated applying that 37% from our historical data in 2017, we thought there were about 14 people. The department just said there's 5. Why would we take the ability of the department to help us in our times of desperate needs, and we've been through them, to focus on 5 people in the North Country? I just don't see it. I'd be happy to take any questions.
Thank you, Eileen. Any questions from the committee? Seeing none. Thank you. Aubrey Freeman. Welcome.
Madam Chair, committee members, Aubrey Friedman, I live in Bridgewater, private citizen. I speak in support of this bill. I applaud that private, voluntary organizations are helping out people when they're having hard times. That's a good thing. But when it comes from government, that's a completely different story. And I think then there should be requirements to work. Again, this bill is not going after people in wheelchairs or disabilities, and it's actually very age restricted. So the requirement to work should not be weird, to be honest. I mean, we all, of course, it's nice to get freebies, but incentives matter. And as was mentioned, when Maine, it went down from 14,000 to 3,000. It makes a difference when there's a requirement. And there should be, to be honest. Of course, if people want to voluntarily give money to other people and help feed them, that's fine. That's voluntary efforts. But government programs, I think the biggest problem with the government programs, the EBT, the SNAP, is it encourages a cycle of poverty. I mean, after all, your income can only be so high. So it's nice to get a few freebies, but if you prosper and you become independent and self-reliant, you won't qualify for that. We should encourage independence, personal responsibility to take care of yourself and your family. And those are good values, and I feel government benefit programs, welfare programs, whatever you want to call them, they increase poverty, actually. It's a cycle. So it's a small program, evidently, or like I'm hearing, but I think it just sends the wrong message. And as far as the employment part, I mean, New Hampshire is like number 5 lowest in the country. And everywhere, all industries are saying, we need workers. So it cannot be that it's hard to find work if one wants to. If one doesn't want to, then, that's another story. So I think we should encourage people to not be on these programs. And if they're going to be, there have to be a couple conditions like actually working. And I think it's only 20 hours too. Most people work 40 hours. So I think it's a reasonable bill, and that's why I support it. Thank you. Are there any questions?
Any questions from the committee? Seeing none, thank you.
Okay, thank you.
We have our last two speakers on this. Dawn McKinney is next, and then Jake Berry is last. So.
Good afternoon. I am Dawn McKinney. I'm the policy director at New Hampshire Legal Assistance. Most of my testimony has really been covered, so I will just.
Dawn, can you just hold on till Cam gets.
Oh, sorry.
Okay.
Most of what I was going to say has already been covered, so rather than repeating things verbatim, I will just kind of try to wrap up a few things that I think want to make sure everyone fully understands at this point. There is a SNAP work requirement. Everybody, sorry, I can't see my paper with my glasses on, and I can't see you without them. So this is where I am. So the folks that we're talking about folks that are working or trying to work, quite frankly. You have to work unless you are, there's a 3-month grace period in 3 years. So that means even if you just were working and lost a job, right, for a month in that transition, when you're, looking for another job, that doesn't count towards a work requirement either. Looking for work does not count. So you're in transition, or there's a shoulder month where there's no snow, for example, for a plow driver. And they might have work the rest of the year, but that 1 month counts towards their 3-month grace period in 3 years. So it doesn't take much to realize, people do have to work and are trying to work. And we're talking about folks, that's the folks we're talking about here. So I just wanted to kind of make sure everyone understood there is a work requirement for SNAP and that folks are working. And like everyone has said, there are 5 individuals currently who are unfortunately in a situation where they can't find work, sustain work, whatever the case might be. There might not be work in those towns. I don't know about you. I haven't actually been to Pinkham's, Grant, or Hart's location, or Stratford, or Stratford you've been? North Stratford. I mean, so there might not actually be any jobs. They may, so anyway, there might be extenuating circumstances there. I don't think those 5 individuals are going to solve our workforce shortage crisis in the state, and it will make it harder in the future if there is an economic downturn like there has been previously for the state to respond, which is what we've all been talking about. And I don't have copies, but I will give the one copy I have to Cam because I'm very stingy with colored copies. But this is the map of the United States in 2009. These were the waivers that were put into place based of the work requirement for ABODs, based for SNAP, based on during the recession. It was almost the entire country. And this was 2019, so they almost all, except for certain parts of the country, almost all went away. And New Hampshire is notably, we did not have any other than those few towns like we've talked about, which is currently some variation of the 4 to 6 towns and 5 people. So the point is the waivers work the way they're supposed to work, and it's important to have the ability to respond in an economic downturn or in some other sort of economic crisis like the COVID pandemic, and et cetera. So I guess I'll just stop there and see if there are any questions.
Any questions to Dawn? Seeing none, thank you.
Thank you.
Jake?
Do you want my?
Good afternoon, Madam Chair, honorable members of the committee. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for more than 25 years to support the
Jake,
health and well.
Can you just hold on until Cam gets to his desk?
Sorry about that. All right.
Yeah.
Thanks. Yeah. All right. Thank you. Sorry about that. We've been working for more than 25 years to support the health and wellness of New Hampshire families and to improve health equity in our state. I don't want to repeat too much of what's been said this afternoon, but I do want to stress New Future's strong opposition to this bill. As you know, and as you've heard this afternoon, SNAP is a critical social benefit program that provides needed financial support to our friends and neighbors when they need it most. The vast majority of adult participants, especially those without dependent children, are required to work, volunteer, or engage in job training for 40 hours each month. But part of what makes this program so successful and so important for our vulnerable residents is the ability to waive the work requirement, particularly during times of challenge. For instance, when a paper mill closes up north or another major employer closes shop and takes with it most of the job opportunities in one particular region, impacted individuals will often rely on SNAP to get them through while the economy recovers and they can find new employment. Or more recently, when the COVID pandemic shut down major industries, SNAP benefits helped many of our families through. To deny the state the ability to seek waivers from the SNAP work requirements as proposed in this bill would not only deprive granted staters of these critical benefits when they need them most, but it would leave us without key federal resources needed to address hunger across New Hampshire. This would only further exacerbate hunger and poverty and leave it to our hospitals, our local welfare offices, and our other community resources to address this problems on the taxpayer dime. For these reasons, I encourage you to vote this bill ITL. Thank you, and I'm happy to take questions.
Thank you, Jake. Any questions? Seeing none?
All right.
Thank you.
Thank you all.
What? So that was the last speaker for Senate Bill 351. I will say that is there anyone here that hasn't, wants to speak but wasn't given the opportunity? With that, we have one person in support, didn't want to speak, and 6 people opposing, not wanting to speak. So with that, I will close the hearing on 351 and wait for Cam to get ready and start the hearing on 456.
Jenny from the block. Crashes and burns. Every day is a busy day.
It's Bill Gannon Day.
Yeah.
Bill Gannon afternoon.
Tomorrow's Bill Gannon Day.
Morning.
Yes.
Wait till tomorrow morning.
Oh, well. I don't have any hearings tomorrow. Okay. You all set? We are going to open the hearing on Senate Bill 456. And welcome the prime sponsor, Senator Gannon.
Thank you, Senator Birdsall, and honorable members of the committee. I'm going to try to be a phoenix rising from the ashes here. I think I'll do a better job this one, and you'll all enjoy it a little more. Hey, I call it the way it is, Senator Whitley. I was in the hospital for 6 weeks, as you know, and I'm like Senator Bradley. I'm very into my politics, and I talk way too much. And so I was talking with the nurses, and I said, what can we do to make it better for you? Because they were doing everything for me, and they were doing a great job. There were a lot of Florida nurses making the triple wages, and the problem with that is there's a double-edged sword. Our young nurses are heading all over the country, and I don't blame them, making triple the wages. So each state's paying triple the money and getting the same number of nurses. So there's got to be a better way around that. But I talked to them, and I was different. I said, what are your main problems? How can we help you in the state? And so what we came up with they had a few other ideas for nursing homes and stuff that just weren't ready for prime time. But they thought if we introduced a bill relative to establishing a nurse retention school loan debt relief program, it would help keep nurses in New Hampshire. Not only do I want to keep the nurses who go to school here from heading down to Leahy Clinic and the higher prices that they can receive in the bordering Mass communities, I also want to attract as many out-of-state nurses. So that comes up in the amendment, which I hope you all have, that came out today, 4456, it's number 0077. So as you all know, we all know about the shortages, and how are we going to address that? So one little way.
Senator, can you
Yes.
just hold on? What can? Oh, sorry.
Zeros. Yes, that is the
Yep,
one.
sorry.
That's okay.
Back.
Okay, we're back in business. The hospitals are overrun. The nursing homes are closing wings because they don't have enough staff nurses. So we want to retain and keep and attract out-of-state nurses. So this would be a little step in the right direction. Would have nursing school loan debt relief program, which will be administered by DHHS. These nurses eligible will be contracted to work in a healthcare facility in New Hampshire for a term of 4 years. Once a nurse agrees to the employment contract, they will receive a one-time tax-free disbursement towards their student loan debt equaling 20% of their student loan balance. This will be funded by a dedicated non-lapsing fund called the Nurses Retention School Debt Relief Fund. Now, as I've been working with a lot of the hospital association, the nurses, we've come up with a few things that we're probably missing. So the 6 points that are covered in the amendment, we to ensure the program is available for undergrad and grad student loan repayment assistance in line with other New Hampshire repayment programs. We clarify the fund is for registered nurses or licensed practical nurses in New Hampshire, not exclusive to nurses working in a hospital. And not just for New Hampshire nurses. If you go to school in another state, we want to attract and lure you up here. One funny thing is most people, or a lot of people between ages of 22 and 26 or 27, we all tend to be, your male or female, tend to nest. So if I can keep you here in those early years, you're going to have established your family here, and you'll be a nurse for life if we can get you into New Hampshire and get you to make New Hampshire your forever home. We want to, in the amendment, we have available to applicants not otherwise participating in the New Hampshire Student Loan Repayment Program, known as SLRP, to avoid double dipping in the state programs. It clarifies the contractual obligations of the applicant to work at a New Hampshire facility. This is modeled off New Hampshire repayment programs, and we're clarifying the private match advantage of the program. So again, I want to attract out-of-state nurses, in-state nurses. We don't care if you went to school out-of-state or in-state. We want you to come here, stay here, and this will be a little piece to make it more attractive for nurses to live, work, and play in the great state of New Hampshire. I hope the committee will consider supporting the bill so we can continue taking steps to address this healthcare. And at this time, I'll thank all the nurses I had at the Elliott and the Elliott Rehab. Did a great job. But again, I found the nurses from New Hampshire to be the out-of-state nurses. A lot of them were only 1 year experience. So when I was in Elliott Rehab, when I got out of the regular Elliott, they said they wouldn't even hire the people that I had had at the regular Elliott. They said, we just wouldn't trust a 1 year nurse to do these things, to do the things that they're doing with you at the regular Elliott. So we need to keep our nurses here. There was an exceptional time when traveling nurses making the triple salary was good, but that really isn't a good thing for the state paying the high wages to inexperienced workers to fill empty slots. So I hope this covers a little bit. Ben Bradley from the Hospital Association is much more adept at the funding mechanism of the private and mixing the two funds sources. So if you had questions on funding, he'd be a great one. Any questions?
Any questions from the committee?
Sorry to
Seeing
take so
none?
much of your day. Thank you.
Whitney Hammond and Sean Jackson from DHHS. Welcome.
Hello, Chair and committee members, and thank you for having us take your time and give some testimony. I'm Whitney Hammond. I'm the administrator for the Bureau of Prevention and Wellness in the Department of Health and Human Services. And within that unit, we have a number of workforce programs, including the State Loan Repayment Program, or SLRP. And I have here my colleague, Sean Jackson. I'll let you introduce yourself.
For the record, Sean Jackson. I'm the section administrator for Rural Health, Primary Care, and Prescription Drug Monitoring Program at New Hampshire's DHHS Division of Public Health Services.
And I did want to just draw people's attention to that we've submitted written testimony. That was submitted before the amendment. So there's a little bit of an inconsistency in terms of the number of years requirement as was referenced in the written testimony. We also did submit a fiscal note worksheet, and that was based off of the original bill. And so I would think there'd be significant changes given that the eligibility for this program originally was limited to nurses who graduated from schools in New Hampshire. So I just wanted to put that out there. So 3 things that I want to cover in my testimony. First, I want to just acknowledge the importance of the intent of this bill. And, you know, I know you guys listened to earlier workforce testimony for Senate Bill 403 and really heard about the shortages that we're experiencing in terms of healthcare professionals. And certainly nurses are a huge, you know, component of that and are really essential to the health of people in New Hampshire. So I want to acknowledge the importance of what the intention is of the bill. That said, I did want to just highlight some of the potential unintended consequences of this bill and how it might actually impact existing state loan repayment and other workforce initiatives. And I would encourage you to even just reflect back on that 403 bill and to kind of consider how this might interact with that bill as well. I want to just highlight a possible technical defect that I think is fairly significant from the bill. And then lastly, just broadly talk about the fiscal impact and agency impact of the bill. So the first issue is related to the unintended consequence that a nurse loan repayment program could have on the existing state loan repayment program that the state operates. When Sean introduced himself, he kind of put the umbrella over his section of that he's rural health and he's primary care. And the nurse loan repayment program broadens loan repayment to nurses who are practicing in hospital settings, which could then erode the efficacy of our state loan repayment program, which is really intended to be recruiting professionals into medically underserved areas in the state or health HPSAs, health professional shortage areas. And if you look at our written testimony, the actual reimbursement of 20% of student loans that's being proposed in this bill would far exceed the reimbursement that we offer currently for Tier 3 of our student loan repayment program, which is what covers our RNs in the state. So you would be broadening where nurses could choose to be practicing and could be incentivizing nurses to practice in places that aren't experiencing shortages. And again, reimbursing for far more than our state loan repayment program. So that's a possible unintended consequence. The technical defect that's of most concern, and it is articulated in our written testimony, relates to the bill's requirement that these be tax-exempt loan repayments. So we're not able to say with 100% certainty, but based on this student loan repayment program, that is tax-exempt, and that's partly because of the Affordable Care Act law that made it so that student loan repayment programs specifically that are paying professionals to practice in medically underserved areas and outpatient settings would be tax exempt. So it is not our understanding that it would be possible for the program to actually operate in a tax exempt way. The final piece is just, again, I wanted to draw your attention to the fiscal note worksheet. It's a significant amount of money that was costed out, and that was prior to us understanding that this could actually be a program that is available to individuals. Oh, you don't have the fiscal note worksheet?
Is that on the online version? Because, yeah, I don't have a, I don't think any of us have the, fiscal note.
Do you have?
No.
Oh, okay.
That's from,
It should have been submitted.
What we have is, it's $0, $0. And
It
then I
was,
guess down at the bottom,
I-
there's estimated costs.
It was released this morning while we were in committee.
But I'm looking online.
Right, they updated the online. I'll print you copies real quick right here.
okay.
Well, it's zeros in the chart, but maybe if you look down, it says combined costs are 18.2 million.
So the version that we submitted does not just have zeros. It's got zeros for state revenues, but not expenditures, and it has up to 4.5 million per year. And that was based on, again, eligibility being limited to nurses who graduate from programs in New Hampshire.
Thank you.
Okay. I should wait, right?
Yeah.
Maybe we should be in recess for 3 minutes.
Okay.
3.
2 minutes.
$2. Okay. Small.
I do have a question on this, actually. So This does not include the amendment, correct?
So the fiscal note does not include the amendment. It also does not reflect what was submitted by us.
Okay.
I'm new to that.
That's funny.
And I can see on the second page, there's detail on the positions that the department would need to operationalize the program. But I see on the first page, it says the bill does not authorize new positions. So I'm not sure if I'm not sure. But certainly
Well, based on the amendment, would the number go up or down?
up.
Okay.
Up from the 18.29.
Yeah.
17, I have 17.8.
Oh, they originally said 4.
Oh, 18.2, got it.
Yeah, up from the 18.2 million. The 18.2 million was the cost that we estimated over the course of the three years.
Okay.
Any questions?
Any questions from the committee? Seeing none. Thank you.
Thank you.
Ben Bradley.
Thank you, members of the committee. I think there are some things to figure out on this bill, but I appreciate that it is well-intentioned and a really important bill to address the nursing concerns that we have in New Hampshire. My name is Ben Bradley. I'm the Vice President of State Government Relations with the New Hampshire Hospital Association. The New Hampshire Hospital Association supports SB 456. And our members deeply appreciate the support from sponsors of the legislation. Healthcare careers are often a calling, and qualified, engaged, and diverse workforce is at the heart of New Hampshire's healthcare system. It's no secret that hospitals have been facing significant challenges that make it difficult to sustain, build, and retain a strong healthcare workforce. According to our latest vacancy report, we've seen a 20% vacancy rate for registered nurses in New Hampshire. These vacancies have led to a reliance on contract labor to fill necessary positions, as Senator Gannon pointed out. At the height of COVID-19, when our hospitals responded to the high need for services, they experienced a 133% increase in contract labor costs over the previous year. Hospitals' reliance on contract labor has diminished somewhat since that time, but our hospitals cannot operate at their current capacities without contract labor and its significant costs. For many years, several of our hospitals have offered student loan repayment to qualified nurses committed to working for our hospitals in an attempt to recruit employed nurses and reduce the need for contract labor. According to the American Association of Colleges of Nursing, the median amount of student loan debt anticipated by graduate nursing students upon completion of their program was between $40,000 and almost $55,000. We believe student loan repayment is an important tool that can make a difference in a nurse's decision to work in a hospital in New Hampshire. Surrounding states have also made investments in the healthcare workforce with student loan repayment programs aimed at attracting nurses and other professionals to work in their state. The concepts included in SB 456 are a strong step towards establishing a competitive benefit in New Hampshire, and we appreciate Senator Gannon's support for Amendment 0077S, which he outlined. I'm happy to work with sponsors of the bill, others, funding, whatever it may be, but feel this is a really important step towards making New Hampshire a competitive place to attract a nursing workforce. I'd be happy to take your questions.
Any questions? Senator Prentice.
Great, thank you. Thank you for joining us today and well into the afternoon. Okay, 2 questions. You mentioned, I think, other New England states. Do other New England states have similar programs?
Other New England states have programs that will provide student loan repayment outside of the standard SLRP as this program does.
Follow up. So we heard representatives from, rural health, primary care, and, DHHS talk about some of the maybe unintended conflicts, or I don't know if conflicts is the right word, but how these could maybe work against each other versus work together. Has that been the experience elsewhere? Like, how could we crack that nut so that these come together?
Yeah, I think it's something that we'll have to work on. I'd like to know exactly how many nurses participate in the SLRP and how many are in rural capacities taking advantage of the existing program. Whether there's some way to match the benefits of the program that would be established with the SLRP. I think that will be one of the things that we should continue to work on.
Okay, one more, and I'm sorry that I didn't write this down. Vacancy rate currently?
I have 20%.
Do you have a 5-year window?
I do not.
Post-COVID? Yes, not to put you on the spot, that would just, I think, be, I feel, may I? Yeah, just very quickly, it's an important initiative, but, I've worked with nurses for years, and I feel like we come up against these shortages. Pretty regularly, people are leaving the profession. So I don't know what I'd love to see a long-term fix, and this might be part of it. So I'd be interested in seeing that trending, because I hear about it regularly. That's all.
Understood.
Thanks, Ben.
Thank you.
My question is, you have 20% vacancy rate. Where did they go? And how long has this been going on?
I think it's a fair question, Senator. I'm happy to get back to you with further details on exactly why we're seeing a reduction in nurse, vacancy, or an increase in nurse vacancies. Part of the issue, I think, is the acuity of the services that we're having to provide, and burnout. All those things contribute to workforce shortages and a reduction in this workforce.
When you're looking up that information, can you also see if you can find any information in the did we lose a lot of healthcare workers because of the COVID mandate? Is that why some of them left?
I can look. I don't believe we have specific data on that, but I'll take a look and get back to you.
Thank you.
Yeah.
Any other questions from the committee? Seeing none. Thank you.
Thanks.
Madam Chair, committee members, Aubrey Friedman, Bridgewater. This one I speak in opposition to. I have nothing against nurses. And if you have to be in the hospital, they're handy to have. However, why do nurses get a special carve-out in this bill? Why not doctors, dentists, chiropractors, optometrists? That's just the healthcare field. What about other fields where people take out student loans? Engineers, architects, geologists, veterinarians. There's a ton of people who are professionals. They've gone on for higher education certification, and they took out loans. And in general, it's worth it because you get paid more over the years. That's fine. Why nurses special? Yes, there is a definite shortage. There's a labor shortage all over the state, in all industries and the country. In fact, it's nothing new. It's been going on for a while. And so why is this, to me, this is favoritism for nurses. All businesses have to, you got to get workers to run your business. So what are they doing? They're paying more, better benefits, maybe better hours or sign-on bonuses. This is another approach, this student loan thing. Why is it on the taxpayers? That's what I don't know. Why don't the hospitals or medical centers, that'd be another way to attract, you have different bargaining tools with employees. That'd be another one. Why is this one on the taxpayers? That's what I don't like. And by the way, I don't have that much sympathy for the hospitals and the medical centers because with the COVID and the vaccine, there were hundreds and I was at the Dartmouth protest, so I definitely followed that afterwards. There were hundreds of nurses and medical workers that were fired for not taking the vaccine. And now they said, well, we're short. Well, why didn't you think about that before you said bye-bye if you don't get the vaccine? So I don't have that much sympathy. Now they've got to deal with this problem like every other business. You either pay more benefits, whatever it is. And this is also a good idea on the student loan thing, but it should not be on the taxpayers. Now, one problem maybe I missed it and I didn't see the amendment, but you have to work for 4 years. Well, it says contracted to work in a hospital in New Hampshire for a term of 4 years. That's not unreasonable. But what happens if you leave before the 4 years is up? Maybe you want to go to another state or another industry or something different. Wouldn't you have to pay that back? Because I don't see that in this bill, and that would be kind of unfair to the taxpayers. We didn't get 4 years worth of work out of you, and I think you get the disbursement of the 20% loan balance right away. So that to me seems like a technical problem with the bill. And lastly, I would just say this is a moral hazard to start giving out goodies on taxpayer dollars. Again, if private industries, companies do that, that's fine. But it seems to me when a person leaves high school and they start planning out their years, I'm going to become a professional, go to college, I'll have to take out some student debt, maybe I should live at home for a little while, maybe take a bigger student loan. If they're thinking, oh, look what they gave the nurses, the taxpayers gave the nurses a little goodie, that might come into it. It's a moral hazard. So private industry, they've got to deal with these things, but taxpayers should not have to pick up these kind of costs. Again, it's nothing against, this seems like favoritism to me. So those are my thoughts. Thank you. Do you have any questions?
Thank you, Albert. Any questions from the committee? Seeing none.
Thank you.
Laura McIntyre.
Right. Good afternoon, Madam Chair and members of the Senate Health and Human Services Committee. My name is Laura McIntyre, and I'm here today on behalf of the Granite State Home Health and Hospice Association, which is the advocacy wing of the Home Care, Hospice, and Palliative Care Alliance of New Hampshire. The association is in support of SB 456 with proposed amendment 0077S. We feel that including nurses employed in all healthcare settings, including home care, would be beneficial to our state and believe that this legislation will help with the recruitment and retention of nurses. And we respectfully ask for a vote of OTP as amended, and also happy to work with the sponsor and other stakeholders if further changes are needed. And that's it.
Thank you, Laura. Any questions from the committee? Seeing none. Thank you. We have 2 speakers left. Alex, you're up next. And then after Alex is Courtney Tanner.
Thank you, Madam Chair, members of the committee. Alex Katrubis here representing long-term care, assisted living, and nursing homes. I did send them a copy of the bill as introduced, both the nursing homes and the assisted living facilities. I did learn that in the long-term care world, there is it's not really a student loan repayment program, but when a LNA goes to work in a nursing home, there is a reimbursement that they can get for the cost of the licensure and the training. And that actually comes out of the Medicaid reimbursement from the nursing homes. That's really not applicable to this bill because this bill is really looking at RNs, not LNAs. But both the assisted living homes and the nursing homes asked to be amended into the bill, which is what the amendment that was presented to you today would achieve. So we do support that amendment. You've heard me talk about the AARP study, and I know Senator Bertzel, you asked where did the workers go, and I just looked up just a couple of things from that study: burnout, stress, mental health, lack of advancement. Those were some of the. There was a survey that was done by an organization, a staffing agency for long-term care facilities, and those were the top reasons why folks in the nursing profession left the industry. And I've provided that study to you before, but I'm happy to do so again if you'd like more information. And I can get you data on vacancy rates. I did last session under Senate Bill 86, but if you need information on vacancy rates for the nursing homes or for the assisted living facilities, I can do so. But Senator Gannon's exactly right. There's wings that are closed off. There's floors that are closed off. And there's just, it's all related to lack of staff, and RNs are a big part of that. So certainly anything we can do to try to encourage more folks to enter the profession, and this may be a good tool in the toolbox. So thank you very much.
Thank you, Alex. Any questions from the committee? Seeing none, and Alex, I'll try and pull Senate Bill 86 from last term,
Sure.
session, whatever, and see if I can find it.
Okay, absolutely.
If I can, I'll let you know.
Yeah, absolutely. Happy to provide it again.
Thanks. Courtney? Welcome.
Good afternoon. Courtney Tanner, for the record, Director of Government Relations for Dartmouth Health. I'm really grateful for Alex's testimony because Dartmouth Health is acutely experiencing barriers to discharge, where we're really struggling to discharge our patients that are clinically ready to leave Dartmouth Hitchcock Medical Center and go to a nursing home or in-home care, and we're unable to do that because there's no nurses in those places. And so I'm really grateful to Alex's testimony. And we're really grateful for Senate Bill 456 because we think this is a tool in the toolbox. Just last month, at Dartmouth Hitchcock Medical Center and our clinics, our CGPs, we had 529 nurse vacancies. There's an interest to increase our LPN activity in our clinics. Currently, we only utilize LPNs in our inpatient settings, but we're interested in expanding that to our outpatient settings also because there's a demand for healthcare services. In 2023, we hired 205 new grads, new RNs, but we have a goal this year of hiring 300 new RNs. And so we see this bill as a tool in our toolbox. We're trying to do everything we can. We have in-house pipeline programs and apprenticeship programs, and we see this as an added tool to our toolbox. So we thank Senator Gannon for bringing this forward, and we support the bill.
Thank you, Courtney. Any questions? Senator Whitley.
Thank you, Madam Chair. Thanks for taking my question. We've heard some testimony today. Someone even said as high as a third of our healthcare workforce have left because of COVID mandates. I wonder what your experience was or what the hospital's experience was.
Yeah, so we did have, it has not been our experience that there's been 1/3 of healthcare workforce that have left our workforce because of COVID mandates. In fact, we actually had nurses thanking us for instituting mandates so that we could ensure that our sickest patients had protections. So that has not been our experience. And it's been about 3 years now, so 2 or 3 years now. Losing track of time.
Courtney, do you have any information on specifically on Dartmouth? Because I know in the HR arena, they usually do exit interviews. And I know that Alex had given some information, but specifically, can you get any information on what the exit interviews had said regarding why they left Dartmouth? Or
Yeah, let me follow up with you, Senator. Absolutely.
That'd be great. Thank you. Any other questions from the committee? Seeing none. Thank you, Courtney. Is there anyone here that would like to speak on Senate Bill 456 that hasn't been given the opportunity? With that, I will close the hearing, and we have one more bill.
Wow. I'm here for this one.
Deja vu. That's good. Tomorrow's my longer day. A lot more bills.
Yeah.
And she's doing a double session. That's good. It's my aim. Ben? Sean said it'd help us. Over here. Sean, introduce yourself to Ben. Oh, you do? Okay, I'm just making sure. I don't know. I'm just bringing people together. Synergy. Yeah, synergy. These help with letters, but then everyone gets blurry.
Okay, just an FYI, we have 9 speakers on this bill,
Wow.
on 457, so if we can keep them pithy, that would be great. So I will open the hearing on Senate Bill 457, an act relative to inpatient psychiatric services, authorization and utilization review. Senator Gannon's the prime sponsor. Welcome.
Thank you, Madam Chair. Senator Bill Gannon from District 23. I'll be very brief, just give you some bullet points. It's relative to inpatient psychiatric utilization review. We all want to be a part of the solution to address our mental health challenges. We want to move the needle on workforce recruitment and retention, especially in healthcare. I was asked to bring SB 457 to keep chipping away at both these matters. 457 requires the New Hampshire Insurance Department to promulgate rules that create greater efficiencies, uniform criteria for admission and utilization review for patients that need inpatient psychiatric care. Currently, insurance carriers can and do have different processes. Uniformity will allow providers to streamline processes, allowing for more patient time care. We can all agree that we'd like our doctors, nurses, care managers to be with the patients more and less at the phone and with the insurance companies. This bill strikes a balance to ensure patient access and still have utilization review process. I believe Courtney Tanner from Dartmouth Health is here to answer any questions you may have. Thank you for your consideration.
Any questions from the committee?
Thank you. Have a great day.
Thanks. Ed Bradley? Is Ben Bradley here?
Yes.
Okay. Why don't Holly?
Good afternoon, Madam Chairman and members of the committee. My name is Holly Stevens, and I'm the Director of Public Policy at NAMI, New Hampshire, the National Alliance on Mental Illness. And I'm here today to testify in favor of Senate Bill 457. NAMI, New Hampshire has heard from hospital personnel that insurers stop paying for inpatient psychiatric stays before the treatment team believes that a person is ready for discharge. As a result, the person either is left with, they're left basically with a decision of either having to pay out of pocket for the rest of their stay or be discharged with some, they try to put intensive outpatient services around them. But as we've heard, due to the workforce shortages, there aren't the outpatient services necessary in order to really wrap around these folks for the outpatient stay. So they're left with a very difficult decision. And as you just heard as well, it's not in my testimony, but the administrative burden that the hospitals have with doctors and nurses having to be on the phones with insurance companies, that does take away from the patient care in the hospitals themselves. So Senate Bill 457, as you know, would prohibit commercial insurers from reviewing psychiatric inpatient stays for the first 30 days, which would allow the treatment team to keep the person inpatient for as long as they felt was necessary. And we also know that because of people waiting in ERs, we're not keeping people in psychiatric hospitals unnecessarily. They've got folks to fill those beds. So it's not like they're just keeping people for longer than necessary. And the bill also does require that the clinical staff does an assessment every single day to see whether that person is ready for discharge. So it does strike a balance between the insurers not being able to do a utilization review in the first 30 days and the clinical team doing that evaluation every single day. So Senate Bill 457 will ensure that each psychiatric admission because the treatment team does the assessments, it will ensure that psychiatric admissions, I lost my train of thought and I apologize. It will ensure that the decisions remain with the treatment team and rather than with the insurers, which is extremely important because the treatment team is with the individuals that are receiving treatment and the insurers are on the other end of a phone. So NAMI New Hampshire is in support of Senate Bill 457 and I will answer any questions that you may have. Thank you very much.
Any questions from the committee? Seeing? Thank you.
Thank
Holly.
you.
Ben?
Thank you, Madam Chair. For the record, Ben Bradley, Vice President, State Government Relations with the New Hampshire Hospital Association, representing all 26 of the state's community hospitals as well as all specialty hospitals. The association supports SB 457, and we believe the bill will reduce the administrative burden on case management and psychiatric care staff while also ensuring daily clinical reviews are conducted on patients to develop appropriate treatment plans and prevent unnecessary lengths of stay. Additionally, by establishing uniform guidelines that outline a single set of criteria for inpatient psychiatric services utilization review, providers of inpatient psychiatric services could lower administrative overhead costs and increase efficiencies in the healthcare system. We have one suggested change to ensure the bill language aligns with the Centers for Medicare and Medicaid Services guidelines for inpatient psychiatric care notifications, specifically on line 8 of the bill, changing the treating facilities notification to the health plan of the admission to within 2 business days or 72 hours. Thanks for the opportunity to share our feedback in support of SB 457. I'm happy to take your questions.
Any questions for Ben? Seeing none? Thank you.
Thank you.
Michelle Heaton.
Hello, Michelle Heaton. I'm the Health Law and Policy Legal Counsel at the New Hampshire Insurance Department. So I'm here today to talk about this bill, and based on our reading, it does essentially 2 things. First, it's directing the commissioner to establish uniform guidelines for inpatient psychiatric services authorization and utilization review. And then the second thing it's doing is preventing any kind of utilization review for the first 30 days of inpatient residential or behavioral health treatment. The insurance department is opposed to this bill because as insurance regulators, what we do is that we make sure the insurance product is working like it's supposed to and in accordance with state and federal law. What we do not do is come up with clinical guidelines, and we are not equipped to come up with these clinical guidelines. It'd be something completely outside of the scope of what we typically do, and it's not something that we are equipped to do at this time. So we did submit a fiscal note already. However, we have submitted just today an amended fiscal note that captures the fact that we do not have the resources to create these clinical guidelines nor the expertise. What we would have to do is hire outside experts to come up with these. We're not sure how much it's going to cost because this is outside of the scope of what we typically do. However, we would expect it to be fairly expensive and not something we can absorb within our typical consultant's budget. This is also the type of thing, clinical guidelines evolve as medicine evolves. So this is not something that you would do once and be done with it. This is something that if the department were tasked with creating these guidelines, we would have to be reviewing them periodically to also make sure they're keeping up with medical practice. Now, one of the technical problems with that is for these to be enforceable, we would have to promulgate them in the form of administrative rules. As you may know, administrative rulemaking is a lengthy process. Sometimes it can be quicker than the legislative process, but it's still a process. So there could be a lag time where our clinical guidelines are out of date and we're in the process of updating them, but that can take several months to do. So that's a potential issue that could come up. And for that, that's the main reason why we're opposing this. With respect to the 30-day prohibition, we don't necessarily take a position on that aspect of it, but we would flag for you that this could lead to services being covered that are not medically necessary. This could cause an increase in medical spending and could have upward pressure on insurance premiums. So I will leave it at that for now and I'd be happy to take any questions.
Any questions from the committee? See none. Thank you, Michelle. Mariah Tidwell and Courtney together.
If it's okay that we testify together.
Perfect, thanks.
Mariah is a nurse at Dartmouth Hitchcock Medical Center. For the record, Courtney Tanner, Senior Director of Government Relations at Dartmouth Health. So we are in support of this bill, and we're very grateful for Senator Gannon for bringing this forward. We currently at DHMC have 20 inpatient psych beds, and later this year we'll be able to increase our capacity to 24 beds, 5 of which will be DRF beds. And we do see this bill as a reduction on administrative burdens for both our providers, and I would actually hope that the carriers too would see this as streamlining some processes. I can hear our department chair's voice ringing in my ear saying there's nothing more aggravating to a provider than a provider that has to stay on the phone with a carrier instead of seeing their patients and being with their patients. So for an average stay for a provider, for a patient rather, a provider might have to do a doc-to-doc with the carrier for a utilization review. That usually takes about 20 minutes, and they might have to do that once a week per patient on average. So if you think about our 20 beds, that could take up to a full business day for a provider to do a doc-to-doc with, in culmination for the week. They could be spending up to 8 to 7 hours doing doc-to-docs with the carriers for utilization reviews. So we really see this as an ability to streamline processes. We're not asking for URs to go away, but just trying to make things more efficient and more administratively effective so that patient care can increase. Mariah Tidwell came down from Dartmouth Hitchcock Medical Center today. She's a nurse and can talk a little bit more about what her experience is for URs and what that means for patients.
For the record, my name is Mariah Tidwell. I'm the Director of Emergency and Psychiatric Services at Dartmouth Hitchcock. And so I oversee the case managers, social workers.
Mariah, could you move the, yeah, sorry, thank you.
I oversee the case managers, social workers, nurses, and I work alongside the physicians that are working both in our emergency department and on our inpatient adult voluntary psychiatric unit. And so some of the biggest frustrations are patients come in and, as you know, typically receive a 5-day guarantee of services. And after those 5 days are up, we have to submit a utilization review for extended services for these patients. And when patients stay an average of 7 to 10 days on our inpatient unit, we have to resubmit for those services. And when there's a denial of coverage or when the doc needs to get on the phone to do a doc-to-doc or peer-to-peer utilization review, often we're left with insurance companies that set a time for us to call. Don't call during the time frame in which they have specified. Our physicians are taken out of being able to interact with their patients, see their patients for up to an hour. Sometimes we try to reschedule those due to the lack of availability because we're an inpatient unit. Emergencies occur and they're on the unit with patients, that can result in a denial of services, which then puts it back on the physicians either needing to schedule another appointment and advocate for the patient, or it results in them having to make a decision whether the patient needs medical services. The other thing that I would raise here is that our patients have a lack of, as we have heard here today, a lack of services outside the hospital. So it's not as easy to get a patient placed that needs maybe a group home or needs assisted living and can't be in the community. So that sometimes is a barrier for us as well.
Thank you. Any questions from the committee? Seeing none. Thank you. Sabrina.
Good afternoon. Thank you, Chair Birdsell and members of the committee. My name is Sabrina Dunlap. I'm Director of Government Relations at Anthem. I appreciate the opportunity to testify today. Well, I think SB 457 is probably a well-intentioned bill. I think it could have unintended adverse consequences, and Anthem is opposed for several reasons. The bill is very broadly drafted. It prohibits any utilization review during the first 30 days of inpatient or residential behavioral health admission. I would note we've seen similar bills in other states like New York, New Jersey, and Massachusetts. And there are concerns these types of bills result in patients having longer stays and higher than necessary levels of care. At a time when New Hampshire already faces a shortage of beds and providers, we're concerned a bill like this could exacerbate the problem because once a patient's admitted inpatient or residential, the bill would not allow for any sort of utilization management that might help move the patient to a more appropriate level of care. This could lead to missed opportunities to effectively coordinate discharge planning for patients, to lower levels of community-based care or other lower acuity services. Our medical folks also commented at a time when we're trying to move people out of the hospital, this takes us in the wrong direction. I would also just note that the bill prohibits collaboration that is currently happening between carriers and providers. Speaking for Anthem, though I suspect other carriers are similar, we have care managers who are all licensed BH clinicians. They use the review process in accordance with widely accepted guidelines to make sure the member has a person-centered treatment plan that is active and appropriate, and that the member is receiving clinical treatment for their condition that will move them towards their goals of recovery. When a member is ready to step down to a lower level of care, our case managers work with the provider to make sure the provider is aware of all potential step-down services, and this bill would prohibit these types of critical collaboration. I did just note the mismatch between the bill title, the commissioner issue, but I think that was clarified that they did intend it to be the insurance commissioner. So anyway, thank you for the opportunity to testify, and I'm happy to take any questions.
Any questions from the committee? Seeing none.
Thank you.
Sabrina. Chris Kennedy?
Do we get that part? Volume's not usually a problem for me. Well, and I will be exceedingly brief. I understand, being a former staffer in this institution, what a forewarning of the number of speakers at this hour of the day means. So I just want to reiterate 2 points that were made and really kind of hammer those home. One, with the first aspect of the bill, deferring clinical criteria and the development of clinical criteria to the regulator and to codifying that criterion statute really makes that process less nimble, less responsive to constant changes in best practices and further clinical trends. I think it's really important that that process resides with the carrier so it can have that nimbleness and be resigned to best practice with what we're seeing with our members and really clinical trends, clinical standards rather.
I will note that we use Interqual at Centene. It's a well-established national standard for medical necessity criteria for inpatient psych stays. And, I have to imagine in a world where, the process for developing that criteria was left to a regulator or rules making, they would borrow heavily off of Interqual and other like processes. With the second part of the bill with respect to prohibiting carriers to engage in utilization review for a period of 30 days, I would just echo what I think my counterpart at Anthem said, that, frankly, one of the things I spend the most time working with providers on is the other side of the equation, which is step-down care. Part of the reason we have such a challenge, I think, with the front side capacity is that we're unable to timely and responsibly and appropriately step down members into a next step appropriate level of care, whether it be a skilled nursing facility, nursing home, long-term care facility, what have you. If you prohibit carriers from engaging in utilization review for the first 30 days, you're essentially taking us out of the equation. We don't have lenses into the state of care and condition of the member, and we can't work with the provider institutions to really triage that member to that next level of care. Again, at the risk of being redundant, well, I think I'll leave it there. Again, I would defer to the insurance department with respect to what Michelle offered pertaining to the level of expertise over there. Again, certainly national standards exist like Interqual, like MCG, MGC, one of the ones that Sabrina referenced, that are developed in consultation with providers, with clinicians, with carriers, that really take into account best practices and standards. I think maintaining that protocol and that nimbleness is critical.
Thank you, Chris. Any questions from the committee? Seeing none?
I've seen that look on the Senate President's face before. I'll take my leave.
Jeffrey Fetter. After Dr. Fetter, we have two more speakers, Peter Bragdon and then Heidi Cole. So.
Thank you, Madam Chairman and members of the committee. I'm Jeffrey Fetter, a psychiatrist who's worked in community mental health, emergency room, and inpatient psychiatric settings in New Hampshire for over 20 years. I'm here representing Dartmouth Health, my employer, not DHHS, though I am a chief medical officer at New Hampshire Hospital. I would like to outline some points in favor of this bill. As previous speakers have mentioned, this has been implemented in other states, including New York. I am going to submit to the committee a cost analysis done by New York, which did implement this language, this exact language in their statutes. And this cost analysis was done by the New York Department of Mental Health. What they found was a very minimal projected increase in patient bed days, but a substantial decrease in utilization review days, almost half there, and 2 to 4% change in patient days. Critically, right now, New Hampshire's mental health system is under a court order to end emergency room boarding of psychiatric patients. So any decrease in the strain on the emergency health system is very timely and would be very helpful to that effort. Utilization review consumes both mental health workforce into the insurance company's employment, as well as diverting clinical staff from tasks that add value to patient care. As a community mental health center medical director, one of the things that killed me was when we would not be able to compete with insurance companies for salaries for social workers, so that we were moving the actual workforce out of the workforce into a spot where they are creating red tape for the workforce. That is not the way you would organize this. Psychiatric hospital beds tend to be among the least profitable parts of a hospital operation. So decreasing the chance of denied days and administration burden helps preserve this resource as hospitals look for places to cut costs. Those of you who've been in this field for some period of time know how many psychiatric hospital units we've lost over the last 15 years. We can't afford to lose anymore. Earlier it was mentioned that this would have to go through JL CAR. That's a feature, not a bug. because the transparency of this process means that stakeholders like patients, like NAMI New Hampshire, will be sitting at the table when they decide what the criteria are. There's no such representation in the boardroom of an insurance company that currently decides how to decide when a patient is stable, despite their psychiatrist saying that they're not. One of the earlier speakers mentioned that these concurrent reviews help make the treatment teams aware of resources in the community. This is not New York. This is not California. This is New Hampshire. I know the community mental health center medical directors, all 10 of them. And our discharge managers know the resources in New Hampshire, that whenever they've swooped in for the insurance companies to try to help us, it's always been extraneous. I've had utilization reviews, hours of utilization reviews, and they've never denied me a single day. It was all for nothing. Time I could have spent with my patients. Finally, this is a parity issue in a broad sense. A patient with a heart attack does not have to get insurance permission to be admitted to the hospital. If we believe that mental health care is health care, it needs to be treated as medically necessary. That's parity. Thank you. I'm happy to take any questions.
Thank you, Doctor. Any questions from the committee? Seeing none. Thank you.
Thank you.
Peter? Welcome.
Thank you, Madam Chair, members of the committee. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's only not-for-profit health insurance provider in the commercial and individual markets. Here in opposition to this bill, I think pretty much what you've heard before, the basics are there. We first of all, don't feel the Department of Insurance has the expertise and the resources to develop these kind of clinical requirements. Yes.
You could wait till Cam's ready. Sorry.
Sorry, Cameron. The resources at the Department of Insurance for these medical criteria do not exist. And these are not a one and done type of things. They undergo constant review. And as the prior speaker alluded to, made it sound like, the board of directors of Harvard Pilgrim Healthcare decides what the medical review criteria are. We have medical professionals deciding what these review criteria are who undergo this on a regular basis. The Department of Insurance does not have those resources. In addition, anecdotally at least, then the prior speaker talked about New York where they didn't see an increase. I think anecdotally we're hearing that in states and areas that have put in a limit on the number of days before you have utilization review, then the length of stay basically ends up approaching that number. And so when you have a situation where there's a shortage of ER beds, then certainly having the risk of people being in there for up to this max, that's allowed by law. It's going to exacerbate that problem and unintended consequences. And then just finally, the fiscal note on the bill, or at least the original fiscal note, Department states there'll be increase in insurance premiums that's indeterminable, but, quote, potentially significant. So again, need to balance the ability of the people to pay the insurance premiums with what's happening. And I think the whole managed care concept, it creates that tension between providers and carriers with utilization review and things like that, but that's there for a reason. We do think this bill would have some unintended consequences. To the extent there are inefficiencies and the way things are done differently by different companies, I'm sure we'd be open to any conversations about that and how to make that better. But I think getting rid of utilization review is going to cause a number of other problems. Thank you.
Thank you. Any questions? Seeing none. Thank you. Thank you. Heidi. And right now, Heidi is the last speaker.
Good afternoon, Madam Chair and members of the committee. I realize I'm standing between you and getting to leave from a long day, so I will try to be brief. My name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm here today representing AHIP, which is America's Health Insurance Plans. We are the trade association for the health insurance carriers here in New Hampshire. AHIP is strongly opposed to SB 457. As you've heard, this bill seeks to prohibit all forms of utilization review during the first 30 days of an inpatient or residential behavioral health admission. Utilization management is a set of policies for evaluating the medical necessity of medical treatments and services and the healthcare setting in which those are taking place on a case-by-case basis. Utilization review can include prior authorization, concurrent review, and retrospective review. We are very concerned about the negative impacts that this bill would have in 3 areas: access to inpatient psychiatric services in New Hampshire, the efficient use of the state's limited resources, and the quality of care, namely getting patients the right care in the right setting. As you know, and you've heard others comment today, we have a shortage of inpatient beds and a shortage of providers to staff those beds. This bill, in our opinion, would only make that situation worse. By prohibiting all utilization review during the first 30 days of an inpatient or residential behavioral health admission, people will be occupying beds for longer periods of time than necessary and using scarce provider resources, when it would be more appropriate for them to be receiving quality care in a less intensive and less costly setting and freeing up the inpatient beds for people who truly need them. As Mr. Bragdon mentioned, I also wanted to call your attention to the bill's fiscal note, which does state that the department states that the extent that the increase is indeterminable, but describes it as potentially significant. And we agree with that assessment. We believe that the bill would not only further strain our inpatient and residential care resources, but it would also put upward pressure on insurance premiums that are paid by hardworking New Hampshire citizens and employers. I also did want to mention that this law would only target carriers that are offering fully insured products. That market share in the employer realm is around 20 to 21%. In the individual market, it's around 5.5%. 34% of the market is in the commercial space, but the self-funded plans. I would also like to say in closing that prior auth and utilization management play a very important role in managed care in the commercial health insurance markets. They provide important patient care protection. They identify overuse, misuse, and safety issues for the patient before a provider delivers the care. It improves quality of care, holding providers accountable to providing care that is consistent with and supported by medical evidence. And it triggers additional coordination of care services for the patient. It also provides financial protection, especially in a healthcare system that remains dominated by a fee-for-service model. I was also going to point out, as Mr. Bragdon did, that carriers do have independent panels of providers that are developing the guidelines. And also wanted to mention that SB 85, which we passed last year, does not have any prior authorization on emergency mental health services. So the analogy that he gave is that with a person going in with a heart attack, similarly, if somebody's going in on an emergency basis for a mental health scenario, that there would be no prior auth there either. So with that, I'd be happy to try to answer any questions, and I appreciate your time this afternoon.
Questions? I only have one. You had mentioned the 34% of the insurance, 34% are commercial and they're self-funded. This would not impact them, correct?
That is correct.
Okay, yes. Thank you.
Thank you.
Is there anyone here, I hate to ask this question, is there anyone here that would like to speak on 457 but hasn't been given the opportunity? With that, I'll close the hearing on 457, and thank you for your patience.